The mechanism of injury is due to the fall on outstretched hand and during a sports activities like football, basketball, cycling, and skateboarding. Its blood supply is from the dorsal branch of the radial artery, which supplies about 70 to 80%, and the volar branch, it supplies the remaining 20 to 30%. Herbert screw, it is a double-threaded titanium alloy screw. It is 2.5 mm in diameter and ranges from 12 to 32 mm in length. The pitch and the diameter of the distal thread is greater than the proximal thread, allowing for the compressions across the fracture. There is no need to remove the screw because of the recessed, as it is recessed beneath the articular surface. The screw was devised to provide secure fracture fixation and allow the early mobilization of the wrist. The distal threads are self-tapping, and the discrepancy in the pitch between the two threads allow for the further compression of the fracture side. Classification, there are different types of classifications like Rusi classification, Mayo, and Evo classification. For fracture fixation, we use most commonly the Herbert and Fisher type of classification. Type A, they are stable. Type A1, tubercle fracture. Type A2, unicortical waist. Type D, these are unstable acute fracture. B1, it is distal oblique. B2, it is complete waist. B3, it is proximal po. B4, it is transcaphoid, and B5, it is comminuted. The aim, it is evaluate the functional outcome of scaphoid fracture using the open reduction and internal fixation with Herbert cannulated screw. Materials and method, it is a prospective study, sample size of 13, which is performed at Carteret Medical College between the time period of December 2022, December 2021, with 8 patients and previously operated 5 patients who came for follow-up. The inclusion criteria, it is 20 to 50-year-old and Herbert type B1, B2, B3, B4, and B5. And delayed union and non-union of scaphoid fracture. Exclusion criteria, scaphoid tubercle fracture, non-displaced scaphoid fracture, and pediatric scaphoid fracture. Surgical technique under regional Brock and tourniquet control, patient in supine position with affected side on the radiolucent table. Here the surgical parts are cleaned and draped, and the wrist extended over a roll, a 4 mm jockeystick incision across the distal wrist crease, angulates towards the base of the thumb, open the sheet of the flexor carpi radialis and retract the tendon radially and the radial artery radially. The wrist capsule is isolated and divided in line with the scaphoid, starting at the distal pole and ending as soon as the fracture is visualized, preserving as much of the radioscaphoid capitate ligament. Remove a portion of trapezium with a rongeur to allow the placement of a guide wire and from distal to proximal for a better place the wire in the center position. The tip of the guide wire is inserted through the scaphoid tubercle at 45 degrees angle in both planes, passed up to the tip of.
Go to conclusion. See, you wasted 3 minutes of your time with your introduction. You're still in surgical methods. You didn't go on to methodology. Go on to your conclusion.
Sir, results.
Yeah, tell results and go to conclusion. See, for all of you here, is there a timer on the top of your screen?
Yes, sir.
Please follow the timer. Okay, everybody, there's a small timer which is visible on the top of your screen. If you think that you're running out of time, please follow that and skip on. Don't waste your time with introduction and all. What we need is the methodology, results and your conclusion. That's the main part, and discussion. See, marks are also allotted based on that only. For introduction, there are no marks here. Okay. With anatomy and all, waste of time.
Here, all the fractures were fixed with 16 to 22 mm Herbert screws using volar approach. Most cases achieved better outcome and good union after screw fixation with pain and free wrist range of movements. 10 male and 1 female patient showed good union. Only 2 cases showed delayed union, that is 1 female and 1 male. Young and active male with no comorbidities achieved good union with 90% of a normal wrist range of movement without any pain after 6 months of follow-up. We found no evidence of significant avian changes and osteoarthritic changes in scaphotrapezial joint after the use of volar approach for internal fixation in comparison with conventionally used dorsal approach. Limitation, this is not a comparative study between the other methods of the treatment. So similar study with non-operative control group or a comparative study with another operative technique would be ideal. A long-term follow-up is necessary to find out its a long-term functional outcome and complications like avascular necrosis of proximal fragment, osteoarthritis, or carpal instability. The conclusion, our study has shown the internal fixation using the Herbert screw results in rapid symptomatic relief and functional recovery. Review of these cases show that the screw provides sufficient stability to allow normal use of the wrist. Functional recovery is much quicker after internal fixation, and most of the patient can return to the work within a few weeks. Orientation of the screw and length of the screw plays a major role in preventing the late complications like arthritis and wrist pain.
Okay, how did you select your patients into surgical and non-surgical modalities?
Yes, sir.
What was the basis of your selection?
So, acute trauma, scaphoid fractures, waist fractures, displaced fractures based on radiological and symptomatic.
Well, there is some classification for the scaphoid, no?
Yes, sir.
What classification did you undertake it, and
Herbert and Fishers, sir.
which
Type B.
which type did you take into surgery?
Type B, sir.
Type B. Okay. I have 10 marks for your statistical methods, and I don't know what statistics you have done.
It is based on modified Coonley's Green and Oprin scoring system, sir.
No. How did you analyze it? You analyzed it with what scores?
There are 4 components in the scoring system which I have taken, sir.
Okay.
Pain, grip strength.
All the scoring you have taken.
Yes, sir.
So to achieve your conclusion,
Yes, sir.
to achieve at your p-value which is less than 0.05, what method did you use? Did you use Fisher's exact t-test, Student's t-test, ANOVA? What test did you use to arrive at your p-value? Student t-test is for comparative study. You didn't compare at all. Okay, thank you. Next presenter, Dinesh, a comparative study between surgical decompression and steroid injection in treatment of decurrence tenosynovitis.
Good morning, everyone. I am Dr. M. Dinesh, presenting you a comparative study between surgical decompression and steroid injection in treatment of decurrence tenosynovitis. Introduction. Decurrence tenosynovitis is one of the most common forms of stenosing tenosynovitis encountered by hand surgeons. This tenosynovitis was first described by de Courvin. Decurrence tenosynovitis causes radial wrist pain that increases with activity. Steroid injection into the tendon sheath is a standard method as a primary treatment in uncomplicated case. Although steroid injection is common, complications such as subcutaneous atrophy, fat necrosis, weakening, or rupture of tendons and depigmentation have been reported after this treatment regimen. A surgical release that provides a precise and permanent solution in most cases is considered for steroid refractory patients and for patients whose complaints last over 6 months. Since the rate of recurrence and complication is lower after surgical treatment, currently it has been widely used. Aims and objectives. To evaluate the efficacy of open surgery versus steroid injection in patients with decurrence tenosynovitis. To study the morbidity and associated complications in both the procedures. Materials and methods. Between November 2020 and November 2021, it were a total of 40 patients. Of them, 28 are females and 12 are males. And mean age was 40.3 years. And ranging between 20 to 71 years who were admitted were included retrospectively. The patients were assigned into 2 groups, including group 1 undergoing open surgery and group 2 receiving steroid injections. The rates of recurrence and satisfaction were evaluated. The patients undergoing surgery were also evaluated for the wound site infection, nerve injury, wound opening, and limited range of motion of the joints. The patients receiving steroid injections were evaluated for subcutaneous atrophy, fat necrosis, weakening, or rupture of tendons, and depigmentation. These are figures. First, figure 1 showing surgical decompression of decurrence tenosynovitis and extensor tendons of thumb, abductor pollicis longus, and extensor pollicis brevis are being excised. 10 on sheath of them are being excised, and the figure 2 showing steroid injection being given into radial aspect of wrist. Results: the mean age of the patients was 40.3 years. Mean follow-up was 12 months. In steroid injection group, recurrence was seen in 4 patients. Also, extensor brevis entrapment test was positive in 8 patients with recurrence following steroid injection. All of the patients who underwent surgery indicated that they were satisfied or very satisfied with the surgical treatment. 5 patients were dissatisfied or very dissatisfied after steroid injection. 1 of them were dissatisfied due to severe pain after injection, and 4 of them were very dissatisfied due to recurrence. This is demographic data showing mean age and open surgery. In open surgery, 18 of them took open surgery, and 22 people were given steroid injection. And we can see it's more common on dominant side, dominant hand. And this is patient satisfaction table where 90% of the patients who received open surgery are satisfied, and only 25% of steroid injection group were satisfied, very satisfied. It is more common in females, although some reports have shown it's commonly involved in dominant hand. Relationship with disease has not been fully clarified. The decurvent stenocytosis diagnosis is made radiologically, and ultrasound and MRI can also be performed to identify anatomic variations. Complications such as wound infection, nerve injury, wound opening, and limitation of range of motion of joint can also be seen following open surgery. Volar subluxation of tendon as rare complication has also been reported in literature. In our study, complete excision of retinaculum was performed and no volar tendon subluxation was observed. In conclusion, our study results suggest that although steroid injection is a treatment option for decurvent stenosynovitis, open surgery seems to be a more useful method with relatively low recurrence and complication rates. These are my references. Thank you.
Why do you think that open surgery might be more likely to be useful in such cases? Is there a kind of bias in your study, or what might be one of the limitations with your study between open surgery and your decurvence injection? I agree that your study has better results for surgical treatment, but what might be one of the limitations?
Maybe surgical fitness is an option where patients are not fit for open surgery.
No. Is there a chance for bias in your study between open surgery and your injection? What is the limitation with injection? The method which you are using, are you using any ultrasound guidance, or what was the method which you use for injection?
Sir, ultrasound guided injection.
Ultrasound guided. In the picture you showed that it's a normal blind procedure. Okay, so correlate your findings. When you're showing it just blind injection, don't put that photo. If you're using ultrasound, you didn't mention it anywhere, no? It's ultrasound guided injection. So it should.
In few patients, we did the ultrasound guided. Yes, sir, I have.
See, in few patients, if you do ultrasound guided, in few patients, if you do normal, then it will be all biased. Study will be biased. One of the main problems with injecting decurvence is you have to find the tendon correctly and inject it correctly. So that can be correctly done with ultrasound. If your study that you have to mention that it's a limitation. In our study, we injected it blindly. So in blind technique, you don't know that it went into the tendon sheath. So that is one of the limitations of your study. You have to mention it in your limitations if somebody asks you. Okay, thank you.
Thank you.
Good morning, everyone. I am Maniraj, orthopedic from GSL. My topic of presentation is a short-term functional outcome of unipolar and bipolar hemiarthroplasty in intracapsular neck of femur fracture, a comparative study. Introduction. Intracapsular neck of femur fracture account for major share of fractures in elderly. Our primary goal is to return the patient to pre-fracture functional status. Hemiarthroplasty is an operation to restore motion and stability to joint. Unipolar and bipolar processes are available. Complications, sir. Persistent pain with unipolar hemiarthroplasty have led to choose bipolar system. Advantages of unipolar process include lower cost and no risk of polyethylene wear debris. And proposed advantages of bipolar process include less vestibular wear and potentially less hip pain or groin pain. In view of these varied opinions, we desire to compare the efficiency of these two unipolar and bipolar processes for management of intracapsular neck of femur fracture in elderly people. In our center, both cemented and uncemented unipolar and bipolar hemiarthroplasties were done, and we have decided to evaluate short-term functional outcome of unipolar and bipolar hemiarthroplasty with a mean follow-up of 32 months and 31 and a half months respectively. Aim of the study to evaluate short-term functional outcome of unipolar and bipolar hemiarthroplasty in intracapsular neck of femur fracture. And materials and methods. It's a retrospective study. For duration is 18 months, and 2 groups were included. First group is unipolar hemiarthroplasty, and second group is bipolar hemiarthroplasty. Sampling. Each group contains 20 samples, including criteria and exclusion criteria. Displaced fractures, male and female patients of more than 60 years and neglected cases, non-union cases are included. And exclusion criteria are in younger patients and extracapsular neck of femur fracture with with any neurological disorders. Pre-operative evaluation. All patients were pre-operatively evaluated using Harris hip score, and investigations were done and radiological assessment were done. Surgical procedure, we use a posterior approach. Spinal anesthesia was employed. Patient is positioned laterally. In our study, we have done all cases in posterior approach. Hip joint capsule is excised with a T-shaped fashion. We achieved dislocation by internal rotation flexion adduction and removed head of femoral head with a fractured neck. Implantation of cemented and uncemented unipolar or bipolar was done. We proceeded with repair of posterior soft tissue and capsule. Short external rotations are reattached. These are the results. Pre-op and post-op, comparison of pre-op and post-op Harris hip score of unipolar and bipolar hemiarthroplasty. The main post-op Harris hip score in unipolar is 81.8 and bipolar is 85.05. These are the graphical representation of unipolar hemiarthroplasty pre-operative and post-operative. The average post-op Harris hip score is 81.8, and this is the graph showing pre-op and post-op Harris hip score of bipolar hemiarthroplasty. The average post-op Harris hip score is 85.05. Discussion: hemiarthroplasty is an effective technique and could help in early ambulation and satisfied functional recovery. The study suggests that bipolar hemiarthroplasty have better improvement in hip functionality, hip pain, and the quality of life compared with unipolar hemiarthroplasty, while with higher cost. There are no significant differences between bipolar unipolar hemiarthroplasty with regard to operation time, blood loss, blood transfusion, hospital stay, or mortality, or reoperational dislocation. Conclusion: Harris hip score is excellent scoring system for assessing the functional outcome. We have 15% excellent results in unipolar hemiarthroplasty and 35% excellent results in bipolar hemiarthroplasty respectively. We have 60% good results in unipolar hemiarthroplasty and 45% in bipolar hemiarthroplasty, and we have 15% fair results in both. The result of our study showed that uncemented bipolar hemiarthroplasty gave better results when compared with uncemented unipolar hemiarthroplasty, and cemented bipolar hemiarthroplasty gave better results when compared with cemented unipolar hemiarthroplasty. Bipolar hemiarthroplasty done for intracapsular neck of fracture gave better results. These are the references. Thank you.
I have a comment regarding your first slide of conclusion. Can you switch back to your first slide of conclusion? So you're concluding that Harris hip score is an excellent scoring system for assessing functional outcome on unipolar and bipolar hemiarthroplasty.
Yes.
See, that is not your conclusion. Are you doing your study on Harris hip score?
No, sir.
No study చేసేది Harris hip score మీద కాదు కదా. So first line అది పెట్టడం it's not good.
Oh.
You can tell that we have used Harris hip score for evaluating such so and so. Now you are telling that Harris hip score అనేది నువ్వు conclude చేసావు. You have done your study on Harris. It seems like you have done your study on Harris hip score. Your studies on bipolar and unipolar, no? You shouldn't put that as your first line.
Okay.
How you sutured external rotator's capsule to the GT?
What are the short external rotators?
Gluteus minus, gluteus minus.
Okay, it's okay. Anatomy question. Okay, sir. Thank you. Next, Mohammad Rafiq A. He'll be presenting on evaluation of radiological and functional outcome of both bone fractures forearm in children aged 5 to 16 years, managed with TENS.
So, good morning to all delegates. Today my presentation is on evaluation of radiological and functional outcome of fractures of both bone forearm in children aged 5 to 16 years, managed with titanium elastic nailing system. Introduction: forearm fractures comprise 40% of pediatric fractures. Majority of these fractures are usually treated by close reduction and above elbow POP casting. Failure occurs due to loosening of cast and movement at the fracture site, which results in angular, rotational, or axial malleolus of the fracture. Titanium nails are used due to its inherent elastic property. TENS are used due to as it's cost effective and is a simple technique. Needs minimal soft tissue dissection. It's a choice of stabilization of forearm fractures in skeletal immature patients. TENS allows micromotion at the fracture site, result in rapid fracture healing. Purpose of the study: of functional and radiological outcome analysis of diaphyseal fractures of both bone forearm in children aged 5 to 16 years, managed with titanium elastic nailing system. Material methods: study is prospective, place Shantra Medical College and General Hospital, Nandyala. Study period from October 2020 to December 2021. Sample size 16 children. Follow for 4 months. Criteria used: price detail criteria. Inclusion and exclusion criteria. In inclusion criteria, both bone fractures of the forearm in children from 5 to 16 years. Complete diaphyseal fractures of both bones of forearm. Open fractures, segmental fractures, grossly displaced fractures. Exclusion criteria: pathological fractures aged more than 16 years, less than 5 years. Single bone fracture and incomplete fractures. Observation results: number of patients in total 16 patients. In 5 to 8 years and 9 to 12 years, we are having 6 members each. Sex distribution: majority of cases were males. Type of fracture: majority of cases for closed fractures, and open fracture we got only one fracture, one case. Fracture distribution based on the level of the fracture in forearm: it is observed that around 75% of fractures were in middle third of forearm. Post-operative complications: the most common complications were skin irritation and inside infection, which contributed to about 12.5%. Functional outcome: the functional outcome was graded according to Price et al. Criteria. According to this criteria, excellent results were achieved. Radiological outcome: in this study, bony union was achieved in range being 6 to 14 weeks, and maximum cases were between the 6 to 18 weeks. And coming to discussion part: diaphyseal forearm fractures in children is common injury. The most common indication for internal fixation of diaphyseal forearm fractures, that is angulation malrotation more than 45 degrees in a children less than 9 years of age, and more than 30 degrees in a child more than 9 years of age. All 16 patients were fixed with TENS in each of radius and ulna. All diaphyseal fractures of radius and ulna are either proximal third, middle third, or distal third. 2 patients sustained fracture of proximal third, 2 patients sustained fracture in the distal third, 14 patients sustained fracture in the middle third. The fracture pattern was oblique transfer or segmental. The average time taken for bone union was 8.62 weeks. Younger patients had early union. The hospital stay was 3 days for closed fracture and 5 days for open fractures. Thicker periosteum in younger age group member promotes early external callus. Till the end of the follow-up, none of them had refractures. Average time for implant removal was 24 weeks after fixation. Conclusion: the advantage of TENS over rigid intramedullary devices are: provides dynamic 3-point cortical contact, accurate and stabilization of fractures, lesser chances of facial injury, helps to re-establish the radial bow, maintain the interosseous space, early mobilization prevents joint stiffness, preserves forearm function, minimal soft tissue dissection even after. In conclusion, potentially unstable and grossly displaced fractures of forearm shaft in children should be approached surgically and treated with the titanium elastic nails, as patient compliance and functional results were found to be good. Thank you.
In your study, What was the post-op protocol after surgical fixation? Was there any period of immobilization?
Yes, sir. First, for 2 weeks, we immobilized the patient with above POP casting, sir. And then after 2 weeks, we mobilized the patient, mobilized the arms.
With a cast, directly with a cast or?
After removing the cast.
Okay, you put a cast directly.
Yes, for 2 weeks we have.
Post-surgery.
Yes, sir. To immobilize, sir.
Cast or slab, are you sure? Cast?
Slab.
Slab. Immediately after post-op?
Immediately after
No,
post-op,
no
for
cast.
2 weeks, we have room slabs. And after that we have.
Why you shouldn't put a cast immediately after post-op?
Because there will be swelling which may lead to compartment.
Okay.
Thank you, sir.
Next presenter, Pavani Kumari. Evaluation of TBW usage in various fractures. Next presenter, Muhammad Ali, also be ready. After that, we have Mohan Chakri Gaura and P. Krishna Sandeep. These 3 presenters next be ready.
Good morning, sir. Evaluation of results of tension band wiring usage in various fractures. Introduction. Fractures of eccentrically loaded bones like patella, olecranon, and medial malleolus pose vexing problem to orthopedic surgeons. As these are subjected to continuous deforming forces from muscles, it is difficult to restore the desired anatomical continuity and congruity of articular surfaces after reduction, leading to complications like arthritis, stiffness of joints, non-union, etc. The advantage of tension band wiring is that it gives rigid fixation with early mobilization of joint. Aims and objectives to study the functional outcome of early mobilization in tension band wiring technique, to assess joint motion and stability following fixation with TBW, and to study complications of tension band wiring. Materials and methods. It's a prospective study done in 45 patients at Alluri Sitaramaraj Academy of Medical Sciences from period of February 2021 to January 2022. Informed consent taken from all the patients. Thorough physical examination and basic investigations done. Fractures of olecranon, patella, and medial malleolus treated according to standard protocols. Inclusion criteria. Age greater than 18 years. Fractures of patella, which are simple transverse fractures. Olecranon, which have less than 2 or 3 fragments, and medial malleolus transverse fractures. Active patients with previous normal range of movements at the respective joints. Exclusion criteria are comminuted fractures, absence of active joint movement, superior and inferior pole fractures, vertical fractures of patella, severe osteopenia, injuries more than 10 days, history of previous joint surgery, grade 2 and 3 open fractures, pediatric fractures, and fractures with pregnant women. Electron fractures. This fracture pattern was assessed using the Mayo classification, which takes into account the degree of fracture displacement and comminution as well as the stability of elbow joint. The patient is placed in a lateral decubitus position. A posterior midline skin incision is used. The ulnar nerve was identified on palpation. Fracture osteosynthesis was achieved with insertion of 2 parallel 1.8 mm K-wires from the tip of the olecranon and 18-gauge wire in a figure of 8 fashion. Major intraoperative goal was the perforation of the ulnar anterior cortex. The circulation wire was placed through a pre-drilled transverse hole in the distal fragment and under the triceps tendon and tightened to create interfragmentary compression with less than 2 mm intra-articular gap or displacement. Medial malleolus fractures. Patient in supine position. The fracture was internally fixed with 2 mm smooth K-wires drilled perpendicular to the fracture line. The ends were bent at 90 degrees. A stainless steel 1.2 mm K-wire was passed through the previously drilled hole around the bent ends of K-wires in a figure of 8 configuration. The wire was then tightened. We made that the K-wires had not crossed the articular surfaces. Patella fractures. Patient was placed in supine position and approach is via midline longitudinal incision. Entire patella is exposed and integrity of the fragments is evaluated. Fracture with small amount of comminution are first converted to a simple transverse fracture. 2 mm smooth K-wires inserted from an inferior to superior direction slightly anterior to the midpoint. The K-wires are inserted slightly anterior in the patella for tension band to function properly. Articular congruity is checked. 18-gauge wire is then passed across the antisurface of patella. Immediate range of motion was started post-operatively, subject to patient tolerance. Clinical and functional outcome measured using standard protocols like Mayo elbow scoring system, OMAS ankle scoring system, Lisholm knee scoring scale. Results are: average duration of hospital stay was 3 days. Complications include deep infection in 2 patients treated with antibiotics, implant backward in 2 patients. and complaint of implant irritation in 3 patients. Average time for union was 10 weeks. At 6 months average, Mayo score for elbow was 90, Uma score was 85, Lissol mean score was 85. Clinical evaluation, Mayo elbow performance score, Ullerid Molander ankle score, Lissol knee score. It's a pre and post-op radiographs of Electron fracture treated with GPW. Pre-op and post-op radiographs of ankle fracture, medial malleolus fracture, and patella fractures. Discussion TBW technique.
Conclusion, time up, conclusion.
It's relied on principle of converting tensile forces to articular compressive forces.
Conclusion.
Tension band wearing is technically advantageous for small fragment fixation of eccentrically loaded bones. It allows for early mobilization while providing rigid fixation. Hence, it prevents stiffness while providing stability.
What is the principle behind the tension band wiring?
So, tensile forces are converted into compressive forces.
Okay. We are running short of time, please. Thank you. Anybody presenting within 3 minutes will have no questions or less questions. Presenting within 3 minutes will have no questions or less questions.
Today, my presentation is on clinical outcome of triceps reflecting approach in the management of distal 2/3 shaft of humerus fractures. Introduction of fracture of shaft humerus accounts for nearly 3% of all fractures. Unlike fractures of other bones, there is no overriding. On the contrary, there is incidence of delayed or non-union as the weight of the limb acts as a distracting force, and there is a danger of interposition of soft tissue. Open reduction and interfixation with the dynamic compression plate gives the following advantages. This is a method of achieving a stable fixation with almost perfect anatomical reduction with the plates placed on tensile side, that is on the posterior aspect of the humerus. As there is no need for CM, the medical staff has no radiation, can avoid post-operative shoulder morbidity after posterior plating, which is common in interlocking nailing of humerus. Material methods, this prospective study is conducted to evaluate the outcome of posterior plating of humerus by triceps reflecting approach done at Siddhartha Medical College, Government General Hospital, Vijayawada. Inclusion criteria, adults above the age of 18 years and fresh fractures. Exclusion criteria, pathological fractures, malunited fractures, compound fractures, infected fractures, and those below 18 years of age. These instruments used for surgery. Procedure, incision starting at the olecranon tip. The incision runs proximally along the arm's posterior midline in a straight line and crosses the radial nerve in the midhumeral region and axillary nerve proximally. Then identify and mobilize the ulnar nerve. Next, mobilize the triceps muscle and retract it laterally. Split the triceps fascia and mobilize the lateral head of triceps from the lateral intermuscular septum and humerus towards ulnar side. This ends in a liberated muscle complex containing the long head, lateral and medial head. This permits the whole triceps muscle to be moved either laterally or medially to provide access to humerus known as triceps flip. These are the pre-operative and post-operative radiographs and post-operative follow-up. These are the results based on the age group, incidence, and mode of injury, level of injury, and the type of fracture, and the blood loss during surgery, and the post-operative pain at 4 days, and time taken for fracture union, and range of elbow flexion, and according to the American Shoulder Elbow Surgeon Score and Stewart and Huntley's criteria. Discussion, extra-articular distal humerus fractures can be exposed by triceps reflecting approach, which avoids direct injury to the triceps and uses bloodless plane, and this is the primary reason for improved elbow range of motion and less post-operative pain and elbow contracture. Next, in 2014, Emmanuel did a study on retrospective comparison of triceps sparing approach to the split approach and demonstrated a significant motion-related outcome benefits with the triceps sparing approach. In our study, there was no incidence of post-operative radial nerve palsy in any of the patients. At a mean follow-up of 24 months, 27 out of 30 patients in whom triceps reflecting approach was used was demonstrated greater elbow motion and strength. In a triceps reflecting approach described by Gavin. Conclusion, the triceps reflecting approach has a better functional outcome in terms of less intraoperative blood loss, less operative time, and less immediate post-operative pain, lesser interference with the biology of the bone, earlier union rates and early post-operative range of movements at elbow, and better functional outcome according to the American Shoulder Elbow Surgeon Score and Stewart's and Handley criteria.
Okay, wait near the conclusion. Okay. better comparative study anedi, you shouldn't be using the term better because you're not it is not a comparative study. You have compared it, you have used it in your discussion, but it's yours is not a comparative study. So you shouldn't be using better because you're not comparing it to something. You should just use good. My study has a good functional outcome. If you feel that your study is good, you're not comparing, you shouldn't be using the term better. Okay, thank you.
Thank you, sir.
Mohan Chakri Gavra. Functional outcome of patients was better when diaphyseal fractures of long bone in children treated with TENS. What's your topic?
Diaphyseal fractures of long bones in children.
Treated with TENS. Okay.
Good morning, everyone. This is Dr. Mohan Chakri, and today I am presenting a study of diaphyseal fractures of long bones in children treated with titanium elastic nailing system. And there is an increased interest in operative treatment of pediatric fractures and little disagreement concerning the treatment of long bone fractures in children less than 6 years and others than older than 16 years. Controversy persists regarding the age between 6 to 16 years. And titanium elastic nail fixation was originally meant as an ideal treatment method for femoral fractures, later gradually applied to other long bone fractures in children. And coming to aims and objectives, the main aim is to study the diaphyseal fractures of long bones in children treated with titanium elastic nailing system and to evaluate the results of operative treatment outcome, safety and efficacy of titanium elastic nailing system for the treatment of diaphyseal fractures. And patients and methods setting is done in Maharaj Institute of Medical Sciences, and population was taken from the college. And sample size will be 20. Type of study is prospective interventional case study. And duration of study is 12 months, November 2022, October 21. And it includes inclusion criteria like 5 to 16 years of age, diaphyseal fractures, simple fractures, ipsilateral fractures, fractures with head injury. And exclusion criteria includes metaphyseal fractures, compound fractures, pathological fractures. And after surgery, each child was followed up for 6 months post-oply. After 3 weeks, the range of motion exercise was started. Partial weight bearing after visible callus seen. With radiological evidence of union, full weight bearing was started after 6 to 8 weeks. In case of upper limb fractures, slab support is withdrawn and mobilization exercise started as there is evidence of callus. Follow-up was carried out at 6 weeks, 12 weeks, and 24 weeks. And later on, radiographs were presented. And statistical analysis were shown. Observation and results. An outcome surgical study of 20 patients with diaphyseal fractures of long bones is undertaken to study the outcome of titanium elastic system. And these are my X-rays and the pre-op and the post-op X-rays. And the patient was advised for cross-legged sitting, squatting, flexion, and extension positions. And this is another patient. These are the 3 cases. And coming to the present discussion, like age incidence, it is around 10 years average, and it is more common in males. And mode of injury is fall due to stumbling is more common. And pattern of injury, transverse fractures are more common than the comminuted. And time interval was taken during 3.5 days. And average duration of surgery was around 1 hour. And average duration of immobilization is for the 6.5 weeks. And duration of hospital stay is 11 days in approximately. Time for union is around 11 weeks. Complications, pain at site of nail insertion, infection, range of motion. Conclusion. Based on our study, we conclude that titanium elastic nailing system, an elastic stable intramedullary nailing technique, is an ideal modality of management of pediatric diaphyseal fractures of long bones, especially in the rural setup. It gives elastic mobility, providing stability and aiding in rapid union at the fracture site. This technique has lower complications, good outcome when compared to other methods. And these are my references. Thank you.
Okay, good management of time. What is your criteria for taking the diameter of TENS nail in case of any operative surgery?
Symmetrical bracing.
Symmetrical bracing. Okay. What thickness, what diameter of the nail are you going to take? What size of nail are you going to take?
3 to 3.5 mm.
For everybody, 3 to 3.5 mm, or
mostly in my cases we take 3 to 3.5 mm.
Is there any criteria like that? 3 to 3.5 mm. If 5 years, what was the age group of your children?
6 to 16 years.
6 to 16 years. Okay. For example, if age 6 patient comes to you, if you take 3 mm. If 16 comes to you, you take 3.5 mm. It's not like that. The TENS nail should fill 80% of the canal. Both TENS nails combined. So the diameter should be halved. you have to calculate the width of the marrow. Both should fill 80%. So in the 80%, again, you will have to half and then take your 10 snail size. Okay. Next, Rajshekar Naik is here. Rajshekar Naik. We move on to the next. P. Krishna Sandeep. Valgus osteotomy with DHS fixation and management of malunited intertrochanteric fractures. Good topic. Let's see how he presents.
Good morning. My topic for today is valgus osteotomy with DHS fixation in the management of malunited IT fractures in rural population. IT fractures of the hip are commonly seen in elderly age group. In younger individuals, this results from a high velocity trauma such as fall from height and road traffic accidents. Our hospital is located in a rural area where most of the population belong to low socioeconomic status. Lack of affordability and also traditional belief in native bone setters make them to go for native treatment with crude native splints extending from the groin to the toes. IT fracture is mainly composed of cancellous bone. This results in more causes for malunion. This results in coxa vara associated with shortening limb external rotation deformity with limitation of abduction and internal rotation. The ideal treatment for this will be THA. THA is an expensive procedure and lack of affordability and avoidance of squatting and sitting cross-leg following arthroplasty would not be feasible for the rural population. In such scenario, valgus osteotomy with DHS fixation would be ideally suited. It is an established procedure which has been primarily used in the management of femoral neck fractures, especially in the younger population. Advantages of this procedure will be, it restores the limb length discrepancy, brings back the reduced neck shaft angle, improves the range of movement of hip, facilitating squatting and sitting cross-leg, restores the integrity of the abductor mechanism. It is mainly cost effective. It is a prospective study of 15 patients done between June 2017 to 2019 and followed up for 2 years. Functional results were analyzed during the Harris hip score. Patients willing for procedure and regular follow-up were included in the study, and active hip or systemic infection and who are not willing to follow up were excluded from the study. Initially, physical examination was done and amount of shortening, ROM of the affected hip and preoperative Harris hip score were assessed. X-rays were taken, neck shaft angle was measured and worked up for the surgical procedure. Under spinal anesthesia, patient in supine position on the fracture table via standard lateral approach to the femur exposure was done, and then entry point was made using a 3.2 mm drill bit as shown in the figure 1. A guide wire was passed in the center of the femoral neck and position was confirmed in the AP and lateral as shown in the figure 2. Reaming was then performed with a triple reamer and an appropriate size Richard screw was then applied as shown in the figure 3. Then an oblique osteotomy was then performed using an oscillating saw at the level just distal to the level of the lesser trochanter without taking a wedge of bone in order to minimize the post-operative shortening as shown in the figure 4. External rotation deformity was corrected. A DHS plus was then applied. The limb was taken into abduction and traction was reduced in order to reduce the shaft of the proximal fragment, and the plate was fixed with 4.5 mm cortical screws. Limb was then brought back to the neutral position where the restoration of the limb length as well as the neck shaft angle could be appreciated. Hemostasis was achieved. Limb length measurements, ROM of the hip and the neck shaft angle on the post-operative radiographs were noted. Follow-up was done at 1, 3, 6 months and at yearly interval for up to 2 years. Radiological evaluation were done by taking serial radiographs at follow-up, and functional evaluation was done using the Harris hip score. Data was analyzed using the IBM software, and chi-square test was used in the comparison of the categorical values. Results were the average neck shaft angle preoperatively was 94.73, while it was 134.76 degree in the postoperatively. The average preoperative shortening was 2.66 centimeter, while 3 patients had minimal shortening in the postoperative period of about 0.2 to 0.5 centimeters, which was well tolerated by the patients. The average pre-op Harris hip score was 72.33, while it was 91 in the postoperative. The average time of union of the osteotomy site was 12.7 weeks. Limitation of the abduction and internal rotation preoperatively improved significantly in the postoperative period with a mean flexion of more than 90 degree, abduction up to 40 degree, adduction 25 degree, internal rotation 45 degree, and external rotation 30 degree as shown in the figures. These are the pre and postoperative range of movement for all the 15 patients. Patient demographic and data for the 15 patients. Discussion: a good restoration of the neck shaft angle to a near normal level and good correction of the limb length discrepancy was achieved. All patients had a significant improvement in the range of movement of the affected hip in the post-operative period, and at the end of 3 months, they were able to squat and sit cross-leg comfortably. My conclusion will be valgus osteotomy with DHS fixation is an effective procedure in the management of malunited IT fractures. Mainly, it corrects the limb length discrepancy, restores the decreased neck shaft angle, improves range of movement, and restores the integrity of the abductor mechanism of the hip and gives good functional results. My limitations will be small study sample and short follow-up period.
What is the angle of barrel blade do you use?
Angle of
Barrel plates for DHS.
135 degree and mainly 135 degree angle plate, and with short barrel we have used.
Short barrel,
Short
135
barrel,
degrees.
135
You
degrees.
check once what is the. Okay, thank you.
Thank you.
Next presenter, Panchal Harinagendra, is going to present on slipped capital femoral epiphysis in situ fixation.
Good morning, sir. My topic is slipped capital head femoral epiphysis in situ fixation. Presenter myself. Coming to introduction, SCFE is a disorder in which capital femoral epiphysis is displaced from the metaphysis through the fascial plate. The term SCFE is actually a misnomer in that the head is held in the acetabulum by the ligamentum teres, and thus it is actually the proximal femoral neck and shaft that moves anteriorly and rotate externally related to the femoral head. In most cases, a varus relationship exists between the head and neck, but occasionally they slip into the valgus with the head displaced superiorly and posteriorly in relation to the neck. Incidence in overall 2 cases per 10,000, 1 lakh population. The disorder generally occurs in the age range from 10 to 14 years in girls and 10 to 16 years in boys. Etiology, idiopathic, thin and tall adolescent or short, obese individuals. Mechanical causes, radiating to pelvis and patients with rickets. Endocrine factors like obese hypogonadal male, hypothyroidism, growth hormone deficiency, and chronic renal failure. Primary hyperparathyroidism, associated symptoms like Klinefelter. My aim of the study is to assess the role of in situ fixation in SCFE to prevent the further slippage and development of avascular necrosis of the femoral head. Materials and method. This is a prospective study was carried out Department of Orthopedics at Khartoum Medical College and Hospital from November 2020 to December 21, consisting of 8 patients. Patients were followed by clinical and radiological appearance for 6 months. Inclusive criteria: patients with age limit 10 to 15 years of age who were evaluated and diagnosed with SCFE were taken into the study. This study was carried out after obtaining ethical committee clearance. Exclusive criteria: age above 18 years, neglected SCFE, bilateral SCFE. Surgical techniques: percutaneous in situ fixation remains the gold standard treatment for SCFE. The patient is positioned supine on a fracture table with contralateral limb in hemi-retorting position. 1 centimeter longitudinal incision is made over the anterior aspect of the proximal femur. Under fluoroscopic guidance, a guide wire is advanced freehand into the center of the epiphysis, stopping approximately 3 mm short of the articular surface. The proximal part of the femur is brought a full range of internal rotation under fluoroscopy to confirm the skew has not violated the joint cavity. Wound is closed in layers and sterile dressing is applied. Post-operative, the patient weight-bearing status is advised on the basis of stability of the SCFE. Radiograph follow-up is performed at 6 months interval to monitor the contralateral until skeletal maturity. This is pre-op X-ray. This is post-op X-ray. This MRI SCFE. This is intraoperative pics and post-operative pics. My results are: among 8 patients who were treated surgically with the CC screw fixation are followed up for 6 months and did not show any signs of avascular necrosis and further slippage femoral head. Coming to discussion, the primary purpose of definitive treatment of SCFE is to stabilize the capital femoral epiphysis to the femoral neck to prevent further slipping and closure of the capital femoral epiphysis and reduction of the epiphyseal displacement. Other treatments like in situ internal fixation by pinning, bone graft epiphyseal disease, open reduction of the epiphysis, osteotomy through the apex or base of the femoral neck or intertrochanteric area with or without fixation of the epiphysis to the femoral neck, and application of spica cast. The choice of treatment depends on the type of slip and its severity and its individual preferences. In my study, males are most commonly affected, particularly age group were involved, that is 10 to 15 years. Left hip is more affected than the right hip. Advantages: with this method, anatomical realignment is achieved, blood supply is preserved, osteonecrosis of the femoral head is prevented, low rate of infection due to small incision, less duration of hospital stay. My limitations: small study of 8 group patients, short-term follow-up, no comparison group. Coming to complications, AVN is most common with moderate and severe slips, chondrolysis, decreased joint space, osteoarthritis. Conclusion: in situ fixation of SCFE with CC screws through the physis has a relevant role in stable slip. SCFE with CC screws shows satisfactory functional outcome and less complications. These are my references.
So why did you choose a screw fixation instead of in situ pinning in the first place? Just not out of this context, but just a question.
In stable slips, CC screw is more accurate, less complications. Preservation of femoral blood supply.
There are several studies indicating that in situ pinning and CC screw fixation have similar studies. So in situ pinning is actually easier for the surgeon. Is there any reason why in situ pinning is just pinning through the closed wound? So for this one, you have to make an incision. It's a wider screw. You'll have to drill, and there's a chance of avian, which is high in case of SUFI. So when a comparative study is indicated between these two, between in situ pinning and screw fixation, so generally the proponents of K-wire fixation or in situ pinning suggest that there is more chance of avian with screw fixation, which is not the case, which has been disproven many times. But is there any reason why you went with screw fixation in your case?
Children more activity, so CC screw more stable than pinning.
For stability purposes, okay. Next presenter, P. Nagaraju, comparative study of compared unipolar versus bipolar in fracture neck of femur in elderly population. Next, Pretam, Puneet Gaurav, Rupa Sai, Murli Krishna
Good
Naik.
morning,
Please be
everyone.
ready.
My study is compared to study results of unipolar versus bipolar hemiarthroplasty in fracture neck of femur in elderly population. Introduction. Fracture neck of femur and its complications of internal fixation account for significant morbidity and mortality in elderly. Hemiarthroplasty helps in early mobilization of the patient as well as bringing the patient to his or her pre-fracture functional status. Prosthetic placement avoids complications like non-union, osteonecrosis, and recumbency of the patient. The decision to perform hemiarthroplasty using unipolar or bipolar process remains controversial with proponents on either side. Advantages of unipolar process include lower cost and low risk of polyethylene wear debris. Advantages of bipolar process include less acetabular wear and potentially less hip pain. So in view of these varied opinions, we decided to compare the efficiency of these two processes. Aims and objectives to evaluate the short-term functional outcome. Materials and methods. It is a comparative study carried out in the Department of Orthopedics at Johnson Hospital, Srikakulam. 20 patients with fracture neck of femur were taken. Of them, 10 patients were treated with unipolar and 10 treated with bipolar. Both the patients' functional outcome was evaluated using Harris hip score. Inclusion criteria. Patients of fracture neck of femur with age above 60 years. Patients with unilateral fracture neck of femur. Patients who are medically fit for surgery. Exclusion criteria. Patients who are non-ambulatory before fracture. Patients with pathological fracture neck of femur. Patients with associated ipsilateral fracture shaft of femur. Patients who are not willing to give consent for surgery. Surgical approach is posterior approach. Entropics of position and incision. Processes and head size selection. Post-operative care. Post-operative lower limbs are kept in abducted position with a pillow in between the legs. A drain is removed after 2 days. Exercises include breathing exercises, quadriceps, and movement exercises are taught. Patients were instructed to sit on the first post-operative days, stand up with support on the second post-operative day, and were allowed to bear full weight and were advised to walk with the support of a walker on the third post-operative day based on his or her pain tolerance capacity, and were encouraged to walk after that. Squatting and sitting cross-legged are not permitted. Removal of suture is done on 14th post-operative day. Patient for checked for any deformities or shortening of the leg and then discharged from the hospital. Follow-up. Patients are advised to visit the hospital at an interval of 6 weeks, 3 months, 6 months, and 1 year. At each visit, functional outcome is analyzed by using a Harris hip scoring system. X-ray of the operative hip was taken immediately after surgery and at each follow-up. Pre-op and post-op X-ray of a bipolar arthroplasty case. Pre-op and post-op X-ray of an unipolar arthroplasty. Result functional outcome using Harris hip score system as used. Age distribution, sex distribution, side, scoring system. In unipolar, there are 3 excellent results and good results for 3, fair 3, and poor outcome in 2 patients. In bipolar, there are 5 excellent results, good results in 3, fair in 2. Our overall mean Harris hip score is 80% for unipolar and 88% for bipolar hemiarthroplasty at 1 year follow-up.
Okay. Conclusion.
The result of our study shows that bipolar hemiarthroplasty gave better results when compared with unipolar hemiarthroplasty.
Okay. Why do you think that in unipolar there are poor outcomes in 2 patients in your study?
Hip pain and
No. What might be the reason?
acetabular erosions.
Okay. Okay, good.
Thanks.
Next. Next presenter, Preetham. Post-operative outcomes of proximal femur fractures in relation to timing of surgery and baseline characteristics in elderly patients.
Good morning, sir. My topic is post-operative outcomes of proximal femur fractures in relation to timing of surgery and baseline characteristics in elderly patients, a retrospective cohort study. Introduction: proximal femur fractures are a major public health issue due to ever-increasing aging population. It's the second most cause of hospitalization in the elderly. There's a long-standing debate on the effect of timing of the surgery, day or night, and time to surgery from injury to surgery on the outcomes. Surgery done in ATAS may be associated with complications related to surgery fatigue, decreased availability of support staff, and logistical matters. Time to surgery from the initial injury also plays an important role in the terms of functional outcome and complications related to prolonged bed rest, such as thromboembolism, atelectasis, and pressure sores. The delay is usually due to associated comorbidities. Aims and objectives: to compare the post-operative outcomes of hip fractures in relation to baseline characteristics and timing of surgery, to compare the post-operative outcomes in hip fractures in relation to time to surgery. Materials and methods: we review total cases of 50 cases of proximal femur fractures operated in Ashram Hospital from the time period of December 2022 to January 2022. Inclusion criteria: age more than 45 years, fractures involving a proximal femur, neck of femur fractures, intertrochanteric fractures, and subtrochanteric fractures. Mechanism of injury: low energy. Treatment detailed at Department of Orthopedics, Ashram Hospital. Exclusion criteria: high energy trauma, patient having associated fractures which influence post-operative mobility and morbidity, revision surgeries on same side, and previous fractures on contralateral side. After considering inclusion and exclusion criteria, we got a total number of 30 cases. Categorized into two groups based on timing of surgery: day group, night group. The time to surgery from the complete sample is divided into three groups: less than 1 day, 1 to 3 days, and more than 3 days. The data collected: pro forma, baseline characteristics, name, age, sex, date and time to injury, mode of injury, comorbidities, pre-injury, site diagnosis procedure, and inpatient number. Outcomes: in hospital outcomes, pre-operative hemoglobin levels, time to surgery, post-operative hemoglobin levels, in hospital mortality, duration to hospital stay, post-operative 1 year ambulation status, post-operative 1 year mortality. This mean age of elderly patients 67.8 years, 82% IT fractures, 11% neck of femur fractures, 6% subtrochanteric fractures. Timing of surgery: in hospital mortality rate, day group 0.8%, night group 7.4%, statistically significant when compared to day cohort. Mortality after 1 year: day group 13%, night group 11.1%, comparable between both the groups. There was no statistically significant differences in other baseline characteristics in between day and night cohorts. Time to surgery: did not show any statistical significance related to post-operative outcomes like 1 year mortality rate, 1 year ambulatory status, post 1 year mobility status. Conclusion: our study throw a light on the outcomes of surgery in proximal femur fractures in elderly in relation to timing of surgery and time to surgery from the initial time of injury. Overall, there was a better outcome associated with patients operated due to the daytime in view of low in hospital mortality rate, but the time to surgery did not show any significant variation in relation to post-operative outcomes. Main limitation of the study is retrospective nature and lack of adequate sample size, and we opine that there is need for prospective study with higher and more uniform results to validate the results. Our study recommends individualization of the treatment of patients based on patient factors in terms of variables such as timing to surgery, time to surgery, and comorbidities in all the fractures around the hip to reduce mortality and morbidity in elderly patients. These are my references. Thank you.
What was your criteria for dividing into day group and night group? Day group and night group.
7 to 5 a.m., 5 p.m. and
night duty, morning duty, something like that.
Yes, sir.
Huh? Okay. Okay. Next, Puneet Gaurav. A clinical study on evaluation to evaluate correlation between BMI and functional outcome of TKR in osteoarthritis.
Good morning, sir. So my topic is clinical study of to evaluate the correlation between body mass index and functional outcome of total knee replacement for osteoarthritis of knee. Introduction: the total knee replacement is a surgical procedure whereby diseased joint is replaced with artificial material it helps to alleviate pain, improves function and the joint, and increases the mobility of the individual. Higher BMI results in elevated loading forces over the articular cartilage, eventually causing the tissue damage. In addition, adipose tissue releases adipokine, a protein that results in excess cartilage inflammation and degradation. Purpose of my study is to we are going to find how BMI significantly contributes to higher rate of osteoarthritis, ultimately affecting the functional outcome of TCAR. The patients were grade 4 according to Clegg-Lawrence classification in the Department of Orthopedics of Ashram from November 2020 to 2021. 17 patients out of 14 females and 3 males. Design of the study was hospital-based prospective and descriptive study. Patients were, the BMI was calculated with WHO formula. International Knee Society score was collected pre-operatively at 3, 6, and 12 months interval. Patients were divided into 2 groups according to BMI less than 25 in group 1 and more than 25 in group 2 according to WHO classification. And subgroup analysis was also done on all 5 subgroups of WHO classifications. Then the patients are evaluated post-operatively for the range of movement, relief of pain, scoring as done for Knee Society pain score, knee functional score, and the KSS has 2 sections, namely knee scores 7 items and functional scores 3 items, and both are scored from 0 to 100. Knee condition improving lower to higher. And this is the WHO BMI criteria, sir, and the classification. And this is Knee Society scoring system. These are the samples of the patient Knee Society score questionnaire, and this is a functional Knee Society score. My result of that 17 patients were total knee replacement was performed in my unit from November 2020 to November 2021. The mean age was 63.6 years, and 18% male and 82% female. And then this is sex distribution chart. The mean follow-up was 6.3 months, and the range of 3 months to 1 year. And distribution according to BMI is showing this curve. The mean BMI was 30.72, and with 52% obese, 29% overweight, and 19% normal weight. 2 comparative study groups consist group 1 and group 2 patients, and the functional outcome was there is no significant difference in the pre-operative and post-operative scores between group 1 and group 2, and similarly there was no significant difference in the post-op scores between the 2 groups, and it was analyzed by student T score, and the complete functional outcome are in the further. The conclusion of my study: overall, the study has shown that comparing normal weight individual to those with BMI more than 25, there is little difference in the post-operative functional outcome. Patients should receive detailed counseling regarding the potential increased risk of complications with increasing BMI, and hence patient can be motivated to lose weight pre-operatively to improve the post-op functional outcome.
So why to lose weight when there is no decrease in functional outcome?
Sir, there was a difference, sir.
Little means?
Sir, those who are receiving
no, it's see
sir,
when you're
the rehabilitations like scoring was around 88.7 to 56 point. This much difference was coming.
Okay. If you have to consider it when you are presenting a paper, is the difference statistically significant or not statistically significant?
Yeah.
Okay. Because you skipped your discussion, I don't know if it's statistically significant or not significant. So you are telling that it is statistically significant.
Yeah, yes, sir.
Okay. Next study, Rupa Sai, a study of functional outcome in prolapsed intervertebral disc using mini open hemilaminectomy and discectomy.
Good morning to all. Today my topic on paper presentation is functional outcome in prolapsed PIVD using mini open hemilaminectomy and discectomy. Introduction of all orthopedic diseases. Lumbar disc herniation is most common pathological disease caused by degenerative changes and is the most common cause of low backache and sciatica. It is characterized by symptoms of back pain radiating to lower limb associated with neurological dysfunction. These are the various conservative methods available, and if these methods fail to respond, we prefer the surgical options. In this present study group, we prefer mini open hemilaminectomy and discectomy. Aim is to analyze the functional outcome of This procedure, it is a prospective study with a sample size of 25 patients performed in Department of Orthopedics at Cardinal Medical College and Hospital with a duration of 13 months and follow-up period 6 months. And the age group involved is 25 to 60 years. Inclusion criteria, patients age about 25 and below 60 years, and symptomatic LDH with corresponding neural compression or preoperative MRI with neurological dysfunction, and symptomatic LDH with failed conservative treatment. Exclusion criteria, patients age below 25 and above 60, associated herniation involving more than one level, associated coagulopathy disorders, trauma, infection, and patients who require fusion surgery, and associated spondylolisthesis, significant lumbar spinal instability, and coexisting scoliosis. In this, we prefer the patient with predominant unilateral leg pain extending below the knee that has been present for at least 6 weeks. Coming into procedure, under general anesthesia, patient in prone position, surgical site is clean, painted, and draped, and appropriate disc level to be operated is marked with the help of CM, and 4 to 5 centimeter midline vertical incision was made, centering over the appropriate disc. Skin, subcutaneous tissue, and fascia are retracted on either side, and the operated side paraspinal muscles are retracted. Then a small part of inferior border of superior lamina and superior border of the inferior lamina removed with Kerrison and Rongers.
Skip the surgical procedure. Skip the surgical procedure.
Coming into results, 25 patients were studied and operated in prone position. Average surgical time is 30 to 45 minutes, and score is assessed using modified McNabb criteria. Among this, most common level of PIVD was observed at L4, L5, and males are predominantly affected, and 25 to 40 years age group are more affected. Among them, agriculture laborers are more involved. Around clinical presentation, brain radiating to unilateral limb associated sensory deficits are more commonly known, and we get 92% success rate. Discussion. These are the observations of made in the study, and our results are compared with in par with the other studies in the literature review. Post-operative protocol, post-operatively antibiotics were given for 2 days. Patients were admitted on first post-operative day and discharged on third post-operative day. Post-operative period was uneventful and no signs of infection noted. 2 patients had mild radicular pain and treated with pregabalin. Advantages in our study, which is minimal soft tissue injury, lesser operative time, lesser stay in hospital, early mobilization and quicker return to daily activities, low chance of infection rate, cost effectiveness, limitations, steep learning curve, cannot be done in multiple levels, and higher chance of dural injury. Conclusion, this present study concludes we have the better outcomes with minimal complications with this procedure.
Last, Murli Krishna Naik. Surgical outcome of pediatric long bone fractures managed with TENS.
Good morning, all. My topic is surgical outcome of pediatric long bone fractures managed with titanium elastic nailing system. In majority of long bone fractures in children are managed with close reductions and POP casting. In some cases, surgical treatment is warranted because of polytrauma, open fractures and compartment syndrome by external fixator or internal fixation by plates and screws. Over recent years, the use of elastic stable intramedullary nailing has dramatically increased with the introduction of variety of TENS for pediatric fractures. My aim of study is to assess the fracture pattern with the help of radiograph to achieve normal anatomical reduction and stabilization of fracture by percutaneous fixation with TENS and to study the final functional outcome. Few points about TENS. TENS is an indent fixation of diaphyseal fracture of long bones where the medullary canal is narrow or flexibility of implant is paramount. In pediatric application, the flexibility of the TENS allows it to be inserted at a point which avoid disruption of the bone growth plates. The sizes varies from 1.5 mm to 5 mm. The biological principles of TENS is based on the 3-point fixation with a symmetrical bracing action of 2 elastic nails inserted into metaphyseal, each of which bearing the inner bone at 3 points. It produces flexure, axial, and translation and rotational stability. The materials and methods I use, mine is Prospective studies 20 children of various fractures of long bones, and my diagnosis based on purely on X-ray images and fracture results from the sports activities, road traffic accidents, falls on ground. There were 4 humeral, 2 forearms, 8 femoral, and 6 tibial fractures in my studies. My inclusion criteria are age between 6 to 14 years, closed fractures, and fresh fractures,
exclusion criteria are age below 6 years and above 14 years, open fractures, and patients who are medically unfit for surgeries. Surgical techniques. Patients are operated as early as possible under anesthesia and under aseptic precautions. The position of the patient depends upon the site of the fractures. The selection of the nail is so that the diameter of individual nail should be 30 to 40% of diameter of medullary canal. Before proceeding, we have to contact the both nails into the bow shape with a nail tip pointing to the concave side of the bow nail. The apex of the bow should be at the level of the fracture, and the bow of each nail should be similar for the balance effect. To create a nail entry point, penetrate the near cortex with a drill or awl. Slowly lower the drill to a 45 degrees angle relative to the shaft axis. Then advance a drill bit to the angle until it reaches the medullary canal. And after loading the nail, the first nail is inserted into the medullary canal with a tip and nail tip at a right angle to the bone shaft. Rotate the nail through 180 degrees with the inserted and align the nail tip with the axis of medullary canal. At the insertion point on the opposite side, open the medullary canal in the same manner and pre-bend a nail of identical manner in the same way. Insert into metaphyseal and advance up to the fracture site. Visualize the fracture under the fluoroscopy, determines which nail is to be easier to pass across the fracture, and advance the nail which will the most effective pull the proximal fragment into the alignment. And the nail across the fractures, monitor the nail position with the fluoroscopy.
Okay, conclusion, time up.
And the advantages are no need for post-operative cast, primary bone union, avoid the growth plate injury, minimal invasive surgery, and excellent functional cosmetic functions. These are the few X-rays which shown excellent result with minimal scar and good cosmetic result. All patients achieved complete healing at the mean time of 7.5 weeks. Complications were noticed in 3 children, which include 1 entry skin site infection and 2 protrusion of tents through the skins. Routine removal of nails. My conclusion: 10 should be very good functional out and cosmetic result. It is a minimal invasive and simple, safe and well reproduced technique with excellent objective and subjective results. This technique has many merits over the more traditional plating technique, and it is very suitable for technique to treat long bone fractures in children. Cosmetic is perhaps the most important and won't have small and less conspicuous with the tens than the traditional approach of plating. Thank you.
Okay, how stable is tense nail? What are the stability modalities you have mentioned with tense nail? Axial stability, torsional stability, in that?
Translation and rotational.
Okay. Why do you consider tense nail as a rotationally stable device? Generally, what happens is, what is the purpose of interlocking nails? What are the interlocking screws for? In case of a nail?
Static nails, diamond.
No. What is the purpose of the interlocking screws?
To prevent rotation.
To prevent rotational stability. Are there any screws in TENS?
No.
So how is it rotationally stable? Why is it rotationally stable? So if you put a single nail, it won't be rotationally stable, but you have to pre-bend your wires. You have done it, but you're not. You have pre-contoured your wires. But that is the weakest link. The rotational stability is the weakest link in your study. But because you have pre-contoured your wires in 3-point fixation, 2 3-point fixations give it slight rotational stability, which is not in par with that of interlocking nailing system, but still some stability will be achieved. Still, it is a weak link. Okay.
Thank you.
We now conclude our paper session. We now proceed towards the next session. Thank you.
Regarding this first session speakers, is Dr. Umami Reddy here? Yeah, he's here. Dr. V. Tejaswini. Dr. V. Tejaswini, yeah, she's there. Dr. Sri Phani from Vijayawada. He's not coming. Okay, he's not coming, it seems. And Dr. Subbarao Garu. Yeah, okay. Dr. Rajiv Reddy is here. Okay. Dr. Kaushik. Yes, sir. So, I think the speakers. Just ఫోన్ చేయండి సార్ అంటే ఏం లేదు సార్ మీ పర్మిషన్ తీసుకొని స్టార్ట్ చేద్దాం ఎందుకంటే నీకు ఎవరు లేదు అందుకని ప్లానింగ్ ఒక బయాప్సీ మేనేజ్మెంట్ All the delegates sitting in the dining hall, please, if you have completed your breakfast, please do move over to Hall A or Hall B as per your interest in the subject. I hope you all know that topics. Hall A, we have orthopedic oncology and followed by Dhanvantri silver medal papers. And the second session is on general orthopedics. వాళ్ళు కొద్దిగా లోపలే ఉంటామన్నమాట జయశేఖర్ గారు అర్థాక బయటకు వెళ్ళి ఉంటారు. As and when required, will come over. Not expect the 1 hour that you get. Good morning, everybody. After yesterday's brainstorming academic sessions, followed by a grand gala dinner, I could see all your energy there. I think that's the reason probably, the whole energy must have been drained there in the banquet. So that's why we have very less crowd today. But this is the first time in these 3 days I am seeing some chairs empty at least. So I think it's time we start our session so that, we all can finish it as early as possible and reach our homes. You must have all come from a very long distance. I expect you to travel very safely. Please don't carry yesterday night's memories while driving. May I invite upon our chairpersons of the session for orthopedic oncology, Dr. SSV Ramana Garu and Dr. VV Narayana Rao Garu. The both doctors are from Guntur. So kindly be seated, sir. Dr. Atmaram, you're one of the chairpersons for one of these sessions here in this hall. You're going or coming? I think we need your presence here today in this hall. Yesterday you were there in Hall B. So I think we need you in Hall A today. That completes you, Come inside and be seated, Just 2-3 hours question. Yeah, she has given you permission, Come. Your better half has given you permission. She has nodded. I have seen it. So may I call upon the first speaker of this today's session, Dr. Umami Garu.
Hello. Extremely thank you for giving me the opportunity to present in this esteemed venue, and I can say whatever. Slides up. Okay. Thank you, Ongol, for this opportunity. First of all, when radiologist is speaking before orthopedicians, now I stop reporting radiographs for orthopedicians. That's a real happiness for me, because when then 10 radiographs come for me, I have to report only 5 of them. 5 I'll give without reports. Why? Because you people have taken the modality to in your hands, and most of the times you are doing better job in picking up fractures, the subtle fractures based on your clinical skills and observatory local area. Most of the doubts I get from orthopedicians are mostly regarding bone tumors, especially whenever I get a common query, WhatsApp image I get, and it is going to be a fibrous cortical defect or an off, and I'll be very happy answering that. And because sclerotic rim will be helping in diagnosing such condition. So I would like to give an overview and gist about everything in a matter of 10 minutes. I think you can extend 2 minutes because speakers are
that is with the permission of the chair, on that side.
So I can time the lecture. Thank you. So reading the radiographs in bone tumors. So basically, tumor and tumor-like lesions, they can be classified into benign and malignant. They are again primary, secondary, and metastatic. Primary bone tumors are relatively, malignant bone tumors are very rare. So secondaries are more commoner than this part you can have in any lectures. Directly coming to my conventional radiographic features: age, number, location in the skeleton, either axial or appendicular skeleton, and location in the bone are extremely important. Followed by it, you perform a radiograph. In it, again, we follow a rule of 8. We look at the age, location, size, zone of transition. These things I would like again emphasize while in pictorial review. Pattern of bone destruction, periosteal reaction, tumor matrix, whether the lesions are polyostotic or monostotic. These are the things we'll like to look at. Next, and again, some things which are, there are some dictums. For example, before epiphysis doesn't close, we don't see giant cell tumor. So malignant tumors in very early age group, less than 5 years, extremely rare. So such dictums are very important while diagnosing bone tumors. In first decade, if at all you are seeing a lesion, it should be some leukemia or a metastasis from a neuroblastoma rather than a primary tumor. So second decades, you'll see osteosarcoma or Ewing sarcoma. So this is a chart which is extremely helpful in knowing age of presentation of the tumor. See the red one, the incidence in first year, you can see first or second years, you can see a metastatic neuroblastoma. And around in 11 years, you can see a malignancy of Ewing sarcoma. So osteosarcoma has a bimodal peak, as you all know. So these things directly going to the radiology per se. See, these are the, first of all, you should assess, am I dealing with a solitary or multiple lesions? Based on single radiographs, it's difficult to assess. Sometimes you may need to have multiple radiographs and bone scan to tell whether it's a lesion is solitary or multiple. When the lesion is unusual, you need to see. If you see a fibrous dysplasia, you do a skeletal survey to look whether it's a multiple polyostotic or monostotic, such things you can do. So this is a classical case of diaphyseal aclasias. So there are multiple osteochondromatous. How is it different? Single osteochondroma, the malignancy rate is 0.3%. If it is multiple osteochondromatosis, malignancy rate can go up to 3%. So polyostotic region is very important. You need to diagnose. So this is again multiplicity. You can see multiple sclerotic lesion. This is a case of breast metastasis. So first of all, again, where is the lesion? Whether it's in longitudinal axis assessment is important. Again, in I'll show it in pictorial review as we are very short. See, again, whether it's an epiphyseal lesion, whether it's a metaphyseal lesion or diaphyseal lesion will extremely help. And sometimes there will be special predilection for sites. So this is a classical cortical diaphyseal lesion, which is a osteofibrous dysplasia. So again, this is a common site for a adamantinoma. We have recently come across the 2-3 cases of osteofibrous dysplasia and adamantinoma. There, if you see a tibial lesion along the anterior cortical location, you have to think about a adamantinoma. So typical location, popliteal fossa, huge mass with osteoid matrix. Again, underline, osteochondroma will have a similar appearance. However, you don't see some destruction here. So if you see a very dirty looking picture in a popliteal fossa, you should always think about a paraosteal osteosarcoma. So if at all, there are 1 or 2 most important things which I would like to emphasize again in a short period of time. One thing is the longitudinal axis. You can't just tell GCT occurs, you can't give a differential diagnosis of GCT in a diaphyseal lesion. It's absurd. So this blunder should not happen. This is in radiology. If anybody calls a GCT for a epiphyseal for a diaphyseal lesion, he's considered to be failed in exam. It's as simple as that. So longitudinal axis, you should not mismatch longitudinal axis. Like there is a subtle chondroblastoma, epiphyseal tumor. So you can't put chondroblastoma somewhere and in diaphysis or something like that. So please always look at the longitudinal axis. Epi diaphyseal lesions you need to know always. You need to while putting the differential diagnosis. Second thing is transfer axis. This is not always foolproof. Most of the time, central lesions are simple bone cyst, enchondroma, fibrous dysplasia. Eccentric lesions are GCT, sarcoma, chondromic site fibroma. But if I'm giving least important for certain finding, this is going to be this, because when tumor grows for a bigger size, it can become eccentric, it can become exophytic. So this can you can just mix match with this. So again, whether the lesion is cortical or not, certain tumors are cortical. This helps a lot actually. Cortical lesions are, as I said, non-ossifying fibroma, osteoid osteoma are cortical lesions, and paraosteal osteosarcoma and osteochondroma, these are juxtacortical lesions. So you have to know the where exactly lesions are occurring. Again, in spine, the lesions occurring in anterior elements, the lesions occurring posterior elements. If you're seeing a exophytic lesion in the posterior elements, you have to think about a osteoblastoma or a osteoid osteoma or a osteochondroma. So anterior, there are multiple lesions, you all know, lymphoma, myeloma, even sarcoma, osteosarcoma and all. So, so based on certain patterns of destruction, you can definitely tell whether it's a lesion we are dealing with a benign or aggressive. We can't tell pinpoint diagnosis based on radiographic features, because osteomyelitis, though it is a not a malignant condition, we call it as an aggressive lesion. Why? Because there is a lot of overlap. So as based on radiographs, it's challenging to differentiate osteomyelitis unless until there is abscess, some intracortical tunneling and CT showing sequestrum, all these things. In radiograph, it's very challenging. We call it as benign and aggressive lesions. For example, this is a case of chondromyxoid fibroma. There are multiple sclerotic lines and the lesion is eccentric and there's some amount of retained trabeculations here. So this is a case of chondromyxoid fibroma, and we call it as Ludwig type 1 pattern of the bone destruction. So this is a benign pattern of bone destruction. So again, we jump with happiness whenever you see the sclerotic rim. Sclerotic rim is a savior for all of us. If you see a well-defined sclerotic rim around a lucent lesion, most probably we are dealing with a case of lipoma or intraosseous ganglion, such in calcaneum. These are the common tumors, and these we call it as a cockade sign. So if you have central lucency, intraosseous lipoma in a calcaneum is a very extremely relatively common condition, and sclerotic rim is always a helpful thing to rule out differentiate benign from malignant. And second thing is geographic bone destruction. Again, one more pattern is, you see, you don't see a sclerotic rim, but you will see a loose destruction. So again, this is suspicious. We need to, there are a lot of differential diagnosis for it. Without sclerotic rim, again, we have to expand our chart. We need to see a lot of things. So this is a classical subcortical location. Cortical breach is there. There are no trabeculations. This is a classical case of giant cell tumor. And this is a type 1B destruction. See, there is no sclerotic rim. So it doesn't give chance, no, osteoclasts just eat away faster. So it doesn't give chance to that sclerotic rim develop. Okay. Then plasmocytoma is a differential diagnosis. It's an ill-defined destruction you are seeing here, and large destruction. This is a moth-eaten appearance. You see, there are large holes within the bone. So the moth-eaten appearance are seen in case of sometimes in osteosarcoma. So this is permeative destruction, very dangerous. In radiograph, in low light settings, if you see permeative destruction, you may just pass it off. Be careful and look for permeative destruction. So then borders I already emphasized, and periosteal reaction is one thing. So whenever the periosteal reaction is continuous, you're dealing with most probably a relatively benign condition. So this is a thyroid acropathy causing a periosteal reaction. This is an osteomyelitis causing a solid periosteal reaction. There is overlap again in periosteal reaction. You can see a Codman's triangle, elevated periosteal in osteosarcoma, speculated periosteal reaction in again osteosarcoma with osteoid matrix. And this is again a periosteal reaction with sunburst periosteal reaction and destruction in hair on end appearance. This is again osteosarcoma. Again, last few slides about matrix. You can have solid osteoid matrix like this, or you can have a ivory like matrix and cotton wool like matrix. This is a osteoid matrix. You are dealing with a osteogenic tumor, and if dense matrix within the based on locations, again you need to classify. And we love to see the chondroid type of calcifications. Chondroid tumors have cloud-like calcifications. In fibrous dysplasia, you'll have ground glass opacification. So again, osteoblastic mineralization in a osteoid osteoma, and this is a larger tumor. Osteoid osteoma is a brother of osteoblastoma. Again, parasteal osteosarcoma of humerus, relatively rare site, osteosarcoma with bone destruction. Chondroid matrix, this is what I'm trying to tell you. Just remember certain picture, the stippled small calcifications in a chondroid type of matrix. So this is again simple bone cyst, no obvious matrix at all, and some rare trabeculations in uninnervable bone cyst. In non-ossifying fibroma, you're seeing a sclerotic rim, and this is a ground glass appearance in a fibrous dysplasia, plasmocytoma and giant cell tumor. So trabeculations, last few slides. Trabeculations can be remaining. Again, presence of trabeculations, you're dealing most probably with a benign lesion. So hemangioma with secondary formation of trabeculations, and this is all benign. In chondromyxoid fibroma also you can have trabeculations. So soft tissue extension, whenever fat planes are maintained, most probably you're dealing with a malignancy. If they are not maintained, you're dealing with some amount of inflammation. So this is about brief about bone tumors. Thank you very much. And
thank you, Reddy. Well explained about bone tumors, how to read X-rays in bone tumors. Thank you very much.
Thank you.
So our next speaker is V. Tejashwini about the basics of pathology.
Good morning, everyone. I thank the organizers for giving me this opportunity. I'll be talking about basics of pathology. I think this will be a little probably not so interesting for orthopedicians, but I would like to make some points which are concerned with the clinical things. So this will be dealt first with the importance of good requisition, which is a must for diagnosing a bone tumor, and then the types of specimens which can be collected for the bone lesions, and certain problematic areas where there is histopathological overlap, like in groups of small round cell tumors and the giant cell tumors. So diagnosis of bone tumor, nowadays it's a teamwork. It is a multidisciplinary approach where the members of pathologist, orthopedician, radiologist, and oncologist sit together and aid in the diagnosis and plan the treatment modality of the case in an individualized manner. So for a good histopathologic diagnosis, two things are important. First one is discussion with the other disciplines, and then a good requisition with complete clinical and radiological data. This requisition should include age, which is very important. Now, as Sir has told, the importance of age, because certain tumors have predilection for certain age groups. In the same way, the clinical presentation and the duration. If the lesion is growing very fast, then the more chance of it being malignant is seen. The most important one, the bones involved and the specific area in bone, whether it is the axial skeleton or the extremities or the metaphyseal, epiphyseal or diaphyseal. The list of all the tumors is earlier explained. The radiographic appearance is a must in the requisition with the radiological diagnosis. It helps us to improve our diagnosis. Systemic symptoms and clinical diagnosis, especially like history of fracture or history of radiation, should be included. I'll just present you two cases to show the importance of radiological appearances. So these two cases, if you can see, they are almost similar. There are vascular spaces which are filled with hemorrhages, and the intervening septa, it shows the giant cells here also and in this case also. So in such cases, the radiological appearance carries importance. So the corresponding radiological pictures of case 1 and 2. So in the second picture, you can see that the margins are permeative, which indicates that it is a malignant tumor. So it is aneurysmal bone cyst and telangiectatic osteosarcoma. A mild nuclear pleomorphisms are seen in this, but if the radiological appearance are not being taken into consideration, there is every chance of missing this. Then coming to the types of specimens, there are various specimens which can be collected in a bone tumor, like scrape cytology smears, Fnac smears or cell blocks, needle core biopsy, whether it is incisional biopsy or an excisional resected specimens. Scrape cytology is gaining importance nowadays. The core is being taken, a material is scraped, and then it is smeared and smashed on a glass slide,
fixed and stained and observed for the features. This is important, especially in intraoperative evaluation of specimens for planning vertebroblasty. So this is an article which is being published by Dr. I.V. Renuka regarding the role of intraoperative scrape cytology in vertebroplasty. These are the pictures were taken from the same article. The first one showing the plenty of neutrophils. So it is a pyogenic infection. In the second picture, you can see the Jane cells and epithelioid cells, which is in favor of tuberculosis. And the third one is a metastatic adenocarcinomatous deposit, where the pleomorphic cells are arranged in a glandular pattern. So vertebroplasty can be planned in metastatic diseases, but it is contraindicated in pyogenic and tubercular lesions. The next method, which is most commonly available, very cost-effective and easy, is Fnac Smears. But the main disadvantage of this procedure is there is good number of false negative cases. So there is every chance of missing a diagnosis. So in order to overcome that, we can do a cell block technique where the material is being centrifuged, sediment is taken to prepare the smears,
60 years, 8 patients was there, and 61 to 80 years, 8 patients was there, and less than 50 years, there was 3 patients was there. Distribution of study population based on diagnosis. 16 patients of the study had a diagnosis of osteoarthritis, and 2 patients had a diagnosis of rheumatoid arthritis. Distribution of study population based on femoral cuts. So mostly we performed +2 cuts, like 11 mm we resected minimally, and for 3 patients we have done 9 mm, and for the 5 patients we have done 13 mm cuts. Distribution based on the implants used. For 4 patients we have done crochet retaining TKR, and for the remaining 14 patients we have done posterior stabilized implants. And it is the table shows the mean arc of movements on pre-op. For 18 patients, mean arc of movements was 44.12 with a standard deviation of 9.78. In the immediate post-op, it is increased up to 84.7 with a standard deviation of 6.47. 1 year follow-up, it is increased further to 90.63 with a standard deviation of 7.07. And on the mean Coase score, on the pre-op period, it was 33.8 with a standard deviation of 8.3. Immediate post-op, it increased up to 65.7 with a standard deviation of 4.8. And in 1 year follow-up, it increased up to 69.8 with a standard deviation of 3.6. And based on the implants used, crochet retaining implants was used for 4 patients, and in that 1 patient lost in follow-up. And mean arc of movements for 1 year follow-up was for the crochet retaining was 86.6, and mean Coase score was 70. For posterior stabilized implant use patient, it was around 91.4 for 14 patients, and mean Coase score was 70. This was the pre-operative pictures which was taken after giving epidural and spinal anesthesia. Here you can see the maximum amount of flexion and extension which was possible after the anesthesia. And this was taken immediately after the surgery. So you can see the improvements in arc of movements. Our study was in our study, actually statistical analysis was done on the paired T test, and there was no complication associated with the study. Similar studies also had the same results. On conclusion, all stiffening in our study were managed by soft tissue release and bone cuts. By increasing a bone cuts by further +4 mm, we were able to achieve a balanced knee along with a proper soft tissue release. Posterior stabilized implants gave a better stability in severe knees compared to crochet retaining knees. Post-operative physiotherapy, including CPM, will help in getting the functional outcomes. Thank you, sir.
Yes, the paper is open for discussion, and even judges are free to ask the questions, and anybody can ask questions.
Yes. So, Dr. Jovin, very good presentation. A few questions I have to ask. You know about the posterior tibial cut. You mentioned about the distal femoral cut angulations. Yes. What was your posterior? What was the proximal tibial cut depths and angles that you used?
So, 3-degree angulation was used for proximal tibial cuts, sir. And minimum, first we started with 6 mm cuts, and if further flexion and extension gap was tightness was there, then we increased up to 8 mm and according this.
And you also mentioned that you had better outcome with posterior stabilizers as compared to crochet retaining, correct? Yes. But there were no much statistics. You see, the number is very small.
Yes.
Correct?
Yes.
So you cannot use a parametric test for that. You have to use a non-parametric test.
Yes.
So that is an observation, but overall good.
Yes.
Sir.
And what about the clinical pictures following the your surgery, post-operative follow-up, post-operative gait videos, gait pictures, walking pictures, and follow-up after 6 months, 3 months, 1 year? Where are the pictures there? You are shown immediate results only on the table. On the table is different, but when a patient is really walking, we would like to see what is the range of motion post-operative after the end of 3 months or end of the 6 months. After the rehabilitation protocols are completed. You have not shown that pictures at all. That's very important. Unless you show that it cannot be considered as a complete follow-up. Is there anything else?
Yeah, I have one question. I did see that there is some improvement in the range of motion after surgery. But to what extent what is the extent of contribution by the soft tissue release? What is the extent of contribution by the bone cuts? There is increase in the range of movement. You just better explain it.
Sir, first we perform soft tissue release, and if then also the stiffness is still pertaining, and we then gone to bone cuts.
How do you correlate soft tissue release to the increase in arc of motion? How do they help? How does it help?
Sir, for the varus, if the patient already have varus deformities, then we went for medial release, sir.
My question is very specific. How does it increase the range of flexion in the knee when you release the soft tissue? What soft tissues you have released?
Sir, deep MCL and posterior medial capsule we have released.
Do you think they will increase the range of flexion in the knee?
Yes.
How do you support your argument? I understand if you release rectus, you will get it. I understand. It's a layman's language.
Yes.
How a soft tissue release around the knee is going to increase the flexion in the knee? Simple question.
What are the soft tissue you have to release to increase the flexion?
Yes.
That's the SARS question.
Sir, the deep MCL and
They are going to correct varus. They will make your bone cuts and job of insertion of process easy. How they are going to increase the flexion? No, I am just not trying to confuse you. Please, just try to know this. It's very important, you know. Thank you so much.
Thank you, sir.
Any more questions? There are no more questions. I think we can move on to the next presentation. Good. Very good, Joseph. Right.
Next speaker is Dr. Venkatasai.
Good morning, everyone. Today I'm going to present to compare the functional outcome of peroneus longus tendon autograft with hamstring tendon autograft in arthroscopic ACL reconstruction under the guidance of Dr. S. Sheshibhushan Rao, Professor and HOD of MIMS. The incidence of ACL rupture is around ranges from 30 to 78 per 1 lakh persons years. ACL reconstruction improves the knee stability and functions. It reconstructs with either autograft or allograft. Generally, we used autografts, sir, bone patella tendon bone graft, hamstring graft, and peroneus longus graft. The advantage of bone patella tendon bone graft are it is bone-to-bone healing and faster return to the function sports activity. Actually, disadvantage are patellar fracture, large incision, and invasive approach, weaker than native ACL and anterior kneeling pain. Hamstring graft advantage sir, tensile strength equal to the native ACL and small incision approach. Disadvantage sir, it has unpredictable graft size and potential decrease in hamstring power. Then peroneus longus graft, it has advantage sir, acceptable amount of length, adequate size, easy and safely harvested, and minimal donor site morbidity. My aim is to compare the functional outcome of peroneus longus tendon autograft with a hamstring autograft in arthroscopic ACL reconstruction. I compare in terms of post-operative knee stability, subjective knee functions, graft size, graft site morbidity, and range of motion. Materials and methods. The study design was done in hospital-based prospective study for 12 months from December 2020 to December 2021. It is done in the place of Department of Orthopedics, Maharaja Institute of Medical Sciences. The number of subjects are 20. The inclusion criteria is complete ACL tear and age between 20 to 40 years. The exclusion criteria is associated ligament injury, chondral damage, fracture around the knee, pathological condition in the lower extremity. The number of patients is 20. It divided into two groups. One group, one is hamstring tendon autograft group, and another is peroneus longus tendon autograft group. Each group contain 10 patients. The post-operative evaluation done 6 months after the surgery. The graft diameter is done intraoperatively. The functional scores is International Knee Documentation Committee score, Lesions score recorded pre-operative and post-operatively 6 months after surgery. We assess the ankle function score with American Orthopedic Foot and Ankle score and Foot and Ankle Disability score. Then graft harvesting, hamstring graft harvesting. The incision 3 to 4 centimeter incision done 3 to 4 centimeter incision along the pes anseris between the tibial tuberosity and posterior-medial border of the tibia. Then after then we done the subcutaneous dissection. Then we expose the pes anseris. Then we palpate the upper and lower border of the sartorius. Then we identify the gracilis and semitendinous 3 to 4 centimeters from the tendinous incision. After that, then we gracilis and semitendinous dissected from the sartorius fascia. Then we carry the dissection proximally. Then with the help of the tendon stripper, we release the tendon from its proximal muscular tendinous attachment. Then the released tendon is taken for graft preparation. Then peroneus longus graft harvesting. 2 to 3 centimeter incision above and 1 centimeter behind the lateral malleus. The tendinous division is present 2 to 3 centimeters above the lateral malleus. After superficial dissection, then we identify the peroneus longus and peroneus brevis tendons. After that, the distal part of the peroneus longus tendon is sutured to the peroneus brevis with N2 side sutures. Then with the help of the tendon stripper, the peroneus longus tendon is stripped. It carried about 4 to 5 centimeters proximal to the fibular head to prevent the injury to the peroneal nerve. Observation and results. Then we comparison of the graft diameter. The mean graft diameter in hamstrings is 8 plus or minus 1, and the peroneus longus is 9 plus or minus 1. Then functional scores. IKTC score for hamstrings and peroneus longus. The mean difference of hamstrings pre-operative and 6 months follow-up is 38.1 plus or minus 15.1. Then mean difference of peroneus longus and pre-operative and 6 months follow-up, that is 33 point plus or minus 11.8. The Lesions score for hamstrings and peroneus longus. The mean difference of hamstring pre-operative and 6 months follow-up, it is 23 point plus or minus 23.2 plus or minus 14.3. Mean difference of peroneus longus pre-operative and 6 months and 6 months follow-up, it is 24.1 plus or minus 10.4. In my statistical analysis, the mean difference between two peroneus longus and hamstring compared pre-operative and 6 months after the surgery. But in that there was no significant difference between the IKTC score and Lesions scores. Then difference in thigh circumference between operated and sound leg. The graft diameter is the mean of the hamstring is 12 plus or minus 3, and the peroneus longus is 3 plus or minus 1. Thigh hypertrophy was more in hamstring group when it compared to the peroneus longus tendon group. Then ankle function score assessed with American Orthopedic Foot and Ankle scores and foot and ankle disability score, it showed good result post-operative after the graft harvesting. Then in review of my literature, outcome of anterior cruciate ligament reconstructed with peroneus longus, Rotami et al. In 2019 obtained good IKDC and Lysolum score, no patient thigh hypertrophy. Trung et al. In 2019 obtained 77.8 excellent outcomes and 22.2% good outcomes. Java et al. In 2011 obtained good IKDC scores and Lysolum scores. In my discussion, peroneus longus autograft showed comparable functional scores at 6 months follow-up compared with the hamstring tendon. Peroneus longus tendon autograft has large diameter compared with the hamstring autograft. Peroneus longus tendon has more tensile strength when it compared to the hamstring tendon. Less the hypertrophy was found in the peroneus longus autograft group. Functional ankle score in the peroneus longus tendon graft group show good result after harvesting the graft from the ankle. In conclusion, in peroneus longus tendon has greater ultimate tensile load, more thickness and length, less graft harvesting time, almost no donor side morbidity, good functional outcome and knee stability. In my conclusion, ACL reconstruction done with peroneus longus tendon autograft, when it is compared to the hamstring tendon autograft, it showed comparable results with hamstring tendon with almost no donor side morbidity. These are my references. Thank you.
Yes, you said there is a higher tensile strength in the peroneus longus.
Yes, sir.
How did you assess the tensile strength of peroneus longus and the hamstrings?
You said there is a high tensile strength, no? Is there any measurement you have done or just only literature support you are telling that?
Actually, we did with literature support, sir.
You have not done any measure, any.
Actually, we don't have that much technique.
Okay, right, good.
So I agree with that observations. So you see, this is a very good study, but whatever cannot be supported by a result, that should not come in conclusion. Usually you would need biomechanical studies to look at ultimate tensile load failure and all those things. Those are biomechanical studies done on cadavers and things, and you, I mean, or even from, if you take it from humans also, you measure that. So stress strain curve and all those things. So otherwise it's okay, but whatever, just remember for future. So whatever is not done in the study should not come in conclusion. Right?
Actually.
Have you assessed the functional disability of the foot and ankle?
Yes, sir. Actually, we assessed it, sir.
So when compared to the normal side?
Yes, sir.
So the donor side morbidity.
Yes, sir.
We
assessed
it was very less.
Actually, in my college, we are doing peroneus longus more, sir.
Oh, okay. How many cases you have assessed these cases? Yes,
actually, I assessed for 5 cases. I actually assessed almost 10 cases, sir. In that 5 cases are sport activity persons, sir.
So how many peroneus longus you have assisted?
Assessed 5 cases, sir.
Very good. So your participation is there.
Yes, sir. Actually, my participation.
But as sir suggested, should be supported with the biomechanical studies. You simply cannot give a statement that tensile strength is more in PL and less in, because this is hamstring transfer has been there for several decades, no? But this time-tested procedure, but you have presented a novel this thing because it became easy to harvest and the donor side morbidity is less in this.
Yes, sir. Like budding says it is easy to harvest, sir.
Okay, the technical is hands, everything is easy. But even I'm not happy with the 4 centimeters in the incision for this hamstring. Yes, sir, I may be, pardon my ignorance, sir. Do you really require such a long incision?
I think in the beginning stage, yes. But, if it is a thin patient, then probably you'll be able to feel it. But if it's an obese patient, female, with fat deposition around that, you may probably need a 4 to 5 centimeter incision, sir.
I'm happy that you are part of the study.
Yes, sir.
Okay, good presentation. Good.
Thank you, sir. Thank you so much.
In any of your in selection of patients, did you select any obese patients? Because hamstrings will be very thin in obese individuals.
Actually, I didn't encounter any obese patients, sir. Actually, we encountered only thin persons and athletics like and sports persons, kabaddi players and weightlifters, sir.
Usually, we do these peroneus longus when the patient is very hefty. Hamstrings will be very thin in those. Usually, we select peroneus longus only for those.
Okay. So one question from my side, sir. Since Dr. Venkat Sai has assisted the cases, I wanted to know what is the draping procedure for both, sir, because he said peroneus longus. I've seen our arthroscopic surgeon taking meticulous care to cover up the foot almost more than mid half of it. So how do you drape it? Because you assisted, I'm asking. So I wanted to know that. How do you drape the foot, the lower limb?
Actually, drape it from the mid thigh to the up to toes, sir.
That should be very strict aseptic conditions they had to do. To what extent the draping was done? Because but the only hamstring and arthroscopy, the draping is different. But when you're harvesting a peroneus longus tendon, the draping is totally different. Okay. That is, we have observed one of the pictures they have shown here.
Yes, sir.
So what is your take on that? Sir, you answer the SARS question.
Actually, we drape separately, sir. Actually, I mean, we say.
No, since you assisted 10 cases,
Yes, sir,
so
actually,
you all, that's why I just asked you, how do you start your draping, especially the lower part of the drapes,
I mean, how to say?
because that's the most important procedure for any postgraduate, unless you know how to, the step one is not how you hold the knife, the step one is your draping, your draping should create confidence in the nurse, who is trying to assist you. So how exactly do you start draping for a peroneus longus graft? The first step of draping, just tell me the steps of draping. The upper part, it's okay. Now the lower part.
Actually, I mean, we drape from the mid leg to the.
Yeah, close to the mic.
Yeah.
Please be close
We
to the
drape
mic. Be louder, please.
We drape from the mid leg. We divide into intervals, sir. From the mid thigh to the mid leg, and another one is mid leg to the mid foot, sir. So first we harvest the hamstring peroneus.
Don't say that. Sorry, is asking what are the parts covered? The draping part. So Sar has given a very beautiful statement. All the postgrads should know the draping procedure, scrubbing, draping, and before that positioning. These are the most important steps in the surgery. Anybody can do surgery, but the ease of surgery lies mostly in the draping and your positioning. The draping and scrubbing will all prevent that infection. Okay, that is very, very important, especially when you are doing a arthroscopic surgery. I think you are not clear, or you did not understand the question,
Actually,
or
I understand,
you
sir,
are
but
confused.
Actually, I don't, and I'm little, and I don't know how to explain it, sir. Actually,
తెలుగులో చెప్పు ఏ పార్ట్స్ కవర్ చేసావు చెప్పు ఏ పార్ట్స్ డ్రేప్ చేసావు సపోజ్ ఫర్ ఏ ఫోర్ ఆర్మ్ సర్జరీ సపోజ్ యు ఆర్ డూయింగ్ ఏ ఫోర్ ఆర్మ్ సర్జరీ యు కవర్ ద హ్యాండ్ అండ్ యు కవర్ అప్ టు ది ఆల్మోస్ట్ అబౌవ్ ది ఎల్బో ఓకే లైక్ దట్ వాట్ ఆర్ ది పార్ట్స్ ఎక్స్పోజ్డ్ వాట్ ఆర్ ది పార్ట్స్ యు డ్రేప్డ్ ఇట్ డ్రేప్డ్ మీన్స్ కవర్డ్ యు ఐసోలేటెడ్
actually we isolated the first of
what
all
part isolated in the lower leg that Sar is asking.
First of all, we isolated the ankles for graft harvesting. Then afterwards, we isolate the knee. We draped knee from mid thigh to the mid legs.
So the confusion he is not understood your question. Sir,
two steps is it? First, you harvest peroneus longus, then start draping. And then again,
No, sir.
then that's what I'm trying to
Actually,
ask you.
We did draping at a time, sir.
Ah,
But
so-
we did it,
So
we
you're
kept it
saying-
like two blocks. One block for harvesting and one block for arthroscopy procedure.
So in between, you're just placing one green towel here,
Yes, sir.
that is separate part and this is
This is
separate
separate
part.
part, sir.
And the foot part, do you cover the ankle?
No,
Uh,
sir.
ankle,
We covered the foot part
mean,
with
the
sterile
heel.
sterile gloves. Or we covered only foot, sir.
Right, right.
So that is one part and this is
Another
other
part, sir.
Okay.
Right, right. Good.
Thank you, sir.
So
Any
thank you.
questions from the audience or judges?
I have one question.
Sir.
What disability you expect after using the peroneus longus graft?
Actually, foot aversion may be lost, sir, but actually peroneus brevis is act as a synergetic. I mean, peroneus brevis is strong foot averter, so we can't expect the foot aversion, sir.
We can't expect the loss of foot aversion
So may
will
loss
not be affected.
will not be affected, sir.
We attempted something new, which is not a routine. That is the reason why we are asking so many questions. That should be, you have to take advantage of these questions.
Yes.
Okay, don't get confused. Right?
Thank you, sir.
Very good.
May I call upon third speaker, Soham Ranade. Arogyasri Health Scheme and the Bhagyasri for compound fracture cases.
Stop the timer. It's not started. Start the timer. Start the timer now, It's already started. Reset. Yeah. Okay.
A very good morning to all, respected professors, consultants, and my dear friends. Arogyashri. Arogyashri is something which we all know, which we all come across daily. In Hindi, there is a word saying that ghar ghar ki kahani is in, we have to make it in hospital ki kahani, then Arogyashri would definitely come in it. So in this talk, I wanted to tell what are the aspects of Arogyashri and how does it help the common man. I'm Dr. Soham Ranade, a postgraduate of Guntur Medical College, and this is my presentation. So we begin with a case study. A 12-year-old boy presented in government hospital, casualty on a Sunday, and with the following injury. He had type 3B compound fracture of the leg with severe degloving injury. Workup was done for this patient. A quick plantar fraction was done, and soft tissue coverage as well as tense nail was kept for the same. But how did we do it? Arogyashri came to our rescue in this. Now, Arogyashri is basically the lifeline. It was started in 2007. It is basically help for below poverty line patients. Now, what happens is when a patient comes to casualty, he's usually brought by the on setup or on the road patients. He doesn't have attenders. When these attenders come to the hospital, there is a loss of daily wages which the patient and the family has to suffer. So, just going by the data, there are about 2,446 procedures in 30 categories. Already, it is supplying and helping 129.4 lakh families. There is a budget of 15,384 crores. And in the current Niti Aayog status, Andhra Pradesh ranks second in terms of healthcare. All this states that Arogyashri is definitely helping for the poor. These are some of the data. The reason for putting up this data is just to show the magnitude of the amount of help which the scheme has done for upliftment of the poor. This is all years, all sectors throughout the course of the Arogyashri. Now, how we have come up with this idea? Now, what we wanted to do is we wanted to evaluate the functioning of the Arogyashri scheme for compound fractures of the tibia. Now, to evaluate, the objectives were to know the working of the Arogyashri health scheme, to know the benefits received by the patients, and to have a compare contrast between the neighboring states. So how did we proceed? What we did was we obtained 132 patients, 132 cases, and then these patients were type 3B compound fractures of the leg. The Ganga score was less than equal to 14. Now, these patients were subjected to 3 codes. They were compound fractures, that is external fixation, wound management, and long bone fixation. The codes and the packages are what we see in this image. Now, which patients did we take and which we excluded? The patients obviously giving consent were taken in the study. Ganga score less than equal to 14 were taken, and the patients having polytrauma patients, multiple limb injuries, as well as comorbidities were excluded from the study. Now, a step-by-step guide as to how exactly Aarogyasri helped the patient. When the patient arrived in casualty, the cashless diagnostics was done, investigations were done, and basically data was taken from the patient, the Aadhaar card and other details. Now, this Vaidya, he collected all the data and he kept in the portal. When the patient came, we divided the patient into 2 categories, one requiring elective surgery and one requiring emergencies. So the telephonic intimation was taken for the emergency patients, and then the pre-auth was raised. If it was an elective case, then panel and trust doctor's authorization was required. After they screened the patient, then surgery and procedure was taken up when they gave approval. Further, the claim was initiated by the hospital after the procedure was completed. Now, what the data was we obtained was patients, compound tibia fractures, around 108 patients were actually the earning members of the population. So a common history which the patients gave was they were drinking at the time of driving bikes at a very high speed, and those were the patients who were actually having compound fractures. The modality which we operated was external fixator was used in 90 cases, and internal fixation was done in 42% cases. The results at the end of 1 year was union was seen in 101 cases, and non-union due to many causes like gap non-union or infection was seen in 31 cases. The number of patients for which single procedure itself was adequate was 55%. 55 patients, and multiple procedures was required in 77% of the cases. Multiple procedures being debridement or removal of X-fix and internal fixation. Now, here is the amount of money which is the patient has received. The big blue area which we can see is the amount received in the range of 10,000 to 20,000 per patient for that particular procedure. There is even more section of the society, the one in gray, which shows that more than 20,000 was obtained by the patient. A very small set was the amount which is less than 10,000 which the patient received. Now, how is the patient getting so much money? The thing is that when a patient comes to casualty and we apply certain codes, that is external fixator, an amount of 12,000 is deposited in the patient's account. This 12,000 is for compound fracture, that is external fixator. When the patient is discharged and when he comes back again after say 2 months, when we remove the X-fix and the signs of healing are there, when we remove the X-fix, again 3,000 is added. If the patient has to be taken up for next surgery, say internal fixation, again 10,000 is added. So the same procedure, the same patient comes up multiple times, and this is how the monetary benefit is being added in his account. When we compare Aarogyasri with other states, we find that only this scheme gives benefit directly to the patient. No other state has the schemes which do that. Other states usually give in terms of free surgical supply. There is no scheme which gives directly monetary benefit. Now, there is a role of Arogya Ashra which says that 225 rupees are given per day after discharge, and this is a maximum limit of 5,000. So after all this, what we notice that patients usually are having timely follow-ups in spite of the COVID times. Patient usually comes back to us in terms of incentives or in terms of repeated next surgeries. Not just the surgical aspect, but it also takes care of the food and the health of the patient, the stay of the patient, traveling allowance. The 10 days post-discharge medications are also given free of cost. And if complications arise, they are given up to 30 days. Now, the reason for taking up this topic is that the daily wages which are implemented, the daily wages are in the range of say 9,000 per month. Aarogyasri takes care of the social dimensions of the health by giving appropriate monetary benefits and also rehabilitation of the patient. Some other benefits which include, there is extensive procedure codes and coverage in the procedure. There is proper documentation and record keeping which is there. Quality is ensured because it is a multi-step modality process. The trust and the panel doctors take care of the monitoring. It is not just for the patients, but also the doctors, the staff, the technicians get due compensation, as well as there is a certain sense of satisfaction which the doctors, especially working in the government sector, have when they apply these schemes. There is also employment which is generated for various sectors of the society, namely the operators, the Vaidya Mitras. So it is a multi benefited system. My conclusion being that definitely Arogyashri is a Bhagyashri for the poor and the needy. It is a holistic care like none other, and it covers the social dimensions as such. The take-home message being, it provides a direct monetary benefits, number one. Number two, there is quality of services which is taken care of. There is proper documentation and employment. It compensates for the loss of daily wages and the family to recuperate, and free treatment and monetary services are applied. These are my references. So in the end, the story of the boy which we saw in the first slide, this boy is now standing on his own leg. In his story, even though the surgeons are the heroes, I would definitely say that Arogyashri was the best actor in the supporting role for this boy and his story at least. This is all what I wanted to share with you, ladies and gentlemen. Thank you so much for your time. Thank you.
Thank you. What's your name? Sonam?
Soham, yes. Soham Ranade, sir.
Okay, this is a scientific forum.
Sir.
This is purely a scientific forum.
Yes.
So what's your message to the for the audience here and all the judges and all these chairpersons? What is your message? What do you want to give?
Sir, there were no studies which were taken from the patient's point of view, sir. The social dimension, sir, is what I wanted to put in forth, sir. The
Okay,
rehabilitation.
this is a social aspect, no, not scientific aspect.
Yes, sir.
No, are you a presenter or you are giving a brand ambassador for Arogyashri?
No, sir.
No, it is you are just looking like a brand ambassador for YSR Arogyashri. So I will ask you only one single question.
Yes, sir.
Will your scientific protocols changes with the financial aspect of the patient? Will your scientific protocols, the management protocols, guidelines, will they change with the pocket of the patient?
No, sir. The scientific,
whether it's a government or
Yes,
private sector or corporate sector,
sir.
the scientific protocols, scientific guidelines should never be violated.
Yes, sir.
Okay, you don't, that is not the expense of the scientific guidelines. Okay, that is a finance aspect, it's a totally different aspect.
Yes, sir.
Because somebody is not paying, are you allowing to go into amputate?
No, sir.
Especially in government hospital, government has got other schemes to support these poor patients.
Yes, sir.
There is a CM relief fund was there. Before this RX3 came, there was a fund was there to support the poor patients.
Yes.
I worked in a government hospital for 30 years. I know how we used to support the poor people. We never left the people alone. So what are the available scientific advances to be should pass on to the benefit poor.
Yes, sir.
But simply you cannot club the social aspect with the scientific aspect. That's my purely, I may be pardoned for my personal opinion. I think this cannot be clubbed with the scientific session. This is purely a brand, a message, a promoting, you are just praising the RX scheme. Of course, we really happy that this has immensely helped the poor.
Yes.
The poor which you cannot dreamt of stepping into the corridor of a corporate hospital, now is welcomed with a garland in a corporate hospital. I never told an auto wala, a rickshaw wala, entering an Apollo hospital, a care hospital, a Severis hospital. But now he's going without any hesitation.
Yes.
So I think your presentation is excellent. The presentation is excellent, but I am not happy with the scientific content of this paper.
Yes. So we just wanted to, yes. Yes, sir. Yes.
All the freedom in the world to express my opinion.
Sure, sir. Yes. So in this paper, we only wanted to put or highlight the aspects which are not discussed from the patient's perspective, sir. The epidemiological aspect of the study, sir, and also the post-operative or post-rehabilitation, what other problems apart from the only operative time, what other problems which the patient face. I just wanted to put some light on it, sir, in my study.
No, you may not be knowing, Sonam.
Sir.
This system is one of the beautiful systems created by government of Andhra Pradesh.
Yes, sir.
Right from thanks to the Dr. Y.S. Rajshekar, it's a late, is very, very absolutely foolproof procedure. This is one Arogya Mitra will be there, will be coordinating with all the activities, right from the moment patient enters the chamber, and is not supposed to spend a single paisa from the pocket of the patient.
Yes.
If there is no computer or one single paisa spent, that will be, the debut from the hospital will be blacklisted. And then they will be followed till the patient is completely recovered. And all the complications should be taken care. And the government is kind enough to give the package for implant removal also.
Yes, sir.
Okay, any complications, it is the hospital responsibility to see that, and simultaneously patient will be getting a phone call even before the doctor knows that the approval has come.
Yes, sir.
So there's one of the wonderful system created. We have to really thank the government of Andhra Pradesh and the YSR, Dr. Y.S. Rajశేఖర్ who initiated it, and later subsequent CMs continued it. But I really appreciate the social aspect of it.
Yes, sir.
But I don't consider this as scientific paper. Sorry for my comments.
Okay.
Also, you wanted to do an epidemiological study, you said. Good presentation.
Thank you,
But few things, if you go back to inclusion and exclusion criteria, go back to the slide of inclusion and exclusion criteria, you have put Ganga Hospital score of 14 in both the groups, inclusion as well as exclusion.
Sorry, not. So in the inclusion criteria, it is less than equal to 14, sir.
And in exclusion also, it's
It
more than or equal to 14. Just go back to the slide. Show that slide.
It should be more than 14. Sir.
But that doesn't say that.
Sir, 15, 16 is the gray zone, sir. 17 onwards, the patient usually goes.
You go to the inclusion exclusion criteria.
As per my knowledge, whenever the score is more than 14, it is one of the indication for
Amputation.
amputation.
Yes.
Yes. Yes, sir.
Right.
More than.
So this is fine. So how many were open grade 1, open grade 2, or did you just include only open grade 2 patients in your study?
We included grade 3, sir. Open grade 3.
Open grade 3,
Yes.
B.
B. Yes, sir.
A. So your study is exclusively of open grade 3B.
Yes, sir. And over a period of 3 years, we collected around 132 patients, sir. And then
You could have made it more scientific by putting out some functional outcome scores, some validated outcome scores. So that could have put a scientific this thing about a cohort of B. You have had only one single stage surgery. So I think, the assessment has been pretty good in terms of debridement, because many of these patients would be probably have a debridement first, and then you do a stage treatment, right? So
Have you come across any case where as per Gustula-Anderson classification, it is grade 1, but patient is having compartment syndrome and there is a limb threatening?
Yes, sir. So there were cases, sir, for which we had to go for emergency fasciotomy, sir, at the time of arrival. And then after fasciotomy, we kept external fixator, sir, for stabilization of the fractures. We did not go for internal fixation, even though it was grade 1, sir. But those patients are not taken in the study, sir.
Any questions? Yes, please.
Regarding RxT only, you enlightened all issues regarding what are the benefits getting patients, everything. Regarding doctors, if you are not mentioned anything, you know that what are the packages, prices from the starting. So I told it's a beautiful, anything like that. What are the prices when started the RxT scheme? What are the prices now itself? There is no increase in the prices. Why that is you are not mentioned that? Because you are not worrying about doctors, I don't know. But just asking, your topic is raised, so I am asking. Because our doctor seniors are there, my request is, can raise the issue regarding that, so that my request that only.
Yes, even that is not taken care of. Even we are also all really upset.
Yeah,
They're
that's
concerned with the what
because
are the
they are
prices.
Patient packages are increasing. Even like plaster, we apply 5,000 for doctor, for patient getting 3,000. So why can't increase in the doctor's charges?
Yes, we have been fighting for the
yeah.
last 10 years. We are fighting for the increasing wages. Unfortunately, I'm sorry, there are some specialties who are getting more packages for less work.
Yeah, definitely, sir.
We work more hard and we're getting less wages.
Sir, actually, before their diagnostic arthroscopy is there, they are not giving.
It's absolutely true. Absolutely true.
For angiogram, they are giving 30,000, sir. Now that is also diagnostic. But as such, arthroscopy, they are not cancelled the code. I don't know why that is happening. Why the orthopedic forum is not raising these issues?
So, sir, orthopedic forum is raising. We are several times have given representation also. As a president also we represented. We will try to continue because the government is more interested in other things rather than the doctor's problems. So nobody is concerned about the doctor's problems. Doctors' worries, how much struggle they underwent, how many lives they lost in the COVID. None of the government person is bothered. They are bothered about only few things, their own selfish ends. We are really, I agree with you, totally agree with you.
Sir, even I would like to request OSAP that they should also write this letter to Indian Orthopedic Association. Now, because eventually all the schemes are getting merged in the Pradhan Mantri Ayushman Bharat scheme. So eventually we want to do it in the national level. And the organization is very much needed for this issue. As the organization of pediatric surgeons has made their rates so compatible with the private that they are happy to do the surgeries in those packages where orthopedic procedures which are most commonly the patients are facing these problems. I hope IO should take an initiative and we all organizations should write this issue to IO. Not only academics should be considered, the financial aspect of the members has to be considered by the IO. Thank you.
So any more questions, sir? Sir?
If there is no question and presenters are over, we will conclude this session.
Yes, sir.
Thank you, sir.
So with this,
thank you, sir. Sure, sir.
maybe he
Sir,
can
Uday
be-
Kumar Garu. Hello. Hello.
Yes, sir. he's
Sir,
here.
I'm just trying to explain what the study was. This has been done under my guidance in a Department of Orthopedics, Guntur Government General Hospital. This is simultaneously a study parallelly studying the Arogyasri scheme, the flow of Arogyasri scheme, how it is benefiting the poor patients that are pouring into the casualty with type 3B compound fractures. That is the, so that has been, because being a student, he was confused. This is actually a scientific study which we have done because with the telephonic intimation, we are getting the permission from the government because of this scheme. And immediately we are able to do the surgery because everybody is, all the surgeons, nurses, everybody is getting benefited because everybody is on tiptoes to help these patients. So earlier it was not there. That is the point which we are trying to stress you. So simultaneously both are happening. The scheme is happening, the patient is benefited, and patient is brought to the pre-injury status at the earliest because of this scheme. We are not bothered about the financial the money that is deposited into the patient's bank account. But this is a scientific data which we have projected simultaneously projecting the Arogyasri scheme, how it is helping the poor people coming into the coming to the casualty. That is what, sir, this is not just to praise the Arogyasri scheme, but that has been sidelined because it is all this data is almost pertaining to Arogyasri. Because the most of the patients were not presented with their range of movements. What are the procedures which we have done for the type 3B compounds? Because he has presented only a simple single boy with a tense nail. So all the other cases he has not presented. That is how it has been sidelined. But it is a parallel study, sir.
Sir, my question is,
that's what I just
will
wanted
the
to explain.
finances will change your guidelines? That's my simple straightforward question to you. But my feeling, whether in government or corporate or wherever we are, our guidance should not change because the compound fractures is the one limb-threatening condition. Your guidance should not change simply because the patient cannot afford.
No, sir.
You should see that they find a way. They find a way to treat the patient, find a way to debride the patient. Then nothing. Debridement will not cost anything, sir.
We are doing sir,
I worked in government hospital for 35 years, 40 years. We have debrided it. Though we may not have done the X-fix or TENS or most advanced procedures, but you kept the patient in simple slab and bandage.
Sir, our
wound healed.
Our mission is type 3B compound patients.
Yes, sir. We appreciate, sir.
I draw your
Registry is a
attention,
wonderful
please.
scheme.
I draw your attention, please. I request your attention, please. Please, I request your attention. I think this part can be discussed outside the platform. I request you to close this issue. And if there is any scientific questions related to the topic, you are welcome.
Very good, very good.
If there are no questions, we'll say that this session is closed, medal session.
Thank you, judges. Thank you, chairpersons. I should congratulate everyone, was in a friendly, it's just a friendly atmosphere, sir. We have just had some discussions. I don't think these were arguments, sir. It was just a friendly discussion. So I request the judges and the chairpersons to come over to the center stage so that we can felicitate all of them. Sir, please. And so this was just a discussion, but the announcement of these results will be declared in the next year, OSSAPCON 20, next year. Okay. Yeah, today the results will be declared, but the present these medals will be given to them in the next inaugural function, that is 2023 52nd OSSAPCON. Sir, please. So, can I have the, yes. I request the judges to felicitate our chairpersons, and vice versa. The judges will be felicitating the chairpersons, and the chairpersons will felicitate our judges. Just wait. Okay, sir. Sir. So there's sir. There's Thank you. Now I request our chairpersons to felicitate our judges. Certificate. So Aziz sir. Sir. Sir, we'll all stand. So, Malleolus. Thank you all. That was a very fruitful session. So coming to the last session of the day, I know everyone is eager to go home, but this covers a lot of very important topics. Kindly pay your attention. May I request the chairpersons, Dr. Naresh Babu Garu and Dr. Umanath. So can Dr. Naresh OSAP General Secretary of 2022, and can I request Dr. Professor Karthik Vishwanath Garu onto the dais, please, to chair this session. Oh, you have a presentation on that side, sir?
It's okay. He'll take care. He can join whenever he finishes the presentation.
Naresh, sir, kindly take over the further proceedings.
Good morning. This is the last session, scientific session of the day before valedictory and dinner. So this session is on general orthopedics. The first topic is choice of surgery in tendinoachilles ruptures by Professor Raghurandan from Kurnool. I request Professor Raghurandan to give his lecture.
Technical team.
Can I have the slides? ఇక్కడ ఓపెన్ చేస్తాను. ఇది కాదు ఇది కాదు పైన సబ్ పైన పైన. Good morning, everyone. I really thank the organizers for giving me this small opportunity. This is one of the least touched topics. And this topic, especially, I am trying to give you some general principles of how we treat tendinoachilles rather than going into technical details of how we really do that and all that. So I hope we go out with certain basic principles of management of this complex injury. So TA, a few anatomical considerations for your information. It's the strongest tendon in the body. This has got a twisted orientation. It makes the things worse. No synovial sheath, absence of retinaculum to hold the bone and the tendon, and has got a long lever because it's just getting inserted into calcaneum posterior part. So there'll be a long distance between the tibia and the calcaneum. So it's more prone for elastic ruptures, you know. And of course, it bears high ground reaction force that you all know. This is the mythology. I think you all know about this, how Achilles is dipped into the river of Styx, being held by his mother. Fortunately, you know, or unfortunately, she holds him in the zone 2. What is zone 2? We're going to see the next slide. So that is the big problem for us. So this is the zone 1 and 2 and 3 of Achilles tendon. From the level of insertion up to 3 centimeters is 1, between 3 and 6 is 2, and then above 6 is 3. This is second zone, which is most problematic. As you can see in these diagrams, these were the cases which we used to do years ago, 98 before. We used to do sort of, when I was a postgraduate between 90 and 93, we used to have a lot of tear ruptures in, as postgraduates in SU Medical College, Tirupati. Every OT, every duty, we used to operate at least one case. When you look at the blood supply to tendinoachilles, you understand that supply from above is there, supply from below is there, but supply to the mid part of the tendon is the critical one, where there is least amount of blood vessels when you take a cross-sectional area of the tendon. So this is what is called as the critical area of the Achilles tendon. And unfortunately, to our misfortune, ruptures are more common in this zone. That is a problem with TA. I would like you to shift your attention to this slide, wherein this is called as tendinosis cycle. It's more related to the chronic ruptures, but I'd like you to go through one point here. There is always a tendon degeneration before it gets ruptured. Please note this point. This is a tendon is already degenerated and then only it ruptures in case of spontaneous ruptures. In case of spontaneous ruptures, that when patient stumbles and then ruptures, getting down the stairs ruptures. These are the cases where the tendon is already damaged, degenerated, and this is what is called as tendinosis cycle, where all the influencers will work over the tendon to make it weak, and finally it gives away. So what we have for regarding surgical techniques, what concerns we have? If you do a direct suture, there is going to be a dynamic area in the middle of the tendon where it gets ruptured. You all understand this? We are not talking about fresh ruptures in this case. When you do a muscle slide, that means slide the gastrum's down, there will be a lot of tension over the tendon as well as over the skin, and you have to keep it in a lot of equinus. There will be a lot of wound problems as well. So we nowadays are going to shift to a procedure called as tendon augmentation or tendon transfer procedure, wherein we try to bridge the gaps, which is more biological and having equal muscle strength. There are certain guidelines. So in type 1, when there is less than 2 centimeters gap, you can directly suture it off. If there is 2 to 5 centimeters gap, you can do a VY-plasty and then get away with without any wound problems. If it is more than 5 centimeters, then you are supposed to bridge the gap with something else. You cannot directly suture it back. There are Professor Mafuli is an authority on tendoachilles. So he says a simple, if you can end-to-end approximate, do a suture. If you cannot do it, do a release or peroneus brevis. Peroneus brevis. If there is gap is more than to be done away with peroneus brevis, you have to use what is called as flexor hallucis longus. So it's very easy, and in all ways, don't ever use to attempt these what is called as synthetic grafts. They are only for discussion sake and journal publications, not for patient sake, especially in Indian scenario, where they don't even wear a normal footwear. Traumatic fresh ruptures, postgraduates dream to get in any duty day, so they can happily suture. But the problem here is some are what is called as lavatory pan injuries, toilet seat injuries. So when you sit in a toilet and your foot gets stuck inside the toilet, when you try to pull it out, the tendon gets ruptured. So that is called as toilet seat injury, especially with respect to tendoachilles. And this is a little bit problematic, but still we can manage with copious irrigation, minimal debridement, because tendon structure is very much intact, and you try to protect the paratenon. This is the only covering over the tendon, otherwise it is completely nude. So you can just cover it up with paratenon. No exaggerated equinus is to be kept. And all of you know about this suture, what is called as Kessler suture, which is very, very useful, very, very easy. And you can still work away with Kessler suture with small knots over the again overlapping it. In delayed presentations, you can go away with muzzle slide operations, or you can reconstruct with what's called as fasciolata, which all we used to do in the earlier days. From 1998 onwards, till now, except for flesh traumas, we never did anything except for flexor hallucis longus. I can vouch upon that. Touch wood, there are no problems. You won't regret doing the procedure. I'll just show you how a few steps of it, because this discussion is not about that technique. For this, what you are going to do? This is what you find in a general practice. A patient comes to you with a ruptured Achilles tendon, huge gap. What are you going to keep in between? Bone, you can keep bone graft. Skin, you can put skin graft. You cannot keep a tendon graft. You have to keep a live tendon. How do you keep a live tendon in between such a big gap? With example of FHL, we'll just go through. So what are the choices we have? We have only two choices, obviously, which are there nearer to the tendon, what's called as peroneus brevis and flexor hallucis longus. When you look at peroneus brevis, which we used to do before 98, strong but very short, when you try to do the procedure, you have to bring it out through the bone and then suture it back. That was the earlier described procedure. And being a lateral incision, the healing is little bit problematic. When you do it with a medial incision, you know the difference. And then probably there are other complications like risk of injuring peroneus longus. Once I did it, I pulled out 2 tendons, both came out. So this can happen to you. So this is a little bit trickish procedure, which can be really abandoned in favor of flexor hallucis longus. When you take FHL, it is the strongest tendon next to TA only in the leg. And you can give a medial incision, which has got excellent healing capacity. And then all the criteria that we look at in a different presentations, like the results, when you talk about, they are better with FHL. You look at this side, what is called as conjugate movements. In CTEV, we apply what is called as so-called Ponseti's technique. So the conjugate movements, when you plantar flex the foot, automatically it goes into inversion. So this is employed when you dorsiflex the foot automatically, or when you avert the foot, it automatically goes into dorsiflexion. So these conjugate movements is helped by the same group of muscles. When you see tendon Achilles and then your FHL, they belong to the same group. Peroneus brevis is on the other side. So just to mention about the technique of peroneus brevis, you know that. And just to mention about, you can complete off, you can save off your day with doing an FDL transfer as well. But both are more complicated than this technique, what is described by Wapner, the use of flexor hallucis longus. When you do a classical Wapner's technique, the diagram on the other side, you can see that the bone tunnel is made onto the medial side of the calcaneum, which is technically extremely difficult. And if you do this kind of VY thing of the tendon through the Achilles, you don't have centralization of the tendon. Probably you may get a heel varus, your bone tunnel may get ruptured, and probably you may have a heel broadening. So we have addressed all these problems by modifying Wapner's technique. And this is how it is. Give a straight medial incision onto the tendon. Tendon dissection till healthy anatomy. Don't bother about the loss of the tendon. You are going to replace it. Weave it through the proximal trunk with hold with absorbable sutures. Centralization of the tendon. Cut the tendon Achilles into half. Bury this tendon and make it central. You give vertical transcalcaneal conical shape of a tunnel and then pull it out by means of Cole's method. So this is how it goes. A few slides on this. This is how you assess the tendon gap, so big it is. And then these type of incisions are to be avoided at any cost. I've seen people giving laziest kind of incisions, fancy WV, everything. This is not going to work at all because TA is such a sensitive thing. You have to approach it very carefully. And then, see, when you give a beautiful medial incision, the tendon pops out. Always identify the morphology. These are the kind of morphologies which we get across in tendon when we just open the wounds. Bulbous, medullohead, atrophic, and these are approximate categories made by us. Just resect it whatever level you want, isolate FHL, and then pull out suture, centralize the tendon, and then through the vertical calcaneal hole, you bring it out and put it onto the gauze bandage. This is how the completed repair looks like. So with FHL, you need not be worried about these kind of re-ruptures, which we get occasionally. And this is one of the case in Zone 3 that I have operated. This was a nightmare, very recently operated. So there was a huge gap of 12 centimeters in the tendon when we resected it. It was in Zone 3. I never knew, I thought Zone 3 was easy to repair, but a rupture, delayed rupture in Zone 3 is a nightmare. Because when you take out the FHL on that side, the FHL is already muscle there. The FHL is already muscle there. So you cannot so easily, you have to isolate the tendon of FHL to the possible extent. You have to detach it from the fibula. Isolate it and slowly try your procedure all along. And it's very difficult to centralize. Slowly you get it out. And finally we could make out weaving through the distal stump as well. This boy is doing well, fortunately for us. Very rarely you get these Zone 3 injuries. So in summary, I'd like to say the prone group is poorly conditioned because you get always almost spontaneous ruptures. Commonest site is zone 2. Majority go with a tendon transfer rather than wasting our time and then later on getting problems with suturing and closure suturings and all that. They work only for fresh injuries. Best results are obtained with FHL fracture. I can vouch for that. And it requires detailed evaluation and follow-up. Thank you very much for your patient hearing.
Thank you very much, sir. That was an excellent presentation. You have summarized your experience, extensive experience on the particular topic. It's open for discussion. Anybody wants to have questions or comments, please go ahead.
We have incidentally the world's largest series of nearly 172 cases.
Wow.
So we have published in international journals as well. And yes, it was appreciated in CCOT conference as well.
Congratulations. It
Thank
was
you,
an
sir.
excellent Raghurandan's paper. Really, because we get a lot of cases,
Yes, sir.
mainly the skin problems.
Yes,
the
sir.
wound problems are very, very common.
Yes, sir.
That's what we have to take care of why especially the undermining should not be there.
The only points here, sir, give only straight medial incision, sir, onto the tendon and make sure that you don't keep it in more equinus. If you keep it in more equinus, more crimples and more skin necrosis, sir. So try to keep it only in 5 degrees or 10 degrees of equinus. That is more than sufficient. Because anyhow, you are putting a biological tendon there. It is going to adopt. It is going to adopt and hypertrophy as well, sir.
Okay.
So,
then what is your post-operative protocol?
Yes, sir. 3 weeks, we are going to put a slab anteriorly. Then we encourage after 3 weeks posterior treating exercise.
Below knee slab or above?
Below knee, sir. Below knee.
Below knee. Okay.
So anterior slab to avoid dorsiflexion and then ask the patient to actively plantar flex after 3 weeks, sir.
Okay.
At 6 weeks, we remove the pull-out suture and then give him a heel raise shoe or whatever it is, sir. He can walk straight away after 6 weeks. I have seen patients, a few of my patients, one patient has participated in police march. One of my colleagues, he is a doctor, gynecology professor. He started playing tennis after 6 weeks, despite warning.
But it's a standard material. But what is the suture material you use?
Proline, sir. Proline to pull out and then to put the tendon into the tendoachilles, we use absorbable Weichel sutures, sir. 2-0 or 3-0.
Thank you, Raghurandan. It was really an excellent paper.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you very much, sir. It was a great presentation.
Thank you, sir.
Yeah. Sir, any certificates will be given to presenters? Yes, Master. Thank you. Now I request the second presenter of the session, Dr. G.V. Praveen Kumar on vascular trauma.
Good afternoon, everyone. I'm Dr. G.V. Praveen Kumar. I'm a Chief Consultant Vascular and Endovascular Surgeon at Vascular Care Center and Asian Vascular Hospitals, which is the largest vascular center in India. I'm here to present about vascular trauma, which is very important to the orthopedicians because they're the first doctors who come across these trauma patients. So it is very important for them to diagnose these vascular injuries and evaluate them properly. So what are the first signs of vascular injuries? They are usually the hard signs and soft signs. In hard signs, you see a pulsatile hemorrhage and there may be minor hemorrhage, small hematoma, and patients may have nerve injuries. Usually, the injury patterns are either penetrating or blunt injuries. Sometimes there may be a contained bleed like a pseudoaneurysm. There may be arteriovenous fistulas and also iatrogenic injuries. In penetrating usually young and healthy people, unlike patients with vascular disease who have severe atherosclerotic changes. The vessels are calcified, vessels are thrombosed, there will be microemboli, which are usually difficult to treat. But patients with vascular injuries, it is very easy to repair the damage and the results are usually very good. What are your options when you come across a patient with a vascular injury? You have to first observe the patient. You have to see look at his hemodynamics, how much blood loss is there, or whether you can ligate the vessel to prevent blood loss. Usually blood vessels like the external carotid arteries, iliac axis, internal iliac arteries, they can be ligated because there'll be good collateralization to help compensate for the blood blood flow. Usually you either do a lateral suture or end-to-end anastomosis. Sometimes you may have to put an interposition graft like an artery, a vein, and sometimes you have to put an artificial grafts like PTFE and a Dacron graft. Sometimes when the access to the blood vessel is very difficult, you have to go for an extra anatomical bypass. Like suppose there's an external iliac artery injury or an internal iliac or a common iliac artery injury, and it is very difficult to access that part. So you can just do a femoral crossover graft. And as the technology is advancing, now many procedures are coming out. These are called as endovascular procedures, wherein you can put stent grafts. It can be done in a cath lab, but usually it is minimally invasive, and patients who are already hemodynamically unstable, who are unfit for surgeries, this can be a good option. Okay, even endovascular therapies can be used in blood vessels which are very difficult to access, like the vertebral artery. During head injuries, vertebral artery injuries, they're difficult to access. So you can embolize them or coil them using endovascular procedures. Even renal artery also can be treated by putting a stent graft. What are the operative principles while treating a vascular injury? Usually you have to make sure that you get a good proximal control and a good distal control. Let me go in a stage-wise manner. Let me start with the head and neck injuries. Usually the major vascular injuries occur in 1 in every 4 patients with penetrating cervical injuries. In these patients, you have to make sure that the airway is properly secured. Asymptomatic patients with penetrating injuries in zone 1 to 3, you have, and who are relatively stable, you can do a 4-vessel angiogram so that you can assess their internal, external carotid arteries, the vertebral arteries, and also the middle cranial arteries and all that. In asymptomatic patients in zone 2, it is usually preferred you should directly go for a surgical exploration, but if possible, you can do a angiography and go ahead. In a blunt vascular injuries, usually you have time. In these cases, usually there's an intimal tear or rupture and a small clot must be formed. Okay, these patients, mostly you can treat them conservatively by anticoagulation. Next is the thoracic vascular injuries. Usually very complex injuries. They don't give you much time to evaluate also. Okay, the patients will be bleeding profusely into the thoracic cavity. In these patients, you can directly go ahead with the anterior lateral thoracotomy and find the bleeding sites. In patients where you have a rough idea of what type of vessels is injured, like in patients with an ascending aortic injury or an innominate artery injury or a proximal right subclavian artery injury, you can go for a median sternotomy. In patients with left subclavian artery and descending thoracic artery injury, aorta injury, you can go for a left thoracotomy. In patients with distal right subclavian artery injury, you can go for a mid-clavicular incision. In very rare cases, there will be a pulmonary hilar injury, wherein extremely high mortality. Usually, the patient does not survive by the time he comes to the hospital. These patients, you can do a pneumonectomy with a linear stapler. In blunt thoracic aortic injury, which is common in 10 to 15% of the motor vehicle deaths, it is usually the descending thoracic aorta which is injured, but you have to look for the associated injuries. These people usually have associated head injuries, lung contusion, other orthopedic injuries. Traditionally, you have to do a prompt operative repair for this thoracic aortic ruptures, but You can also go for endovascular repairs in patients with descending thoracic aortic ruptures. Endovascular repairs are now becoming more common in this thoracic vascular injuries. When compared to open injuries, they have lesser mortality and lesser paraplegia. But in India, there are many technical issues, like you may not get the correct sized endograft at the correct time, or the angulation of the aorta may be very difficult to do an endovascular repair. Next, we look into the abdominal vascular injuries. Usually, these also usually are very devastating. You don't have time to shift the patient also to a higher center, and he may be bleeding profusely into the abdomen. These patients, you have to just think about whether you want to do a damage control or directly go ahead with a definitive repair. But easiest thing to do is to give an incision just below the xiphisternum, and you can just access the aorta directly there, and you can put a supraceliac aortic clamp. And then directly we'll just go to the peripheral vascular trauma, which the orthopedicians very commonly encounter in their practice. In these patients, we have to first look for the neurological status of the affected extremities, their movements and all that. And also we have to assess the compartments, whether the patient has compartment syndrome or not. Most common presentation of vascular insufficiency in these trauma patients is compartment syndrome. This can be just dealt with fasciotomy, a bedside fasciotomy also. You can buy time for the patient by doing a bedside fasciotomy and then shifting the patient for an angiogram. Usually for a peripheral vascular injury, you have up to 6 hours to evaluate and go for a definitive treatment. It is advisable for every orthopedician to have a handheld Doppler wherein you can assess the peripheral pulses. Even in patients who are hemodynamically unstable or who have bled a lot and they're in hypovolemic shock, with a hand Doppler, we can just assess whether he has sufficient blood circulation to the limb or not. Arteriography or the CT angiograms or the DSA angiograms, which we regularly do to assess vascular injuries, they're indicated when the difference of blood pressure between the two limbs is greater than 10 mm of mercury. Role of arteriography in actively bleeding patients is controversial, but usually it is advisable to just know where the injury is, and so that you can intervene faster. You can save time during surgeries, and you can also prepare for other complications. And also you have to look for other soft signs like nerve injuries and all that. Usually when you come across a vascular injury with a bony injury, you have to treat bony injuries first, because without a proper bone fixation, it is very difficult to fix a vascular injury. And also you can, if you feel that the patient is going to lose the limb or something, you can put a shunt. Avoid a synthetic graft. Indian patients who undergo trauma, usually young patients, they have good native grafts like a great saphenous vein in both legs. They are very good grafts. And also you can go for radial artery grafts and also, but you have to avoid PTFE graft. And I'll just go ahead faster. Okay, and after the surgery also, you have to look for compartment syndrome. These patients usually develop what you call as a reperfusion injury, because over a period of 6 hours, the limb may not be having proper circulation, but suddenly after you re-establish the circulation, these patients develop reperfusion injury, which leads to the increased compartmental pressure. So fasciotomy, you have to learn to do a proper fasciotomy in these patients. Iatrogenic injuries usually occur when you try to place a catheter, a central line and all that. Usually these patients develop a pseudaneurysm, which are very dangerous. 90% of the cases can be treated by proper compression also. And also some patients develop arterial thrombosis. These patients have to be properly assessed, and they should be properly evaluated, and a thrombectomy should be done. Popliteal artery injury is the most common peripheral arterial injury, and next comes the brachial artery injury, which is more common in children who have supracondylar fractures. Okay, these are some of the patients. This is patients with vascular injury around the hip are very difficult to treat. This is a patient in whom we have kept a reverse saphenous vein graft, which we have harvested from the opposite leg. In this patient, we had just put a patch of the reverse saphenous vein graft into the brachial artery. This patient, actually, this patient I was called suddenly to a peripheral hospital wherein the patient had a brachial artery injury and lot of tissue loss. I had no time to assess. I just put a reverse saphenous vein graft. Afterwards, the plastic surgeon came and told me you cannot do any soft tissue cover. So it is always very important to take the orthopedician, the vascular surgeon, and the plastic surgeon also into the loop, because even after a successful vascular repair, we may lose the limb if you don't have a proper plastic cover. And always after your treatment, you have to check the pulse and all that. Thank you.
Thank you very much, sir. That's a very nice presentation. Any questions to Dr. Praveen Kumar on vascular injuries? So whenever you think of a vascular surgeon during surgery, it's a nightmare for us.
Yes.
Hope we don't need you in any of intervention, but there is some basic skills which even a common orthopedic surgeon should be able to know, at least to control the bleeding till you come.
Yes.
Keep some bullocks ready, and then that's one area. Unless we see once you operating, we don't know what all need to be kept in a situation.
Yes.
Thank you very much, sir. That was a nice presentation. Thanks for your contribution. There is a small change of order in the presentations because the same speakers are speaking in another as well. The next presentation is by Professor Lalit Miani, Management of Trauma during COVID Pandemic. I think this is going to be a recorded presentation. Lalit Miani, Management of Trauma during COVID Pandemic. Sorry. Yeah, this coming side. Both a slightly clash because his video is also there in the other hall. So once they finish there, you will come.
Hello everyone, I am Dr. Lalit Mani from Malana Medical College, Professor of Orthopedics. I will be talking on management of trauma during the COVID-19 pandemic. Definitely, the pandemic has brought a new normal to our lives, and the new normal has been ever evolving. So when it all started, we could realize that there was a need for change. Triage was a key, categorization of health facility, management of manpower, material resource management. These were the three key areas which had to be changed and had to be regularly modified according to in which part of the pandemic our region was. So I bring you the experience from a particular center from Malana Medical College. We attached to the Fnac Hospital, were running one of the largest COVID facility in the NCR, and we also had a running trauma center attached to our hospital. So we realized that standard operating protocols for orthopedic patients were mandatory, and not only mandatory, it needed a modification regularly depending upon the guidelines of the hospital, region, and the country. So it had to be a written guideline which would include each and every detail which need to be followed, from the definition of an orthopedic patient to consent form. So defining the orthopedic inpatient, so that was the key. Orthopedic OPD in our institute was stopped. However, the trauma follow-up continued in the trauma center, and the inpatients have to be clearly defined who are coming up to our institute, and they were the bare minimum which could not be tackled otherwise. Any orthopedic case who came in had to be COVID tested. It could be either negative, positive, or awaiting. And if it was negative, it would be referred to a center which was handling COVID negative patients, and our trauma center itself was one of them. And if positive, depending upon the injury, they would be taken. We had a particular written protocol for triage, and one new thing which had come in was documentation. So anything which was happening was either being documented on paper and also on Google Forms, because reports had to be generated and forwarded to the relevant authorities. We had to list our emergency surgeries, and these were them which would have to be taken even if the COVID report was not with us. And they would be taken as COVID positive. The procedures would be done by all the protocols which were at present relevant at our institute. And then once the report came, they would be segregated into either positive or negative color. Then were the emergent surgeries which had to be decided in consultation with either at least two faculty members together, whether they need to go ahead and do them, or they can be sort of halted, managed in a different way. This was subjective and needed a case-based approach. And the difference from emergent was that this, after sending the test, we would wait for the COVID-19 report, and if the report came positive, we would have to take in a call, are we going to follow the same protocol for care, or they need to be modified, and we need to wait for the patient to get negative. And the third possibility would be that we go ahead with the surgeries, but do what we do like in the emergent cases. Minor procedures were done, and they have to be done in designated ward area with all precautions and consent, and to be done under supervision. For fractures, the arm area, everything was conservative. Exceptions were open fractures, neurovascular injury, and dislocations. The forearm area, we used the hematoma block to get the closed ductions, and again, the exceptions were the same. Below elbow, the hand area, body strapping or plasters and splints were used. So practically, except for open fractures, neurovascular injury, and dislocation, upper limb was totally conservative care. Pelvic fractures, external fixators, if and when required. All other limb injuries in the thigh region, we go for a medial splint or splint with skin traction, and exceptions will be open fractures, neurovascular or dislocation. Fracture fetula would get a cylinder slab. The leg segment, limb elevation, so there is an issue, observation is required, and then care according to the fracture pattern. Foot and ankle, below, you would observe, give hematoma block, do your splintage, and then manage. Cervical spine injury, neurology was one of the indications for surgery, especially if it was a polyquina or an acute epidural abscess. Although the primary care would be on the splintage and various types of traction which can be used. So protocols were made for having special corridors between red, green, and yellow, meaning that positive, negative, and maybe gone for tested. And PP were categorized according to in positive, negative, and unknown scenarios, and all these were instructions were pasted at various places. We had an extra calculation to do on each case, and an average of 12 PP were required for managing any surgical case. Discharges had to be documented, and for follow-up, the protocol was to see these patients in COVID negative designated institutes, and if the patient didn't have a negative report, we would still come back to our place, but that would be only in specific scenarios. They were encouraged to follow up in and close to their house. Tips for orthopods: consider each patient as positive. Consent should include that COVID can be in incubation period in patient and can be transmitted to the patient from hospital environment. Treatment plan should be in consultation with the anesthetist and availability of the plan. Surgical team should be of 2 or maximum 3 experienced surgeons, not trainers. The treating team along with the patient can decide to wait upon a semi-emergency till the case becomes COVID negative. And you need to have separate teams, keep surgery time and surgical team to minimum, visitors to be minimum, all OPD patients to be screened, and interdepartmental meetings were via video conference. Investigations again had to be rationalized as much as they could be. PS to be done in bed before deciding surgical plan with the patient. And I think the take-home message would be that aim is to provide an effective, necessary treatment of patients while ensuring safety of the healthcare workers during the pandemic. We need to be prepared to cohabitate with this deadly novel coronavirus and adapt our surgical practices according to the need of the hour, minimizing surgical indications, strengthening the training in conservative principles, and following protocols indigenized for workplaces can provide optimal patient care with personal safety. So at the end, there was a need for change, and the change has been continuous. Triage has been the key, and categorization of health facility, management of manpower, and material resources has been the main crux. Thank you so much.
Thank you very much, sir. I think they don't be available for taking questions. Now I request Dr. Ajit Shinde to come on present his lecture on Let's Open for Open Fractures. Can I have the talk of Dr. Ajit Shinde, Let's Open for Open Fractures.
Make it as a full screen. No. It has to be made full, no? No. And this one.
It's full screen, Jay.
Full.
It's full screen.
Respected Chairman, my seniors, and dear friends. First of all, I like to thank Andhra Pradesh Orthopedic Society and organizers of this conference for including me in this scientific meeting. I am going to talk on open injuries, how to manage, when to manage, how, when, and what. By definition, compound fracture, commonly termed as an open fracture, is an osseous disruption in which breach in continuity of skin and soft tissue communicate directly with fracture and its hematoma. Comparing with US and European data, there are more than 4.5 million cases of open fracture occurring in every year in India. Gustulo-Anderson classification is most widely used based on size of the wound, soft tissue damage, periosteal and vascular injury, but it does not help for decision making of limb salvage versus amputation. Injury severity score, which is developed by Ganga Hospital, India, which is based on 3 anatomical structure and 4th comorbid condition of the patient. On severity, certain marks has been given, and whenever the points are more than 14, it is highly suggestive for amputation. Antibiotics plays major role in the management of open fractures. If antibiotics are given within 3 hours, the chances of infection are less. We follow this regime for depending upon grade 1, grade 2, grade 3 and contamination. The first and foremost step for managing open fracture under cover of the antibiotic is wound debridement, where all dead devitalized tissue right from skin to bone has to be removed. Remember, the first debridement is your best chance for prevention of infection. Wound irrigation is essential to reduce the bacterial load. We prefer normal saline for wound irrigation, not given with low medium pressure lavage system and follow rule of 3. Now, when to stabilize? We prefer early stabilization as it protects soft tissue, prevent further damage, restores bony limb length, reduces soft tissue dead space and thus infection. Facilitate patient early mobilization. Choice of modality depends upon bone involved, extent of soft tissue injury, degree of contamination, and physiological status of patient. Also, wound coverage, we prefer early wound coverage within 48 to 72 hours, which decreases incidence of infection and non-union. Delayed closure are prepared as per the need, either in the form of flap or skin grafting. Wax dressing reduces local edema, enhance granulation tissue formation, and obviating frequently need of plastic surgical procedures. Now, what we have done and what is our experience? This is my first patient, 26-year young engineer, was having grade 3B segmental tibia compound fracture, which was initially stabilized with the EVO external fixator and in second stage wound covered with the rotational flap and finally managed with the interlocking nailing. This is his functional recovery after 17 years. This is my second patient, a 50-year male veterinary doctor, road traffic accident on National Highway, grade 3B segmental compound tibia fracture with tibial bone loss of 15 centimeter, had been advised amputation elsewhere. This is his clinical pictures and X-ray. Primarily managed with debridement, Elizara ring fixator with planning of bone transport. Successfully managed with corticotomy and bone transport. This is his 14-month follow-up. This is his 13-year follow-up of clinical as well as radiological. And this is his function. This is my third patient, 22-year young patient, open injury to knee, lateral condyle of femur, fracture patella, and proximal tibia. After debridement, all the fractures stabilized with minimal invasive surgery, catheter screw for the lateral condyle, tension band wiring for the patella, and Elizara for the tibia. In second stage, the open wound covered with the flap. And this is his 4-year follow-up, clinical as well as radiological. And this is his function. This is my fourth patient, a 17-year young patient, road traffic accident, grade 3C injury, where distal pulsation were not palpable. There was ipsilateral distal femur and proximal tibia fracture. As previous speaker told, we done vascular injury confirmation by CT angiography. Fortunately, there was no internal injury to the vessel. It was just because of external pressure of the proximal fragment in canal. So immediately patient was taken for stabilization, joint spanning stabilization with external fixator done, and the open wound joint is covered with the rotational flap. This is his follow-up of after definitive treatment of interlocking nailing of femur. And this is his clinical picture and union. This is his functional recovery. As mentioned, the Stilo-Anderson classification does not guide for the management. It gives sometimes problems. This is a grade 1 compound patient where distal pulsation were not palpable. Patient had compartment syndrome. Immediately fasciotomy we did and got the distal pulsation. Fracture stabilized with the Elizara ring fixator. Later on, the fasciotomies were covered with the skin grafting and he required bone grafting as there was a bone loss, and ultimately we achieve union. This is a 17-year follow-up clinical and radiological pictures. This is functional recovery. This is my last patient. 45-year female police officer, road traffic accident, side shift injury, multiple open upper limb injuries, stabilized primarily at local hospital with external fixator of humerus, radius, and intramedullary nailing for ulna. Presented after 1 week with infection, necrosis of soft tissue of arm and forearm. Managed with debridement, VAC application, and skin grafting. Because of constrained skin condition, all fractures stabilized with minimal invasive surgery, interlocking nailing for humerus, and nailing for radiation ulna. This is her clinical pictures and union after 18 months. Of course, for humerus, we required bone grafting and additional plate osteosynthesis. These are her functional, this is functional recovery, clinical photograph and video. In conclusion, for better prognosis, adequate and satisfactory debridement by experienced surgical team in major OT with appropriate instrumentation and implant is preferred. Enough plenty saline irrigation with prompt systemic IV antibiotic and local freshly prepared antibiotic with prophylaxis, reduce infection and non-immune. Early stabilization and wound coverage with judicial use of back dressing and appropriate definitive osteosynthesis is essential for best functional result. Thank you for patient reading.
Thank you. Thank you very much, sir. Any questions to Dr. Professor Shinde? So you have nicely elaborated your extensive knowledge on open fractures. So there is a day-to-day problem, mostly bread and butter for any orthopedic surgeon. Any interesting questions from the audience, you can just pose the questions. If not, we thank Dr. Ajit Shinde for coming all the way from Maharashtra and participating. He has been traveling extensively across the South Indian states. For information, he is contesting for the, I think he will contact you, all of you soon. So I wish you all success for your future endeavors. Thank you very much for the kind lecture.
Thank you for this nice word and my introduction. I am Dr. Ajit Shinde, professor in orthopedic, and presently I am president of West Zone. I was president of Maharashtra Orthopedic Association for 2 years, and I organized the IOCON 2021 Goa, which more than 7,500 people attended, and even 136 people from Andhra Pradesh attended this conference, and I hope everyone is happy.
We are all very happy that you are the most luckiest person of the COVID pandemic. You are just between the Delta and Omicron break, and we had an excellent Goa conference. Congratulations for a well-done conference as well, sir.
I expect same faith and support from all of you. Thank you very much.
Thank you, sir. Thank you very much. Next, again, there is a slight change of order in the presentations, and I'll call upon Dr. Vijay Jain, Professor Vijay Jain, musculoskeletal manifestation of COVID-19. I guess it's also a recorded video. So Vijay Jain.
Hello everyone, my talk is on musculoskeletal manifestation of COVID-19. This is the overview of talk. As we all know, the COVID-19 is a predominantly respiratory illness, but the cardiovascular system, neurological system can involve, because of the direct entry of the virus into the cell, the multiple organs can be involved and the musculoskeletal system is not immune. The musculoskeletal symptom in COVID-19 can occur during the acute stage or may occur after the recovery of the patient. We call it as a musculoskeletal post-COVID pain, which occurs beyond 4 weeks, and the long COVID. In acute phase, there is a new onset of myalgia, joint pain, back pain, and muscle weakness are present. And in the post-COVID phase, these symptoms may be, person may have demonstrated ongoing symptoms, and then they may have increased severity of the previous symptoms, or new symptoms can occur, which comprises of fatigue and the joint pain. So and then long COVID, in which the patient may have pain, musculoskeletal symptoms can occur after the 8 months or the 12 months of the COVID-19 infection. So the patient can also develop the ICU-acquired musculoskeletal symptoms, which can occur at least 14 to 75% of patients, and they develop because of the immobilization in sedated patients, which are on ventilations, and these patients develop weakness, contraction, and the shoulder stiffness. So as we all know, the pruning is one of the methods to improve the ventilation, and the pruning associated complications can occur, which includes the brachial nerve injury, joint subluxation, and soft tissue damage. Further, the medication which are commonly used to treat the SARS-CoV virus, that includes interferon, which can cause arthralgia and myalgia. The corticosteroid can cause the muscle weakness and atrophy, and they also cause the decrease in the bone density and osteonecrosis. And then the ribavirin can also cause the arthralgia. And the musculoskeletal symptoms can occur in patients who take vaccine for the prevention of the disease in the form of a vaccine-related shoulder injury. So the period of the long activity, lack of sunlight, and lack of exercise during COVID-19 can also precipitate the musculoskeletal manifestations. The patients who are at risk can be obese, or patients who are comorbid, elderly, female patients, and patients who have a long rheumatoid disease or low vitamin D deficiency. The genetics may be a factor for some of the patients. So we have recognized musculoskeletal manifestations, which were published in several papers, and then we compiled the results and published this paper in our association journal. And WHO also declared that some of the musculoskeletal associated symptoms are related to the severe COVID-19 infection that includes fatigue, myalgia, or arthralgia. This study by the Jacob et al. Showed that one orthopedic manifestation is present in at least 27% of patients in their population. So in post-acute COVID-19, after the 4 weeks, patient may develop fatigue, decline in quality of life, muscular weakness, and joint pain. The long COVID has been recognized by us, and then we published this paper. The patients also develop fatigue, dyspnea, exertional joint pain, tiredness, and they have sleep disturbances. So the long COVID-19 is thought to be a new challenge to the public health, because the health system is already compromised, and now we are dealing with the routine cases as well as the patients who have long COVID symptoms. So if we see for the COVID-19 illness in a critically ill patients, because of the impaired pulmonary function and deprived in the oxygen in the skeletal muscle, and due to that, there's an increase in the lactic acidosis, which causes muscle pain and weakness, and the hypoxia inducible factors can induce the fibroinflammatory pathway and cause myalgia, arthralgia, and other musculoskeletal abnormalities. The musculoskeletal symptom comprises, which can be manifested in 1/4 to 1/2 of the symptomatic patients, and they are in the form of fatigue, myalgia, arthralgia, transient synovitis, back pain, and these symptoms are present early in the course of disease. They are not severe, but they can be disabling. Chronic arthritis has been reported in about 37% of patients by the paper by Taha et al. And adhesive capsulitis after COVID-19 infection could be could be present, and it has been published recently. Other musculoskeletal symptoms include the sarcopenia, which is age-related decline in the muscle mass, limb gangrene, pressure sores, COVID-19 toes, which can occur because in which one or more toes can be swollen and turn pink, red, purplish color, and osteonecrosis and osteoporosis are due to the medication used during the COVID-19. So it was previously thought that the SARS-CoV virus induces the inflammation and cause problems in the skeletal muscles and bone and joint, but later on it was shown that because of the ACE2 and transmembrane proteaceline expression receptor, which are most expressed in the skeletal muscles and synovium, which allows entry of the virus into the host cell and can cause inflammatory response, dysregulated or accelerated immune response, or there may be the direct viral toxicity or endothelial cell damage, which could lead to the musculoskeletal problems. And if we see for the osteonecrosis, the corticosteroid act as a double-edged sword, which can improve the symptoms of the COVID-19, but can cause osteonecrosis. The SARS-CoV infection can also induces the hyperinflammatory state, can cause arthritis, and hypercoagulable state, which causes micro and macrovascular dysfunction and decreased blood flow to the femoral head. But in these cases, the genetic factors may have some role, and the dose of the corticosteroid or duration of the corticosteroid, whether these are responsible for the osteonecrosis, is yet to be proved. So as we know, in the SARS-CoV-1, there was the incidence of the femoral head necrosis was 29%. And so we can predict that these COVID-19 patients, which have some median exposure of the glucocorticoids, may develop osteonecrosis. So early screening protocol and early intervention in these patients are required. And this algorithm has recently published, which shows if the patients on glucocorticoid has taken no glucocorticoids, they can be follow-up. And if there's any symptom arises, they can be undergo MRI. But those patients who have taken the methylprednisolone in a lower or higher doses than 2000 milligram can be regularly or intensively followed. So these are the cases, these are the papers coming up these days in which the COVID-19 patients have developed the avascular necrosis. So why we should worry for the musculoskeletal problem? Because these patients are usually elderly, middle-aged, and have comorbidities. There's an increased consumption of the NSAIDs, and there's a surge of the osteonecrosis patients. So for these, we can investigate to rule out other rheumatic cause, and fatigue scoring can be done. Inflammatory and infective markers can be performed to rule out the infection and inflammation. Synovial biopsy, muscle biopsy, joint root analysis has role, but till date, no study has been done to find out the cause, to find out the extent of the damage. The imaging has some role. A recent paper showed that the role of MRI, ultrasound, and CT scan to investigate patients for the musculoskeletal problems. And the management of the musculoskeletal symptoms can include online therapy, especially in patients with the acute COVID-19, in order to avoid face-to-face consultation. Role of the NSAIDs, which includes COX-2 inhibitors, which are safe to the patients, can be given. Opioid should be avoided because they can cause respiratory depression. Other things like nutraceuticals like vitamin D, nutritional supplement, omega-3 fatty acid can be given. Anabolic supplements have role in patients with the sarcopenia. Protein-rich diet should be given in order to avoid the long-term disability. Surveillance of the symptoms should be done, and exercise-based regime should be performed in order to reduce the stiffness and disuse atrophy. There's a role of physical therapy. These patients require long-term orthopedic rehabilitation and psychological consultation. So holistic treatment plan is required in these patients, which comprises of biopsychosocial support. And so in conclusion, the MSK symptoms not immune for COVID-19, various symptoms like can be there, which can be chronic or disabling. Identification and management of osteonecrosis is challenging. Early screening is required in order to prevent the disease, and holistic approach for the patient care is needed. Thank you.
So thank you very much, sir, for the presentation. I think we will move on to one physical presentation next by Pre-Operative Management in Prospective COVID-19 Pandemic. Pre-Operative Management in Perspective to COVID-19 Pandemic by Dr. M. Vamsi Krishna. So we will be jumbling one recorded and one physical lectures.
Good afternoon to the chairperson and good afternoon to the seniors and the colleagues and students who are here. Basically, I'm an anesthetist and intensive care specialist working in a 150-bedded hospital at Sangamitra Hospital, Ongole. I have been working there since 10 years. In the past 2 years, our hospital almost treated more than 2,000 COVID patients, out of which our hospital became the highest referral center for critically ill COVID patients. We are proud that we have treated more than 300 patients invasively ventilated. Out of them, around 50 patients were tracheostomized. In the first wave, because of lack of knowledge or understanding of the disease, the mortality rates were high. Whereas coming to the second wave, we got very good understanding of the COVID pathology, how that behaves. And even the ventilated patients, our recovery rates were more than 60%. With this, we have little small experience for intraoperative management or perioperative management of COVID also. We all know that around, as per the official government statistics, around 5 crore people in India were infected with COVID. And it is not only Indian newspapers, this American New York Times has mentioned that in India, for every one patient which was reported with COVID, 10 to 12 patients were not reported. Means that around 50 crore population were maybe affected with COVID, which is almost 1/3 of Indian total population. And the problem with COVID is again and again people are coming with reinfections. Vaccination is not been protective. So nowadays, in future, for at least next coming 12 months or so, it is not quite uncommon that we come across patients who were suffering from COVID or who may recover from COVID with recent history. And out of these COVID patients, we know that around 3 to 4% will become moderately or severely ill. And the pattern of the disease also is varying from time to time, and means wave to wave. And we as anesthetists and surgeons, we always have dilemma how to diagnose the COVID, whether to go for diagnostic investigations in the perioperative period at all if the patient is asymptomatic, or which diagnostic techniques. No test is 100% specific or sensitive to diagnose COVID, whether it is RT-PCR or antigen or HRCT or clinical. And when to go for surgery if the patient is having active COVID disease or patient had recovered from COVID with recent history of hospitalization, and what to do in the perioperative period. There is little dilemma for every one of us. And one study which is published in 2021 Jan has mentioned the mortality rates were significantly high for those who underwent surgeries with COVID active disease, which is almost 16%. Whereas in non-COVID group, it is around 1 to 2%. And the morbidity, again, the morbidity is either shock or respiratory failure or pneumonia or ICU stay or renal failure is also very high. This is almost more than 10-folds high compared to the non-COVID group. This study is mainly concentrated on around 140,000 surgeries which underwent for the patients who are having COVID active disease. So at our hospital, we did around 120 surgeries for those people who are having active COVID disease. But most of the surgeries were either cesarean sections or tracheostomies for those who require prolonged ventilation. But few surgeries like EDH or amputations for the necrotizing fasciitis or vascular injuries, compound trauma, external fixators, we did few surgeries, but their number is less than in single digits. So we found there is no attributable mortality associated with anesthesia or surgery, at least for the mild to moderate severe surgeries. One patient I will tell you an example. One patient we operated for the CABC. After third day, patient developed fever, and slowly again with good LV function, no identifiable cardiac cause, he is developing hypoxia. We did again rapid test, which became COVID positive. The attendants complained to the district collector, all authorities regarding the same issue. They tried to sue us also. Then we have gone through what are the guidelines available. What are the guidelines available for testing in the pre-operative period in the COVID pandemic? And what are the guidelines available to take up the surgery? Then the same guidelines what I mentioned already again, regarding intraoperative management precautions and all the things the previous two speakers has mentioned. I mainly stress here only the guidelines available and what is that guidelines available with the American Society of Anesthesiologists and the same guidelines which were adopted by the Indian Society of Anesthesiologists. I will stress here. They mentioned that wait for few weeks after recovery for non-urgent surgeries or elective surgeries. Wait for few weeks in the sense, again they categorize patients who recovered from mild disease or without any symptoms. Wait for 4 weeks. Again, 4 weeks time for an elective surgery is a little bit long. The reason also they mentioned that I will explain later. Whereas they mentioned that wait for 6 weeks for those who required hospitalization, but they did not require any non-invasive ventilation or so. And they and 8 to 10 weeks to be waited for those who are severely infected and required ICU admission, and the people who have comorbidities also, particularly those who are elderly or uncontrolled diabetes or some other immunocompromised issues also. And they had 3 months to be waited for those who had admitted in ICU with invasive ventilation. The rationale also I will tell. And you all know what are the emergency surgeries and what are non-essential emergencies. This is the rationale for this guidelines to be framed is following the pattern of inflammatory markers in the COVID. Here they compared the pattern of the inflammatory markers for those who recovered without any symptoms and those who recovered are after invasive ventilation or who landed into mortality. For those who recovered, and the parameters they observed is the D-dimer, LDH, lymphocyte counts, and troponin T, which again are troponin I or troponin T, which again shows the coagulation cascade, and renal parameters. For those who recovered without symptoms, the inflammatory markers has risen to peak levels in the 2nd week and started coming down to normal levels in the 3rd week. So the rationale for waiting for 4 weeks is that it takes at least 3 weeks for the inflammatory markers to come down. And surgery again contributes to the, we all know that surgery alters the inflammatory response and again can activate the coagulation cascade and cause prothrombotic complications. For those who recovered from severe disease, it almost for 4 weeks, there is still rise in the inflammatory markers. So it is better to wait for at least 8 to 10 weeks for those who recover from severe disease. This is the rationale for waiting for at least for elective surgeries. Whereas another dilemma is whether to go for routine PCR testing or HRCT in the pre-operative period is again a mandate. We all know that by this time, even with the patient who recovered from COVID without any symptoms, their PCR is positive for at least 2 to 3 weeks. So CDC or even ICMR recommends for those who became positive at one point, no need of repeat testing for at least 90 days, 3 months. That is clear cut. Even ICMR also has advised. Only RT-PCR is advised in the pre-operative period for those who don't have COVID and who never diagnosed with COVID in the last 90 days, or those who have significant symptoms, fever, cough, or any symptoms of the COVID. They only require either RT-PCR or antigen testing. No routine testing is needed. And there is one clause that when there is active pandemic going in the geography area, suppose there is active wave is going, then routine testing can be done in such scenarios. And HRCT also, no routine HRCT is indicated. The rationale for this is only one thing. HRCT will become positive after 5 days or 6 days after the antigen or PCR becomes positive. HRCT signs take some time later. And HRCT overdiagnosis the COVID. So patient who require surgery may go for postponement. So HRCT is not routinely advised. It is only advised in scenarios where patients who recovered from very severe disease to know their lung condition, HRCT test is advised, are those people who PCR is negative and have strong symptoms of the COVID. There we can go for HRCT to know whether there is COVID or not. Out of all this, proper history is very important. Proper history regarding their previous COVID infection, their hospitalization pattern and length of hospital stay, their investigations to be followed, and their vaccination status is very important. And functional assessment will give very good idea. And again, I am stressing that high-end investigations were advised only for those who recover from severe disease or who require major surgery. Otherwise, no high-end investigations like HRCT or inflammatory markers to be done in the pre-operative period. We all know in the pre-operative optimization period, vaccination is advised. If vaccination is done, wait for at least 2 weeks for the immune response to develop under this thing. All anticoagulant stoppage guidelines are as per the previous protocols. Particularly oral anticoagulant usage is now very high. So wait for at least 72 hours after stopping the oral anticoagulants, and steroids has to be continued. For mild disease, there is no specific intraoperative or perioperative change planning is needed. For those who recover from severe disease, invasive hemodynamic monitoring is needed. In the post-operative care, the main concentration is to decrease the inflammatory response, that is pain. Pain and proper sedation and angiolysis is the only management, specific management. In conclusion, I stress that there is no routine PCR testing is needed when there is no active pandemic is there. HRCT has got very limited load in the pre-operative period. Wait for a few weeks after surgery, and only for those who recover from very severe disease, they need meticulous planning. These are the guidelines that are available. They may change with variant. Okay, thank you.
Thank you, sir. Thank you very much, Dr. Vamsi Krishna. Any questions to Dr. Vamsi Krishna on intensive care management? Looks like all are exhausted of 3 days of heavy scientific sessions. Thank you very much, Vinod Kumar. There is a lot of insights in your presentation. Thanks for coming over and giving the lecture in a non-anesthesia form. Yeah. Thank you very much.
Thanks.
So now I request Dr. Vinod Kumar to speak on role of L0 in management of skin defects.
Respected chairman, seniors and my dear colleagues, good afternoon everyone. At the outset, I would like to thank OSAP and Prakasham Orthopedic Association for giving me this opportunity and conducting an excellent scientific session. Usually, most of the times, we, in our day-to-day practice, we experience some kind of delayed wound healing or wound necrosis, or sometimes these can be healed with a local debridement, IV antibiotics, but sometimes it will be challenging if they doesn't heal. In this presentation, I would like to tell how to manage these wound gapings or wound delayed necrosis by the use of L0. First of all, I would like to salute the genius who discovered this procedure. He is none other than Professor Gabriel Ambroich L0. He had a good number of cases, more than 1,000 cases he has done during the Second World War. And based on his work, Russian government has started a biggest orthopedic hospital in Kurgan, which is Russian L0 Center, and restorative traumatology and orthopedics in Kurgan. It's a 800 bed hospital, which is exclusively for orthopedics. It contains 20 departments and has 45 operating rooms. It has its own experimental animal lab and also own factory for implant manufacturing. During his work, Professor Iljaro discovered law of tension stress, which says that gradual traction on the living tissue creates stresses that can stimulate growth and regeneration of certain tissues. The principle behind this is slow and steady traction on some tissues makes them become metabolically active, which increases in proliferative and biosynthetic function. For this, it needs adequacy of the blood supply for the tissue to be that is being elongated, and also there should be some stimulating effect like weight bearing and functional use. Based on this, he postulated distraction osteogenesis, which says that mechanical induction of new bone formation between bony surfaces that are gradually pulled apart. She produced this by local special corticotomy and controlled it by externally by ring fixator. This achieves local neovascularization, which produces fibrovascular interface, which aligns parallel to the direction of the distraction over which new bone columns are added. So he has applied these new bone formation techniques to treat non-unions, limb lengthening, and deformity corrections by longitudinal distraction. Once he did it, then he had got an idea of transverse distraction or healing of the non-unions, non-healing wounds. So he developed this technique as transverse distraction for the treatment of peripheral vascular disease. Then he has given this role of soft tissue osteogenesis with the Iljaro. He says that under the influence of tension stress, active osteogenesis takes place not only in the bone but also in the soft tissue. So, there are few papers from India also. There is one paper by Dr. Jagdish and Dr. Ajay, who has treated more than 60 cases of Berger's disease, and they have healed non-healing ulcers in the foot due to peripheral vascular disease. There is another paper from hospital for special surgery, where they have used the Iljaro method for wound closure and bone union of a non-union open grade 3B tibia fracture. And they said that this technique of bone and soft tissue transport may prove useful in the treatment of tibia fractures with difficult to close wounds, and also for patients who are not candidates for flap coverage. Here is another paper from Hospital for the University of Pennsylvania by Dr. Christopher Bibo, who had also successfully treated many traumatic soft tissue defects by Iljaro. So how it is done? So usually, if there is fracture, is there 2 rings above and 2 rings below, the fracture site should be applied, and the distraction osteogenesis started 5 days after surgery at the rate of 1 mm per day in equally divided 4 times. Each time one should distract at 90 degrees, followed by acute compression. The next day, if there is pain, you can divide it that acute compression in 2 days, and then you can repeat the distraction cycle if the wound doesn't heal. Here are the examples which I'd like to present. Here is a 58-year-old male who had grade 3B open tibia fracture, and he had been operated with debridement and external fixator as applied elsewhere. And he presented to me at this stage because the wound is not healing till 8 to 10 weeks. It's like that only. So I removed that screw and also the external fixator, kept Iljaro, and distraction started after 5 days. The 2 cycles of compression distraction done, and the fracture healed in 6 weeks. And this is another case where a 69-year-old male who had RTA and run over by vehicle, he had grade 3B tibia fracture, for which Iljaro was applied as primary surgery itself, because the skin condition is not good. So, like that early, the wound necrosed, and distraction started at day 5 at 3 to 4 weeks. I think there is a slight improvement in the wound healing. So distraction cycles continued, and at that 3 months the wound healed, and also the fracture healed after 7 months. This is another 50-year-old female who had ONE due to non-union of the distal femur, Hoffa's fracture, for which hinged TKR was done elsewhere. But unfortunately, the wound doesn't heal, maybe because of incision. And for her, the plastic surgeon people did a good flap cover, but unfortunately, within 10 days, the flap also necrosed, and the primary surgeon advised amputation, and she came to me at this stage, and even I also advised amputation, but they were reluctant to go for amputation. They want the salvage the surgery. So I have done thorough debridement, removed all the implants, and after removing, there is almost 30 centimeters medial to lateral defect, and anteroposteriorly almost 20 centimeters defect was noted. And after removal of the implants, there is almost 3 finger breadth defect is there. So acute docking was not done. And the skins, as it is, they are approximated, and stage sutures were applied, and compression started at day 5. Unfortunately, the primary cultures were negative, but the second time we have sent cultures, and the E. coli was reported, and antibiotics was given accordingly. At day 21, this is the picture. The distraction cycles continued, and at 80 days, the skin healed, and also the arthrodesis is consolidating. So in my hospital, I have done 10 cases of cases like this. 8 healed well, and average wound healing time is 45 days, and 2 have undergone amputation because of severe sepsis and uncontrolled diabetes mellitus. So to conclude, Ilgero can be considered as an option for management of these skin defects where flaps are not feasible, and in cases of flap necrosis. And one should select the cases before going this procedure. Thank you one and all for your patient hearing.
Thank you, Vinod. So wonderful presentations. I had few cases before. Anybody want to ask a question to Vinod about the skin defects managed by Ilgero?
Nothing.
Yeah.
If no one has any doubts, I think we'll proceed with the next case. Before that, I think let's felicitate all our speakers before we go to the video session. Can I call upon Dr. Raghunandan Garu?
So one more talk is there, sir. 3D printing in orthopedics. There is one more talk is left over.
That is online. Video presentation.
Yeah, there is a video presentation. And I think 4 sessions, 4 talks, we have time. So there is so after this talk, we'll have all the speakers and
hello everyone. Today
yeah,
I'm presenting this experience on 3D printing and adding creativity, and I see it as a future of orthopedics. I'm Dr. Lalit Maini. I'm a professor of orthopedics at Maulana Azad Medical College. So that's a jalebi being made. That's a popular dish in North India, in which the jalebi is actually the 3D printed object. The hand of the person is the printer, and the brain is the computer and the design which we give to the printer. So this is the most simplistic way of explaining how 3D printing is done and what happens with 3D printing. So to give a better schematic diagram, you can see on this, there are 2 layers of diagrams. The top one shows you the traditional way of manufacturing, in which you used to subtract a design out of a block of material. And the new way is additive manufacturing, in which you just layer in and create an object. On the extreme right, you can appreciate the difference in the waste. Let's explain it the orthopedic way. So if you have to make a femur bone, if you do a subtractive manufacturing, you will take a block of material and you will chisel it out into the femoral shape. However, in additive manufacturing, you go bottom-up process and you gradually layer up the femur and practically have absolutely no wastage of material. So let's look into the basic steps to do 3D printing. If you have to start it as a hobby or start applying it into your practice, you need to choose a software. You need to do some virtual planning, make a STL file, or if you can't, you can download certain free STL files, which I'm showing you here from the internet, and practice your hobby or get to understand. So you need to load the printer with the spool of material. There could be various materials which could be used. And the printers which are handy, the FDM printers are like a microwave in which the material is loaded into an extruder, which is at high temperature, and it melts the plastic. You transfer your design, the STL file, to a printer by directly connecting it with your computer or through a memory stick. Once you've done that, and you enter, and the printing starts. Now, printing begins with additive manufacturing. That means it goes layer by layer. The Z-axis could be the nozzle moving up and down, or it could be the whole platform which moves in one direction, and the nozzle in X and Y. So it's an easy thing to understand in this way, and if you start applying it, you will realize that it is a very useful tool which you can use in your orthopedic practice. So at the end of the day, you need a software, a hardware, which is a printer, and the material which you choose. There is some amount of post-processing which is required, and then you have the final object. Of course, you need training, you need skill and experience, which comes by using this particular technology more and more. 3D printing has gone through a huge evolution. And to start with, it was a huge sort of a setup with a very small printing area. And the difference between the normal printer and the 3D printer is this, that you print out an object which is three-dimensional, and it can be used for many utilities. The most extreme application would be bioprinting, which is now a reality. And long strides have been taken in this research also, and various researchers have achieved various types of tissues which have been bioprinted. So various applications in orthopedics, they can be used for surgical planning, corrective osteotomies, in trauma, tumors, arthroplasty. It can of course be used for research, academics, and display, and doctor-patient interaction with 3D models. You can really explain to your students as well as your patients the disease you're handling, and it gives a real good understanding even to the surgical team. So here's an example how you go about the virtual planning. It starts with a CT scan in which you try to extract whatever bone you want to work on, you're interested into. Here is a patient of a chondrosarcoma of the iliac bone. And here is an MRI now. We took the CT and now we're taking the MRI images. We are marking the tumor, we're taking the soft tissue component from the MRI and extracting it and transferring it into a software where you can fuse both the CT and the MRI. So the possibilities are immense. You can fuse MR with PET CTs, you can fuse PET CTs with CT scans, and then you can have your absolute accurate 3D model on which you can do your virtual planning as well as surgery pre-operative. So once you've got the fused model, you can easily make out the margins where the tumor exists, and then mark it out using your surgical planning tools on where should be the resection margin to give you an absolute R0 resection. So you can print a 3D template, which ultimately can be used intraoperatively to guide your saw and your guide wires to do your surgical cut. So this is what has been done in this patient, in which the acetabulum could be saved and the surgery time could be reduced just because of the understanding of the whole disease which we were dealing with. The applications today's day are immense in orthopedics, from planning of complex trauma to correction of deformities to creating customized solutions for bone tumors to placing pedicle screws through guided jigs which can be printed by 3D printing to totally surgically simulate a surgery preoperatively, both virtually and on models like in the chondroblastoma shown below. So here is a video which takes you further into the future, an example of a bone tumor in which you scan the limb, you acquire the data, you plan your resection. The resection plan can then be transferred to a robotic arm. which can then use that data to do an accurate resection of the tumor intraoperatively, which allows you to give a limb sparing as well as joint sparing surgery. The resected model can be very quickly scanned intraoperatively, and the same data can be sent for creating a solution which can be reimplanted within the OR. So the planning is transferred to an ultra high speed printer, which creates a hydroxyapatite scaffold. It builds it up by additive manufacturing in a sterile environment, and you can reimplant it and add biologics to the whole reconstruct. And the ultimate bioprinting, this is a bioprinting video in which you use a bio ink, which is laid down according to the structure you want to make, and you can make a scaffold which has live tissue inside, the cells inside, as well as the scaffold. So evolution of bioprinting has gone a long way from the 1980s to the present structure, where people have even made human heart tissues which have been reimplanted in experimental labs. Thank you very much for your attention. And if you want to see and learn more, you can visit my YouTube channel, Ortho-60. Thank you.
Thank you very much. I think this closes this session. I think we have successfully completed all the scientific sessions of the day.
And in time also, sir.
So there are two sessions, other session is going on in Hall B. Once that is over, we will have a valedictory function. Meanwhile, the organizers can arrange the arrangements for valedictory function.
Shall we call the speakers?
Yeah, you can call the speakers. I request all the organizing committee members of Ongole Orthopedic Association, Prakasham Orthopedic Association to assemble for a valedictory function. Yeah.
Yeah. Before that, let me invite all the speakers of this session onto the dais and kindly accept our a token gift and a certificate of participation. May I invite Dr. Raghunandan sir from Kurnool, Dr. GV Praveen Kumar Garu, Dr. Ajit Shinde if he is here, and Dr. M. Vamsi Krishna, Dr. Vinod Kumar. Five certificates, 5 roses. Sir, please come on to the center stage. Thank you. I invite all the speakers to come here, so that we can have a photograph too. I request our secretary, organizing secretary, to hand over all the certificates to the speakers. Can we have a group photo, please? Cigar. Group photo, sir. Sir, Vinod Kumar, right. Right, thank you. Thank you all. Sir, I request Dr. Raghunandan sir to felicitate our chairperson with a shawl. దాంట్లో మీ సింబల్ కూడా ఉంది సార్. Right, thank you. So Ajit Shinde sir, please come. Sir Naresh sir వచ్చారు. Sir, come on, sir. Thank you, Ajit Shinde sir, for having come all the way from Sangli. So we have 2 more scientific sessions going on there. Probably in another 20 minutes, we will be starting our valedictory function. Almost an awaited function for all the aspirants who are aspiring for last year's prizes, and some results of today's PG's quiz also will be declared today. So kindly be seated here. After that, we can proceed towards lunch. I request all our state OSAP committee also to be there. And finally, I request all our committee to be in this hall, not to run around anywhere, so that we need not contact them again. So if anyone is there in the hall, be kindly ask them to be here in another 10-15 minutes. Kindly register yourself as members to OSAP and IOA. It's just near the entrance of trade stalls. And kindly correct your monograph also, the postgraduates. If anyone is interested in the membership, please go ahead, today itself, because you will be eligible for voting in the next year's elections for IOA and OSAP.
Long live OSSAP.
As strong as healthy bone, though flexible as oil, it's all because of you. We are made but for you. We love OSSAP, long live OSSAP. We love OSSAP, long live OSSAP. You passed us the wisdom of our seniors. You taught us how to treat a junior. We are the babes of you. Privileged to sing for you. We love OSSAP, long live OSSAP. We love OSSAP, long live OSSAP.
Long live OSSAP.
As strong as healthy bone, though flexible as oil, it's all because of you. We are made but for you. We love OSSAP, long live OSSAP. We love OSSAP, long live OSSAP. We are the babes of you. Privileged to sing for you. We love OSSAPCON. Long live OSSAPCON. We love OSSAPCON. Long live OSSAPCON. Long live OSSAPCON. As strong as healthy bone, though flexible as oil, it's all because of you. We are made but for you. We love OSSAPCON. Long live OSSAPCON. We love OSSAPCON. Long live OSSAPCON. You possess the wisdom of our senior. You taught us how to treat a junior. We are the babes of you. Privileged to sing for you. We love OSSAPCON. Long live OSSAPCON. We love OSSAPCON. Long live OSSAPCON. Long live OSSAPCON. wisdom of our senior. You taught us how to treat a junior. We are the babes of you. Privileged to sing for you. We love OSSAPCON. Long live our OSSAPCON. We love OSSAPCON. Long live our OSSAPCON.
Long live OSSAPCON.
As strong as healthy bone, though flexible as oil, it's all because of you. We are neighbored for you. We love OSSAPCON. Long live our OSSAPCON. We love OSSAPCON. Long live our OSSAPCON. You passed us the wisdom of our senior. You taught us how to treat a junior. We are the babes of you. Privileged to sing for you. We love OSSAPCON. Long live our OSSAPCON. We love OSSAPCON.
Please switch off the music. Thank you. Now, coming to the last part of the conference, this is a valedictory function. And in this function, many exchanges will take place. And these are the moments we have to cherish till the next conference. So this, I shall invite the OSSAP president onto the dais, Dr. Durga Prasad Garu. I request one of the members from my team to come over here, please. I request Dr. Jayshekhar to on the stage. Receive Jayshekhar. Okay. Next is, I'll call upon our, the President-elect, Dr. Dharmarao Garu, onto the dais. As per the protocol, next let me invite our beloved General Secretary of OSSAP, State OSSAP, Dr. Naresh Babu Garu, over to the dais, sir. Okay. Incoming president. May I invite Dr. V.V. Narayan Rao Garu, the incoming president of OSSAP. Incoming president-elect. And want to invite our beloved secretary, organizing secretary of the OSSAPCON 2022. Today, our the organizing chairperson couldn't make it to the valedictory function as he is held up with his personal program. And I invite upon our secretary to have his words to the.
Thank you very much, sir. Indeed, all good things must come to an end at some point in time. So this is a wonderful conference. For the past 3 years, we cherish the hospitality of Prakasham Orthopedic Association, the excellent scientific program, hospitality, food, entertainment, and the personal touch. That is the tagline of this year's conference. I can confidently say you can touch any delegate who attended the meeting. They would always, they watch to say that this meeting has a lot of personal touch from all the members of Prakasham Orthopedic Association. It's something like they are doing a family function of their own association. So there's a big round of applause to all the members of Prakasham Orthopedic Association. It couldn't have been possible with the unity and the confidence what you have bestowed on your seniors, and taking the responsibility and feeling it is something to do with our association is something which is a commendable job by the Orthopedic Association of Prakasham districts. So coming to the events which we are going to follow in this valedictory function. So I will be announcing the results of competition, scientific competitions held during the meeting. and then we'll have message from our president, and then our secretary, organizing secretary, and then we have a change of medallions of president to president becomes past president and president-elect becomes president, and then incoming president-elect will take over as a president-elect of our association. And then we'll have some expressions from the participants here. So we are waiting for the Uday Kumar sir to come and declare the few results. Meanwhile, can I ask Jay Shekhar sir to come and give the Joint Secretary's message. So if he's taking time, and I'll ask our president to give the message. You can say there.
I profusely thank Prakasham orthopedic team for conducting this. There are some good achievements done. I mean, some milestones. We have crossed some milestones during my tenure, conducting OSSAP fellowships and some sports activities. This year went very well. We have been able to conduct mid-year CME, all the activities throughout the year. Though because of COVID, some activities may be happened, but we have done almost all the activities. I am very thankful to my team of executives, OSSAP executives team, and Prakasham Orthopedic Association has done excellent job conducting this OSSAPCON at Ongole. I personally thank Dr. Malleolus and Dr. Jay Shekhar, and excellent conduction of scientific events by Dr. Amarnath Reddy. And I request my incoming president to discharge the duties as well. Thank you. Thank you for doing.
So thank you, sir. Thank you very much. I will request our president-elect to give his expression of how the meeting was conducted. We'll get your president's message later, sir.
Respected President and Secretary and Organizing Chairman Dr. K.C. Malleolus and Dr. Jay Shekhar, Secretary, and the Prakasham Organizing Association team. I really impressed, very much impressed with the organization. These two persons, along with the Prakasham Association team, conducted a successful conference excellently, because the post-day CME program, Ithirajulu CME program, if we attended here, it is almost equal to the standards of national levels by the faculties of versatile wisdom. If we enjoy it, really, we impressed like that. We'll be impressed like that. So it is really a great wonder. Even though there is no medical college here, with the mere 40 people of orthopedic surgeons, they conducted with their limited resources. They conducted successfully the memorable Silver Jubilee Conference. We're really very grateful to them, and we very much thankful to them. Wish you in future, wish you all to conduct the same events in future, sir, successfully. Wish you good luck, sir.
I request Dr. V.V. Narayan Rao Garu also to have his speech, please.
Good afternoon, everybody. I will say only one thing about this conference. This is a most memorable one, and I wish all the best. Thank you.
So now the most important part of the program, that's installation of our president-elect into the president. But before that, ఆ కార్యక్రమాన్ని ఏ విఘ్నము లేకుండా ఆ ఇంటి గృహలక్ష్మి గారే వచ్చి విఘ్నం కోసం ఒక దేవుణ్ణి పూజిస్తూ ఒక పాట పాడతారు. ప్లీజ్ వెల్కమ్ మిస్సెస్ జయలక్ష్మి గారు. షీఈస్ వైఫ్ ఆఫ్ డాక్టర్ ధర్మారావు గారు, who is going to be installed as a president of OSSAP for this year. అండ్ మేడం గారు మీ పాటతో అన్ని విఘ్నాలు తొలగిపోతా ఉండాలని కోరుకుంటూ, అదే మీరు కూడా ఆ పాటలో
वातापि गणपतिं भजे हम, 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 वाराणस्यं वरप्रदं हम, वाराणस्यं वरप्रदं श्रीवातापि गणपतिं भजे हम, भूतादिसं सेवितचरणं, भूतादिसं सेवितचरणं, भूतभौतिका प्रपञ्चभरणं, भूतादिसं सेवितचरणं, भूतभौतिका प्रपञ्चभरणं, वीतरागिणं विनुतयोगिनं, वीतरागिणं विनुतयोगिनं, विश्वकारणं विघ्नवारणं, वीतरागिणं विनुतयोगिनं, विश्वकारणं विघ्नवारणं, वातापि गणपतिं भजे हम, पुरा कुम्भसम्भव मुनिवर प्रपूजितं त्रिभुवनमाद्यगतं, मुरारे प्रमुखाद्युपास्थितं, मूलाधारक्षेत्रास्थितं, परादिचत्वारि वागात्मकं, प्रणवस्वरूप वक्रतुण्डं, निरन्तरं निठलचन्द्रखण्डं, निजवामकरविद्रुतेक्षुदण्डं, कराम्बुजपाशबीजपूरं कलुषविदूरं भूताकारम्, कराम्बुजपाशबीजपूरं कलुषविदूरं भूताकारं, हरादिगुरुगुहतोषितबिम्बं हंसध्वनिभूषितहेरम्भं, हरादिगुरुगुहतोषितबिम्बं हंसध्वनिभूषितहेरम्भं, वातापि गणपतिं भजेऽहं, वाराणस्यं वरप्रदं श्रीवातापि गणपतिं भजे हम.
Thank you. Thank you, the First Lady of OSSAP. మేడం సార్, అసలుకి ఈ గాత్రం వింటే మీకు ఎప్పుడన్నా కోపం వచ్చినప్పుడు మేడం గారు ఆ గళం ఎత్తితే ఆ చిరునవ్వు అలాగే ఉండిపోతుందేమోనండి మీ ముఖంలో. ఐ థింక్ దట్ ఈస్ ద సీక్రెట్ ఆఫ్ యువర్ సక్సెస్ ఏమో సార్. మేడం గారు షీఈస్ అ క్లాసికల్ కర్ణాటిక్ సింగర్ అండి. షీఈస్ గివెన్ వేరియస్ ప్రోగ్రామ్స్. అసలు ధర్మారావు గారి ముఖం మీద చిరునవ్వుకి 3 రోజుల నుంచి జరగపోవటానికి మేమందరం చెట్టుపట్లాడుతున్నా కూడా ఆయన ముఖం మీద చిరునవ్వు తొలగిపోకుండా ఉండటానికి కారణం మేడం గారని
ఇప్పుడు మేము సభాముఖంగా మీ అందరికీ నా కంక్లూషన్స్ చెప్తున్నా అండి. థ్యాంక్ యూ మేడం. Yes, I request Dr. Durga Prasad Garu, Mrs. also onto the stage. Dr. Sailaja Garu.
So this is one of the most memorable event of the conference, where we exchange the medals. The president becomes past president, and president-elect will take over as a president, and incoming president-elect will come as a president-elect of the conference. So we made it a tradition for the past 3 years. So without support at home, so nobody can do anything confidently for the rest of the year. So we made it a mandatory issue that they come with spouses while exchanging the medals. So I request Dharmarao Garu to come onto the front, and also Durga Prasad Garu to come to the front. Dr. Sailaja Garu at the side of Dr. Durga Prasad Garu and Dr. Jay Lakshmi Madam. Yeah. Some music. So I request now our President, Dr. Durga Prasad Garu, to
Requesting Dr. Durga Prasad passing his responsibilities to the other professor, Dharmarao Garu. I must really congratulate Naresh Garu on this innovative program of inviting the better halves on both the sides. Thank you, sir.
So I have some motto also in doing this. We request better halves of the president and past president to at least provide some of your quality time. The association will take some from your family time. Thank you, madam, Dr. Sailaja madam, Dr. Jay Lakshmi Garu, to come and in this occasion to participate in the program. Thank you very much, madam, for your prayer song. We are honored with this. Now this is the time when we announce the results of our medal sessions. So PZ quiz, first on the PZ quiz. The PZ quiz master, Dr. S.S.V. Ramanagar, conducted the PZ quiz. 5 teams contested, and the 5 rounds were organized. Different rounds on basing on the classifications, radiological things, and who is who in orthopedics, something like that. And then the first prize goes to Dr. Mrinalini and Dheeraj from Katuri Medical College. Are they here? Mrinalini and Dheeraj, are they here? They can please come onto the stage and just show your faces. Your certificates will be distributed next year annual conference. You can please come onto the stage and shake hands with our president and president. So second prize goes to M. Anil Kumar and Shoham Rande from Guntur Medical College. Are they around? Shoham and Anil Kumar. Third prize goes to Bhargavi and Sukanya from Narayana Medical College. So you just join. Yeah, sir. Thank you, Mrinalini and Dheeraj and Soham. Thank you very much. Sir, you please. Next, Durga Prasad, the Best Poster Awards. So there are actually 130 posters, nearly 130 posters were submitted, and 70 posters, the presenter is on the side of the posters. Only those were considered for judging for the Best Poster Award. Professor Nageshwar Rao Garu from GSL Medical College acted as a judge, and he is the winner of the Durga Prasad Best Poster Award for 2022 is Kanagrala Shiva Praful. College, I don't know. So the topic is fibula strut graft with PFLC fixation. Yeah, maybe college there. So do anybody know where is he from? Shiva Praful. You also about GSL. Oh, okay. Please come in, Praful. So your poster will be awarded next year. You can just have a picture. So next comes the Dhanvantri Silver Medal. I request Professor Uday Kumar sir to come and present the results of Dhanvantri Silver Medal and how was it conducted. I think 6 papers were selected, 3 were presented, and Dr. Ajit Shinde, Dr. Uday Kumar, Dr. Harnath, and Dr. Karthik Vishwanathan acted as judges. I request Dr. Uday Kumar sir to present.
There were actually 6 papers, but only 3 presented. Out of these 3, the Jovin Joes presented on the Stephanie, Venkat Sai on the ACL reconstruction with the hamstring graft and PL, and Soham Ranade on the RX3 scheme. Basing on the criteria of the research problem, creativity and originality, and research design, and then discussion, conclusions, skills in communicating results, and what there are some guidelines are given. Based on the guidelines, so here, based on the marks given by my colleague judge, Sri Karthik Vishwanathan and myself, we judged the paper on the ACL reconstruction with comparative results of peroneus longus tendon and hamstring graft from R. Venkat Sai Kumar from the MIMS Vijayanagaram.
Congratulations, Venkat Sai Kumar.
Congratulations, Venkat Sai. Please come on to the dais.
The official certificates will be presented next year in the annual conference in Guntur. Thank you, Venkat Sai. Now I request regarding Professor M. Ramohan Rao Best PG Thesis Award, Dr. Narayan Rao Garu to present the results.
There are 5 papers, 5 theses. Myself, Dr. Kalesh Shavali, and Dr. KBS Srinivas were judges. And there was a tough fight between the 2 papers, and we allotted prize to Dr. Sai Soumya from Katuri Medical College for her paper, for her thesis on study on clinical and functional outcome of mini open rotator cuff repair.
Congratulations, Sai Soumya. You can just come and have a picture. So she's from Katuri Medical College, Guntur. Thank you, Sai Soumya. So this makes better argument for having a women wing for our Orthopedic Association. Sir, quiz kuda women. Dhanvantri silver medal, and so the next comes the Vagrous gold medal session for consultants. 7 members contested for the award, and judges were Dr. Guduru Jagadish Garu, Dr. Mallikarjun Swami from Bangalore, Dr. Dakshinamurthy Garu from Guntur, and Purnachandra Rao Garu from Vijayawada. And the topic on spontaneous pyogenic spondylodiscitis in post-COVID-19 patients by Dr. Sai Krishna Gadde got the award. Sai, are you around? So this is from Malika Spine Center, Guntur. So these are the results for the year, and I request all the winners to come to the annual conference next year, so that we will be awarding the physical certificate and medals in person with the chief guest of that particular function. I also request take this opportunity to elaborate on the competition level of award sessions are slightly increasing year on year, but still there is a lot of scope for improvement. The selection criteria is very simple and strict. Everyone needs to apply with a full paper. That's where the selection criteria is different. The papers are being submitted with just abstract of 250 words, and then none of the submitters are submitting the full paper. And the work has to be done from only Andhra Pradesh. These are the only criteria for medal sessions. So I request for the next year, please come out with a lot more papers on this particular subject. So this
one small submission to the committee on the dais. Our scientific session committee has decided to give some additional prizes to the free paper presentations. So with the permission of the chair.
So these are the awards of Prakasham Orthopedic Association.
Yeah, these are from Prakasham Orthopedic Association, mind you. And the first one is the gold medal is to Sri Harsha Bogireddy, is presented on a composite study of humerus intraarticular fractures treated with a parallel plating versus orthogonal plating. You know, we have allotted him the gold medal for this paper from Prakasham Orthopedic Association. If he so he is not written here. If he is here, is he here? Okay. Now we have presented 2 silver medals to 2 free papers. You know, one is Tino Chandesh Kotla. The other one is Dr. P. Krishna Sandeep. The first one is the topic is functional and radiological outcome of closed talus neck fractures managed with ORIF. And second one is valgus osteotomy with DHS in management of malunited intertrochanteric fractures in rural population. You know, so I congratulate both these 2 doctors. If they are here, kindly come out of the dais to accept your medals, please. I think they have left. You know, anyone on their behalf, if you know them, if he is your friend or if or she is your friend, you know, kindly come out of the stage. Okay. I think we have not intimated them prior, sir.
Yeah, sure, sir.
Right, sir.
We'll put it in the newsletter.
So
please pass on the names.
So yeah, bronze medal is for Dr. P. Rupasai, Dr. Krishna Vijay Krishna, and Dr. G. Akila, sir. Study of functional outcome in PIVD. The second topic is reconstruction of ACL with peroneus longus graft. The third free paper was on establishing effectiveness of bone marrow injections as an adjuvant in managing delayed union of long bones, sir. So these 3 doctors have received bronze medals. Yeah, she is here. So 1 medal can be. Yeah, Rupasai, study of functional outcome in prolapsed intervertebral disc. assessing mini open hemilaminectomy and discectomy. I invite our organizing secretary to deliver his speech, please.
Respected President Dr. Dharmarao Garu, dignitaries on the dais, off the dais. Of course, మనందరికీ తెలిసిందే ఈ పాండమిక్ మనందరినీ ఎలా దూరం చేసిందో. డెఫినెట్గా ఈ పాండమిక్ సిచ్యువేషన్ నుంచి మనందరం దానిలో సఫర్ అయిన వాళ్ళు అయితేనేమి, మనం హెల్ప్ చేసిన వాళ్ళు అయితేమి, ఎంతోమంది మెడికల్ ఫెటర్నిటీలో ఉండి ఈ రియల్ పాండమిక్ని ఫేస్ చేసి ఈవేళ ఈ 2 years సెపరేషన్ తర్వాత ఇంత మంచి అకేషన్లో మనం కలవడానికి ముఖ్య కారణం మన వసాప్. వాళ్ళు మనకి ఇచ్చిన ఈ బాధ్యతని మనం వీ హావ్ డన్ ఇట్ ఇన్ ఏ నైస్ వే. Definitely, once again, I thank WhatsApp for giving us to conduct this OSSAPCON 22. Of course, దీనికి వెనక మీరు ఇచ్చిన 2 years బ్యాక్ మాకు ఇవ్వడం ఒక రకంగా కొంత డిలే అయినా కూడాను series of meeting was held regularly, almost with every month interval. We have conducted a lot of series of meetings, which has basically increased the intimacy between our own colleagues, and that is the reason why today we could win this. It's all because of the united work which has been done by our Prakasham Orthopedic Association. Really, I thank all my colleagues of Prakasham Orthopedic Association who have done this wonderful job under the guidance of course, our seniors like KRV Prasad Garu, Vijayaraghav Garu, and Nadana Chandrasekhar Garu, and of course our chairman Malleolus Naidu. So మీ అందరి యొక్క కృషి వల్లనే ఈవేళ ఇంతమంది మనని పొగుడుతున్నారు, సూపర్ జరిగింది, అలా జరిగింది, ఇంత బాగా జరిగిందని చెప్తున్నారంటే ఇట్స్ ఆల్ బికాస్ ఆఫ్ ఓన్లీ ద యూనిటీ వాట్ ప్రకాశం ఆర్థోపెడిక్ అసోసియేషన్ షోన్. ఇప్పుడే మన నరేష్ గారు చెప్పినట్లు ఒక కాన్ఫరెన్స్ లాగా కాకుండా ఒక ఇంటి ఫంక్షన్ లాగా చేసుకున్నారు అని చెప్పారు. సో ఐ థ్యాంక్ వన్స్ అగైన్ OSSAP అండ్ ప్రకాశం ఆర్థోపెడిక్ అసోసియేషన్ కొలీగ్స్ ఫర్ డూయింగ్ దిస్ వండర్ఫుల్ జాబ్. అయితే దీనిలో ఏదన్నా తప్పులు జరుగుంటే లెట్ దట్ బ్లేమ్ గోస్ టు మీ, అండ్ మంచి అంతాను మా ప్రకాశం ఆర్థోపెడిక్ అసోసియేషన్కి పోవాలని కోరుకుంటూ detailed report of this will be mailed to the OSSAP sir. Shortly it will be done. So ilage every year మనం ఇంకా నెక్స్ట్ ఇయర్ కాన్ఫరెన్స్ ఆఫ్ కోర్స్ గుంటూరులో చేస్తున్నారు గోవా తరపున. సో ఐ విష్ దెమ్ గుడ్ లక్ గోవా అసోసియేషన్. దీనికంటే ఎందుకంటే అవి డెఫినెట్లీ బెటర్ సిటీస్ ఇంకా బాగా చేస్తారని, అలాంటి వాటికి డెఫినెట్గా ఎక్కువ క్రౌడ్తో రావాలని, పీజీస్ ఇంకా ఇటువంటి కాన్ఫరెన్స్కి వచ్చి మంచిగా లేటెస్ట్ ట్రెండ్స్ అన్ని సబ్జెక్ట్ నేర్చుకోవాలని కోరుకుంటూ మరొకసారి ధన్యవాదాలు. థ్యాంక్ యూ.
Thanks. You have actually elevated the bar. It's very difficult for Guntur to match and then cross the bar. That has been a big tough task for the upcoming conferences. I take this opportunity to also get the expressions from the participants, members, delegates, whoever wants to express how the meeting was conducted. You are welcome.
Please come out of the dais if you want
they can,
to express.
can give the mic also. No problem. If you want to come, you can come in, sir. Sir, please come.
Sir can come up, sir. Because we have one plan with you also.
I can also come here. Yeah.
అంటే ఒక కాన్ఫరెన్స్ కండక్ట్ చేయాలంటే ఎంత కష్టం అనేది నాకు పర్సనల్గా తెలుసు. 2008లో నేను కాన్ఫరెన్స్ కండక్ట్ చేశాను. అప్పట్లో మా బడ్జెట్ 25 lakhs. దానికే చాలా కష్టపడ్డాము. ఇప్పుడు బడ్జెట్ ఎంతో మరి నేను ఐ థింక్ ఇప్పుడు అడగకూడదు. అంటే ప్రాబ్లం ఏమైందంటే అప్పట్లో మేము కండక్ట్ చేసినప్పుడు ఫార్మా కంపెనీస్ అన్నీ కూడా చాలా కోఆపరేటివ్గా ఉండేవి. తర్వాత అంటే కోఆపరేట్ అంటే వాళ్ళకున్న లిమిటేషన్స్ వాళ్ళకు ఉంటాయి. వాళ్ళు బాగా ఒబ్లైజింగ్గా ఉండేవారు అనమాట. సో మాకు పెద్ద ప్రాబ్లం లేదు. సో తర్వాత ఏదైనా కంపెనీస్, ఎస్టాబ్లిష్డ్ కంపెనీస్ కానీ ఇండస్ట్రీస్ కానీ సపోర్ట్ బాగుంటుంది అనమాట. రాను ఏమైపోయిందంటే ఈ కంపెనీస్ కూడా ఏమైందంటే అంటే గ్రూప్ సపోర్ట్ మానేసి ఇండివిజువల్ సపోర్ట్కి వెళ్ళిపోయారు వాళ్ళందరూ కూడా. ఇప్పుడు ఒక నార్త్ ఆంధ్రాకి సపోర్ట్ చేద్దామా లేకపోతే ఉదయ్ కుమార్ సపోర్ట్ చేద్దామంటే ఉదయ్ కుమార్ చేస్తే బెటర్ అనే స్టేజ్కి వచ్చేసింది. ఎందుకంటే దే ఆర్ గెటర్ మోర్ రిటర్న్స్ వెన్ దే ఆర్ సపోర్టింగ్ ఇండివిజువల్స్. సో దట్ ఈస్ ద చేంజ్ వాట్ హ్యావ్ సీన్ ద లాస్ట్ 40 years యాటిట్యూడ్ ఆఫ్ ది కంపెనీస్ అన్నీ కూడా. సో తర్వాత ఇంకోటి ఏంటంటే అటెండెన్స్ కూడా ఎలా ఉండేదంటే అప్పుడు ఆల్ సీనియర్స్ ఫ్రంట్ రో అంతా బీపీ నరసింహన్ గారు, సికే శర్మ అందరూ అటెండెన్స్ యూజ్ టు బి వెరీ లైవ్లీ అటెండెన్స్ అనమాట. సో యాక్టివ్ డిస్కషన్ మేము పేపర్ ప్రయాణించడం చాలా భయంగా ఉండేది మాకు. బీపీ నరసింహన్ గారు ఏం క్వశ్చన్ అడుగుతారా, లేదా వేద సత్యనారాయణ గారు ఏం అడుగుతారా, ఇంకోటి ఏం అడుగుతారని భయపడుతూ ఉండేవాడు అనమాట. సో అక్కడి నుంచి మనం ఇంతవరకు వచ్చాం. బట్ నెంబర్ బాగా పెరిగింది మనకి. ఇప్పటికి అప్పుడు 8 మెడికల్ కాలేజెస్ ఉంటే ఇప్పుడు ఎన్ని మెడికల్ కాలేజెస్ ఉన్నాయో మీకు తెలిసిన విషయమే. సో నెంబర్ కూడా ఇంక్రీజ్ అయింది. బట్ అటెండెన్స్ ఇంప్రూవ్ అవ్వలేదు. బట్ ఏ కాన్ఫరెన్స్కైనా కూడా ఆర్గనైజ్ సక్సెస్కి ఏంటంటే మెయిన్ కమ్యూనికేషను, తర్వాత సైంటిఫిక్ సెషన్స్, ఆడియో విజువల్స్, ఫుడ్ ఒకటి మెయిన్ ఫుడ్, ఎంటర్టైన్మెంట్. సో ఈ 4 కూడా చాలా ఇంపార్టెంట్ ఆస్పెక్ట్స్. మేము ఇదే బీయింగ్ ఏ పర్సనల్ ఎక్స్పీరియన్స్ చెప్తున్నాను నేను. బట్ ప్రకాశం ఆర్థోపెడిక్ సర్జన్ మేము ముందు చాలా చిన్నది అని ఒంగోలు అని కానీ దే హ్యావ్ డన్ ఎక్స్ట్రాడినరీ వెల్. దే ఆర్ exceeded our expectations. I really wholehearted congratulate ప్రకాశం ఆర్థోపెడిక్ అసోసియేషన్. అంటే సైంటిఫిక్ సెషన్స్ అండ్ ఆడియో విజువల్ చాలా బాగున్నాయి. ఏదో చిన్న ప్రాబ్లమ్స్ ఉంటాయి, స్టార్టింగ్ ప్రాబ్లమ్స్. ఫుడ్ ఈజ్ ఎక్సలెంట్. అంటే నేను మామూలుగా ఫుడ్ ప్రియుడిని. సో అన్నీ కూడా దాంట్లో మొహమాట ఏముండదు. చిన్న ఉప్పు ఎక్కువైన కారం ఎక్కువ కూడా చెప్పేస్తాను మా ఆవిడకి నేను. సో అంచేత ఆ విధంగా ఫుడ్ ఈజ్ ఎక్సలెంట్. అండ్ యూ హ్యావ్ ట్రెడిషనల్ ఫుడ్. సార్ ట్రెడిషన్స్, ఒంగోలు ట్రెడిషన్ రియల్గా ఎంజాయ్ చేసాం. మీ ఊరు కారం కూడా బాగా ఘాటుగా ఉంది, అది కూడా చెప్తున్నాం. తర్వాత ఎంటర్టైన్మెంట్ అనేది బడ్జెట్ మీద లిమిట్ అయి ఉంటుంది. ఎప్పుడు కూడా బడ్జెట్ ఎక్కువ ఉంటే మనం ఎవరైనా తీసుకురావచ్చు. బడ్జెట్తో సరిపోతే మాత్రం కొంచెం ఇబ్బందిగా ఉంటుంది. అయినా కూడా ప్రకాశం ఆర్థోపెడిక్ అసోసియేషన్ బడ్జెట్కి ఆలోచించకుండా ప్రెస్టేజ్గా తీసుకుని 2 days కూడా ఎంటర్టైన్మెంట్ చాలా బాగా కండక్ట్ చేశారు. దాని ప్రత్యేకంగా నేను అభినందన తెలియజేస్తున్నాను. మాలయాద్రి నాయుడు గారికి, జయశేఖర్ గారికి, అందరికీ కూడా. తర్వాత వీరే చౌదరి గారు సార్ మాత్రం ఎక్స్ట్రాడినరీ కంపేరింగ్ చేశారు. ఫస్ట్ డే నుంచి ప్రోగ్రామ్ CME కానివ్వండి, ఫస్ట్ డే సెషన్స్, సెకండ్ డే సెషన్స్ అన్నీ కూడా చాలా బాగా కండక్ట్ చేశారు. మీకు ఒక్కసారి కంగ్రాచులేషన్ సార్. చాలా ఎక్సలెంట్ కండక్ట్ చేశారు సార్. అండ్ ఆల్ ది టీమ్ మెంబర్స్, ఎగ్జిక్యూటివ్ కమిటీ, అంటే ఎవరిని మనం సింగిల్ చేయలేము, ఎందుకంటే అందరూ కూడా కష్టపడ్డారు. ఇప్పుడు జీవన్ బ్యాంక్వెట్కి, తర్వాత మా సందీప్ ఎక్కడేదో సైంటిఫిక్ సెషన్ సందీప్, తర్వాత రిజిస్ట్రేషన్ దగ్గర మన ఇంకెవరు ఐవిరెడ్డి గారు. సో అండ్ దెన్ కాన్ఫరెన్స్కి ఎప్పుడు మీరు గుర్తుపెట్టుకోవాల్సింది ఏంటంటే మన సైంటిఫిక్ నాలెడ్జ్ ఒకటే కాదు, విల్ మేక్ సో మెనీ ఫ్రెండ్స్, వీ మీట్ అవర్ ఫ్రెండ్స్. నేను ఎప్పుడు కాన్ఫరెన్స్కి ఎందుకు వెళ్తానంటే ఫ్రెండ్స్ని కలవడానికి, కొత్త ఫ్రెండ్స్. ఐ వాంట్ టు మేక్ మోర్ అండ్ మోర్ ఫ్రెండ్స్. సో ఈవేళ నాకు 2-3 ఫ్రెండ్స్, కొత్త ఫ్రెండ్స్ తగ్గారు. కార్తీక్ ఒక ఫ్రెండ్, తర్వాత ఇంకా ఐ కుడ్ మీట్ సమ్ అజిత్ సన్ మీట్ అయ్యాను. సరే యూ గెట్ దట్ ఇస్ సోషలైజేషన్. సో మీరు ఎప్పుడు కాన్ఫరెన్స్ అండ్ ఎంటర్టైన్మెంట్ ద స్టాల్స్ లేదా అది అనుకోకండి. ఇట్స్ ఏ కంబైన్డ్. అసలు యూ గెయిన్ ఏ లాట్ ఆఫ్ థింగ్స్ డైరెక్ట్ ఆర్ ఇండైరెక్ట్లీ. సో కాన్ఫరెన్స్ మిస్ అవ్వకండి. మీరు అందరూ పీసీస్ అందరూ కూడా ఇంకా లార్జ్ నెంబర్స్లో రండి. అందరూ కూడా OSSAP మెంబర్స్ అవ్వండి. ఆల్ కన్సల్టెంట్స్ అందరూ కూడా OSSAP స్ట్రెంత్ ఇంక్రీజ్ చేయండి. సో వసాప్ అంటే ఒక్కరి సొత్తు కాదు, అందరిది, మన అందరిది. OSSAPCON అంటే ఒంగోలు ఫంక్షన్ కాదు, అందరి ఫంక్షన్ ఇది. సో అది అలాగ మన ఫంక్షన్. అదే ఇప్పుడు చెప్తున్న నరేష్ గారు చెప్పారు కదా, మన ఇంట్లో ఫంక్షన్లా చేశారని. సో డెఫినెట్గా ఇంటి పండగలా జరిగింది. ఈ పండగ ఇలాగే ఇక ముందు కూడా జరగాలని మనస్ఫూర్తిగా కోరుకుంటాను. థ్యాంక్ యూ ఫర్ ద ఆపర్చునిటీ. థ్యాంక్ యూ సో మచ్.
So, good afternoon, everyone. I am Dr. Paparao. Bejawada, my inti peru. I practice in Bejawada and settled in Bejawada. Kani nadi Ongol. So I am a native of Ongol. I am proud to tell you that Prakasam Orthopedic Association has conducted this conference in a wonderful way. Uday Kumar sir ippudaka prati event prati amsamo clear ga cheppesaru ఎవరెవరు ఎలా చేస్తున్నారు. ఒక మాటలో కాన్ఫరెన్స్ ఎలా చేయాలో కూడా మొత్తం చెప్పేశారు మీరు. At this point of time, I would like to thank Prakasam Orthopedic Association for inviting me and giving me an opportunity to conduct arthroscopy workshop and arthroscopy session in this conference. And I'm also proud to say that yesterday when arthroscopy session was going on, a lot of people told me that more number of delegates were there in arthroscopy hall when compared to hall A. Usually arthroscopy lo 2 days kin divide chesi oka 1 hour second day, 1 hour third day conference arthroscopy meetings ayyetappudu ippudu daaka nenu last 5-6 years nunchi chustunnanu speakers tappa evaru unnatla. But this time I am very happy. They clubbed both workshop, shoulder arthroscopy, knee arthroscopy lectures on the same day. Adi kuda ek advantage. Next Guntur వాళ్ళు కూడా సేమ్ ఇదే పని చేస్తారని నేను అనుకుంటున్నాను. I request OSSAP secretary and Goa to do the same thing, not to split arthroscopy on 2 different days. So thanks everyone. Thank you Prakasam Orthopedic Association once again for giving me this opportunity. And I also have a small personal request. I want to become a member of Prakasam Orthopedic Association. Thank you.
Anyone else? I would like even to take opinion of my junior friends, from postgraduates or junior consultants. Please do come over, and we would like to have your feedback because that's going to make us better. So I'll be coming down there. So one of my friend will be coming down there. Please, you have to say at least 1 or 2 words about us, Otherwise, all our efforts will go waste. All our, banquet effects will go waste, I saw you all guys, running havoc and creating havoc there, And I think you must have enjoyed with all the Jabardast lady boys. Yes. Yeah. Before that, one of the members is here for the silver medal of Prakasam Orthopedic Association. Dr. Tino Chandesh Kotla, functional and radiological outcome of closed talus neck fractures managed with open reduction and internal fixation. He is from Narayana Medical College, Nellore. Okay. I think if no one wants to volunteer from the audience, about our feedbacks regarding the program, where we have to improve, where we have done good, where we have gone wrong, where we have hurted you. So then now I invite upon the president of OSAP 2022-23 to come and give his message to the orthopedicians, the young orthopedicians.
Respected friends and colleagues and esteemed dignitaries on the dais and of the dais, and respected President and Secretary of the OSAP and Organizing Secretary and Organizing Chairman, Dr. Malleolus Naidu and Dr. Jaishankar and Prakasham Orthopedic Association team. This is really an auspicious occasion as we are conducting along with you, Dr. Malleolus Naidu, Dr. Jaishankar and Prakasham Orthopedic Association. The entire team organizing and conducting successfully the memorable and enlightened Silver Jubilee Conference, OSSAPCON 22. First of all, on this auspicious event, my hearty humble pranamams to my parents and teachers and God Almighty for showering their benevolent blessings on me. My wholehearted namaskarams and thanks to you all, my seniors, friends, and to all my orthopedic fraternity for electing me and for giving me the opportunity of OSAP President for the year 2022 and 23. I congratulate wholeheartedly Dr. Y.V.K. Durga Prasad Garu, who completed his tenure successfully with the help of our dynamic secretary, J. Naresh Babu, and all other respected EC members, and with all your cooperation. Today, they placed our organization, OSAP, at one of the top prestigious positions in the country and won the bronze medal. I will wholeheartedly congratulate the President Durga Prasad Garu and Naresh Secretary. I will try to maintain and carry forward your success and achievements. And I will try my level best to uplift the dignity and decorum of our OSAP in all aspects with respect to all your ideas and suggestions, as you all our enlightened brothers of orthopedic fraternity. It is our teamwork with a spirit of unity and understanding to improve our OSAP in all aspects, like membership drive, as members, the strength of our association. And I will try to increase so much further. And planning and for training of our junior colleagues, as we are already doing, like fellowships, if possible, still to the national and international levels. Continuous training of the PG students with top-class teachers, as our respected elder brother and teacher, Dr. Uday Kumar Garu, is already doing as a North Andhra orthopedic PG teaching program. Training of the students with the basic operative skills in trauma and subspecialties. Encouraging and activating all the district level associations in all districts and major towns, if possible, for academic excellence, already happening in some districts, as in Ongole by Prakasham Orthopedic Association, like this. Incentives and awards to district branches which are already active in the form of prizes and with OSAP fundraising activity wherever possible. And we'll try to improve and implement the benevolent fund scheme with all your help and with the help of our secretary and executive team. Best Young Orthopedic Surgeons Award for Expert Excellence as a token of encouragement we are going to plan. Activating the legal forum as we already starting to useful level to the entire state by dedicated orthopedic legal experts in our fraternity. We are along with you and our team. It is my proposal, 24/7 expert advice academic platform to all our younger brothers, younger orthopedic surgeons as in an academic by academic excellent orthopedic dedicated brothers who are willing to serve to all our junior colleagues by clearing doubts. I will try to seek for good ideas, suggestions from all of you from time to time, as you are all most of the innovative and constructive brains. Once again, thank you all wholeheartedly for giving me this chance in spite of so many seniors and enlightened elder brothers and orthopedic surgeons amongst us by electing me unanimously without competitive prejudices and conflicts, and proved our unity, created a friendly and fraternal atmosphere amongst us. Successfully, we elected Dr. V.V. Narayan Rao as President-elect in the same way. All this indicate my wholehearted congratulations to Dr. V.V. Narayan Rao as he was elected unanimously as President-elect. Let us maintain the same unity and same tempo in future and in coming years with harmonious understanding. My heartfelt congratulations to the new elected EC team, along with our invincible secretary, Dr. J. Naresh Babu, as Joint Secretary, Dr. Mopat Srinivas, Treasurer, Dr. Amarnath Reddy, and respected EC members, Dr. M. Ganesh Kumar Reddy, Dr. B. Leela Prasad, Dr. G. Raghunandan, Dr. K. Sudhakar, Dr. Abhishek Reddy. Let all of us work together to uplift our further to farther heights. Dr. Malayadri Naidu and Jai Sekhar once again, and the Prakash Orthopedic Association, my wholehearted congratulations to them here, conducting Silver Jubilee Conference successfully and excellent with eminent faculties of versatile wisdom, good hospitality. Once again, I congratulate them and my wholehearted thanks to you all, sir. Finally, let us go together as one ortho fraternity. Let all prejudices and conflicts and differences among us be gone. Let cooperation and love prevail. Let us uplift our OSSAP to the standards of national and international levels with a spirit of togetherness and unity as one team. Let all of us enjoy and share together. Thank you all.
Thank you, sir. I invite our President-elect to say a few words about his views.
Good afternoon, everybody. నా మీద ఇంత ప్రేమాభిమానాలు చూపించి నన్ను ప్రెసిడెంట్-ఎలెక్ట్గా ఎన్నుకున్న ప్రతి ఒక్క OSSAP మెంబర్కి నేను ధన్యవాదాలు తెలుపుకుంటున్నాను. నిజంగా ఇది నేను డిజర్వ్ కాదో తెలియదు. దీనికి కారణమైన సునంద్ కుమార్ రెడ్డి, అచ్యుత్ ప్రసాద్ గారికి మరొక్కసారి నా మనఃపూర్వక కృతజ్ఞతలు తెలుపుకుంటున్నాను. నా ముందు ఎంతోమంది పెద్దలు ఈ చైర్కి గౌరవాన్ని తెచ్చారు. ఆ గౌరవాన్ని కాపాడటానికి నేను ప్రతి నిమిషము శ్రమిస్తానని మీ అందరి ముఖంగా చెప్పుకుంటున్నాను. అట్లాగే ధర్మారావు గారు తనకి ఈ 1 year నేను పక్క నుండి సహకారం అందిస్తానని, ఇంకా బాగా మన OSSAPని వృద్ధిలోకి తీసుకురావడానికి పెద్దలందరి సలహాలు తీసుకుంటూ, ఇంకా మనము మన ఇండియాలోని IOAతోనే మనం కాంపీట్ చేయాలని కోరుకుంటున్నాను. అండ్ గుంటూరు ఆర్థోపెడిక్ అసోసియేషన్ తరఫున నెక్స్ట్ ఇయర్ గుంటూరులో జరిగే కాన్ఫరెన్స్కి మిమ్మల్ని అందరినీ మనఃపూర్వకంగా ఆహ్వానిస్తున్నాను. థ్యాంక్ యూ వెరీ మచ్.
Thank you, sir. now I invite all the members of Prakasam Orthopedic Association to come over to the dais, please. Okay. Meanwhile, you continue. But let me call all of my friends, sign. Please come, Anna. Amarnath sir, Dr. Kamal Hassan, Dr. Shrikant, Dr. Vamsi Krishna, Dr. Sriman Narayana, Dr. I.V. Reddy, Dr. Umapati Venkateswalu, Dr. Chavala Prakash, Dr. Ravindranath Reddy, the financial wizard, Dr. Jeevan, the sportsman. He's coincidentally, he's also president of Lady Football. What is it? Lady Football. For the state lady woman football team president of Andhra Pradesh, and Dr. Madhukaran Reddy Garu, Dr. Abdul Kalam, and myself, Dr. Veeray Chaudhary. Care, Dr. Sir, Raren sir, Mire first lo undali. Sir, Miru తీసుకెళ్ళబాకండి సార్, మాకుండే ఏకైక జెమ్ ఆయన. మీ జెమ్స్ కు తీసుకెళ్ళిపోబాకండి. And Sir Vijay Raghav sir. So he wants to see us all from the from there. And
sir, meanwhile we have a few comments to be passed regarding conference. A few people are here to talk while we rearrange ourselves.
Chappan.
Sir, I am Dr. Rajshekhar Reddy from Guntur. Conference was OSSAP Conference 2022 organized by Prakasam Orthopedic Association was excellent and beyond words. You people have done excellent work and justice for OSSAPCON, which was conducted in physical presence after 2 years. So we are all very much delighted, all the members of OSSAP who have attended, all the consultants or all the PGs. We had a good take-home knowledge and message from OSSAP. And we really wholeheartedly thank you, Prakasam Orthopedic Association.
Thank you, sir. Anyone else? Yes. The most awaited. We were the lady representative of the day,
Good evening, sir. I'm Dr. Parinita and I'm from Hyderabad, NIMS Hyderabad. So this is my first conference, sir. After COVID, to attend a live conference. And I had a very good experience all these 3 days. And I had a very good support from all the OSSAP team. And special thanks to Jeevan sir for helping me in all the ways. And thank you so much, sir. The food is wonderful here. And we really had a great time, sir. Thank you. Thank you.
Thank you, ma'am, for your kind words. Before I propose vote of thanks, I would like the technical committee to show a short clipping about the OSSAPCON 2022 conference. We have just made a. Yeah, please play that small clipping, video clipping.
Waking up, what's up?
Is that all? Right, thank you. Yeah, vote of the, it's my honor and privilege to propose vote of thanks. And I thank OSSAP State Committee, the past President Durga Prasad sir, the present President Dr. Dharma Rao Garu, and the President-elect Dr. V.V. Narayan Rao Garu. And I also thank our beloved General Secretary of OSSAP, Dr. Naresh J. Babu Garu, on this occasion. And I sincerely thank all the chairpersons who have added during our academic sessions. And I should really thank all the speakers for their enthusiasm to come over to our place and then deliver their lectures. And I should thank all the organizing committee members, all my friends who have done excellent job, day and night they have worked for this, they have taken it as a personal challenge and they have risen up to the situation as we expected. Thank you, doctors. And finally, I thank the venue owner of A1 Convention for having provided us such a beautiful venue. And especially I must congratulate the technical team who has done excellent job. They have supported us every time, everywhere they have supported us right from day one. Right from day one, they have supported me, especially being in Hall A. They have supported me terribly. Yeah, Mr. Bashir, Madan Garu, and all his team members, they have done excellent job. They have not left their places. Generally they just drop off and go, but I have not seen them moving their chairs. They have done excellently. They have just given me the best guard. In fact, thank you, technical team. And finally, I must thank all the pharma companies who have participated in this conference. And I must also thank the watchmen, in fact, all the people, the employees of this convention hall who have done and kept this hall very neatly. And I should, yes, I don't want to forget the photographers who have captured the memories for the conference. And he's waving his hands to me, so that I don't forget him. I thank you, photographers, for the excellent job you have done. And thank you, one and all. Let's carry these memories for at least a year. And thanks again for coming down to Ongole, sir. I thank all the guests. I thank all the postgraduates, who have excellently shown their enthusiasm in participating in all the scientific sessions. And most of the times we have never seen a single chair empty during this time of 2-3 days. Thank you all. Let's meet again in Guntur for the same conference, OSSAPCON 52nd conference.
Thanks. Go home safe for our safe travel back. Sir, తెలుసా
మెడికల్ సార్ మీరు జీవితం మా ఫోటో
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Rana, photo